a very good afternoon. So I hope and I believe all of you are doing well. So INI-CET November 25 is done finally. And I hope all of you have given your best shot and you are satisfied with the attempt that you have given. Irrespective of how the exam has been, remember it is done and dusted, right? It cannot be changed, whatever answers you have marked or however the paper has been. So just take a chill pill and relax. And this recall session is not meant, to point at your mistakes or something. It's just to learn out of it, because remember, every exam helps us learn, how is the trend changing? What are the types of questions and topics that are being asked in the exams? So this is not just for the students who have given the exam. This is also for the future aspirants who are going to give any exam in future, be it FMG, NEET PG, or the next INI-CET as well, right? So to understand it firsthand, what kind of questions were asked, the general review that I've got regarding the today's INI-CET exam is it was moderate. May was comparatively easier as compared to this exam, right? And pharmacology was the one which was the toughest. A lot of difficult questions. In pharmacology, that's what majority students said. And the questions itself were on the difficult side, not just like the options which were difficult, but majority students said कि questions could be difficult the. But I think every exam has mixed reviews. It finally depends on the level of preparation of every student, whether you had read what has been asked in the exam, right? So uh, it's all going to be results which will speak about it. So let's start discussing the radiology questions. Radiology questions, per se, if you ask me, were very much doable and the commonly asked topics, and they were clinical integrated type of questions. So just based on the history itself in the question that was given, the questions could be solved. Majority questions could be solved based on that as well, right? So that is how we are seeing the radiology questions being changing. You are in final year MBBS, and should you attend this discussion? Of course, if it is Sunday and you are not doing anything, so this is going to be very productive thing that you would do on a Sunday, right? So you can at least know that if I would have given the exam, how much of this do I actually know? Okay. All right. Uh, let's start discussing everyone. Okay, some of you say that there were less questions from pre and paraclinical subjects, which is generally unusual for INI-CET. But remember, there's no clear demarcation in the questions that are asked in our exams, because everything right from physio to pharmac to patho to medicine is integrated, right? So, all right, let's start. The first question that we have here, the history is very important, which will help you make a diagnosis. So, a 14-year-old boy, there's pain and swelling over the right humerus, right? There's a typing mistake there. So, humerus hai, fir fever hai, raised ESR is there. So, look at the major points, the clues that have been given. It's a 14-year-old, right? A 14-year-old with pain, swelling, fever, raised ESR, right? So which of the following will be the best test or the next best step that would be done in this case? Okay. So now, depending on, what exactly was the question? Was the question, what is the next best step? Or was the question, you want to confirm the diagnosis? So if the question, yes. So biopsy has also been added here in the options. There are two options which are confusing here. Remember that in a bone lesion evaluation, before we do biopsy for the lesion, the detailed radiological evaluation is very important. If it's a do not touch lesion, which is like straightforward diagnosis and you don't want to do anything, then only X-ray is enough. But if there's a bone tumor like this and you are seeing on the radiograph, there is this moth-eaten permeative lesion involving the diaphysis of the bone, which fits with the clinical history. This fits into Ewing sarcoma. So before doing biopsy or doing surgery, the radiological evaluation has to be complete, which includes the X-ray and the MRI. Okay, which includes X-ray and MRI. So if the question was, okay, so if the question is not the best test to confirm the diagnosis, the question was the next step. What is the next investigation that you would do? Then the answer in that case would be MRI. because you want to see in the bone lesion which is there, how much is the extent, local extent, are there any skip lesions, is the neurovascular bundle involved, if I have to take a biopsy, what track should I take so that we do not injure the neurovascular bundle. So all of that we need to evaluate, and x-ray will not help us look at those neurovascular bundles and the soft tissue extension. So that is why MRI is going to be there. So remember, the next step is going to be MRI. And after that, we will do biopsy, which will confirm the diagnosis. In Ewing's, you will see the small round blue cells, right? So the next step, if was asked, then the answer would be MRI in that case. Okay. Going on to the next one. Again, this is a question where the history is very important and it helps you make a diagnosis. A 28-year-old man with involuntary jerky movements, personality changes is there, forgetfulness is there. So based on the history, you can make a diagnosis. The coriform movements is also given. So you know that chorea, right? Chorea, C for chorea caudate atrophy is what we see in Huntington's chorea, Huntington's disease. And remember the 3 M's in the clinical manifestation of Huntington's: memory, mood, and movement, right? Memory is gone. There's early onset dementia, mood, irritability is there, and then there is movement abnormality, chorea is there. So the answer is going to be Huntington's disease here. Options may, one option Narayan says was tardive dyskinesia. Okay. It's not possible to give a USG image for the brain, right? It should be MRI. Tardive dyskinesia. Okay. So one of the option, which option was not there then if there was tardive dyskinesia? Okay, Wilson's was not there. And I'll put this as tardive dyskinesia, which was there. Right. So this is going to be Huntington's, where you see in Huntington's, what happens basically is the caudate gets atrophied and there might be some putaminal loss as well. And because of that, there is frontal horn dilatation, which you see here. Okay, so there is this loss of the putamen. Putamen is normally not so small. Caudate is also bigger with some hyper intensity. So that is going to be Huntington's. Okay, so some of you also say that the other option was the Tourette syndrome. So I'll add that. Which option was not there? Okay, all right. So the answer here is Huntington's. Going to the next one, again, the clinical history, which is very, very important. Smoker, drooping of the right eyelid, constricted pupils, so ptosis, meiosis, and enhydrosis is given. So you've made a diagnosis. This is going to be Horner's. Along with that, there's shoulder pain, tingling sensation, and the chest x-ray is given. So even before looking at the chest x-ray, based on the history, there is Horner's, tingling, numbness, you have made a diagnosis of Pancoast tumor, right? Pancoast, the apex tumor, the apical tumor, superior sulcus tumor, you can see which is here, invades the brachial plexus, sympathetic trunk, and that is why upper limb symptoms and Horner's is there. So the diagnosis is Pancoast. What I want is, what were the options exactly given in this question? Were the options the same, which is the best investigation to confirm the diagnosis? This wasn't the question some of you are saying. What was the option here? I'm sorry. Okay. CT guided biopsy was one of the options. Okay. CT guided biopsy, if there, you can go for CT guided biopsy. For the confirming the diagnosis, remember, gold standard to confirm any lesion is going to be biopsy. If you want to see the brachial plexus invasion, then you will go for the MRI. Okay. Okay. One option was NCV. MRI was not an option, so that is out, right? So that removes the confusion. So the answer is going to be CT guided biopsy. Other options were USG, NCV, and sputum microscopy. Okay. Okay, so these were the options which were given. I'll remove these options. So CT guided biopsy, USG, NCV, or sputum microscopy. So to confirm the diagnosis in any lesion, it's going to be biopsy. For lung lesions, we do CT guided biopsy. Nerve conduction studies, right? The NCV. Okay, going on to the next one, favorite for any exam, shortness of breath. And this is the CT given with the black area. Black is the air, pneumothorax. So there is emergency symptoms which are there. Shortness of breath is there. This is bilateral pneumothorax that we are doing. So the first thing that we will do here is needle thoracostomy, right? So the needle puncture for the pneumothorax is what we are going to do here. Going to the next one, there was a patient with 3-month history of cough, productive. There was hemoptysis as well. So again, the history is important here. Were the options the same options there? Yes, are the options correct? Whether it's a lung abscess, it's a pulmonary tuberculosis, it's a metastatic carcinoma, or is it bronchiectasis? Okay, so depending on the history, which is given here, right? And even the image, this is going to be pulmonary tuberculosis, right? This is going to be chronic cough history with 1 episode of hemoptysis, right? And look at the image here. There are these opacities in the right upper lobe that you are seeing there. So the right upper lobe, the apical area is commonly involved. So this is going to be pulmonary tuberculosis. Okay, this is going to be pulmonary tuberculosis. Bronchiectasis predominantly is in the lower lobe, elderly patient, right? Hemoptysis बहुत commonly होता है. Metastatic carcinoma, there are generally going to be multiple lesions. Lung abscess is going to have air fluid level, right, which you are not seeing here. So ruling out the options also, you come to pulmonary tuberculosis. Okay. Pneumonia will not have a chronic 3-month history if you look at it clinically, right? There's going to be more likely high grade fever that's going to be mentioned in the question, right? So then in that case, pneumonia will have more acute history, okay, with high grade fever. Okay, was this question also there? Identify the mark structure in the below CT image. Is it external auditory meatus, internal auditory meatus, carotid canal, or it is vestibular aqueduct? And is the arrow marked correctly here? Right. If this is where the arrow was marked, then in that case, this arrow which you are seeing here, this structure, this area that you are seeing here, this is the carotid canal. Okay, this is where the internal carotid artery goes. This is the carotid canal. If the arrow would have been here, this black area, air containing, this is the external auditory canal, okay, that contains the air. If the arrow was here, this is the vestibular aqueduct wala area. And this area which you are seeing here going to the cochlea, the 7th, 8th nerve will go here. This is going to be internal auditory meatus. Okay. So depending on where the arrow was, that's why I've given, I'm showing you all the images for all the 4 options. Agar arrow yahan pe tha, where it is ending into the cochlea, then it is internal auditory meatus. If it is behind that, then it is your vestibular aqueduct. Okay. And the black area, this is the external auditory canal, and this area here, this is the carotid canal. Okay. This is the carotid canal. Okay. If it was ending in cochlea, if you could see that, ठीक है, ऐसा कुछ था कि cochlea वाले में जो end कर रहा है, then it will be internal auditory meatus. Okay, so if either of this was there, just check whether it is ending into the cochlea, then internal auditory meatus. If not, if still behind that, then that's a vestibular aqueduct. Okay, so then it is internal auditory meatus that was asked, if majority of you are saying that, right? Okay, then there was this one question on shoulder dislocation as well. Yes, whether it is anterior shoulder dislocation, posterior, inferior, acromioclavicular. I think abduction and external rotation was mentioned in the question. Abduction and external rotation was mentioned in the question, right? So what is this? This is the anterior dislocation of the shoulder that you are seeing here. anterior dislocation of the shoulder that you are seeing. If it was inferior dislocation, the arm is very much abducted. It's like the hand touching the head. You will not see the humerus, which is parallel to the scapula that you would see here. Okay, so ऐसा long नहीं दिखेगा. The humerus is going to be much higher up, abducted. Okay, in posterior dislocation, there is light bulb sign. The overlap between the humerus and the glenoid is gone. So this is going to be anterior dislocation of shoulder that you are seeing here. The head is more medial. Okay. Okay. And also you are saying the foosh, the fall on outstretched hand was already mentioned. So that kind of injury leads to anterior dislocation commonly. Okay. That was anterior dislocation. All right. So those were the questions in radiology that we had. Radiology per se, if you ask me, was very much doable, even if you have not done per se radiology images. But the clinical history integration helps you answer a lot of questions, right? So that's very, very important. And like I said, overall, the paper seems to be moderate. And but irrespective of that, you always see that the cutoffs being high, because even the preparation level of the students is also increasing with every year, right? So that was great. Do let me know if there are any changes. 2 questions were not matching. Which questions are not matching? If options are not matching, please let us know so that we can modify it accordingly and put up the refined questions in the app for your final review as well. Okay. How to handle these kind of exam questions, not radio, but some questions. See, every exam is going to have some questions which are very eccentric, very weird, right? Alien questions which are going to be there. So, uska zyada tension nahi lena. It's absolutely fine, right? You are never going to know all 200 questions in any exam. So that's absolutely fine. Okay. Internal and auditory canal, majority of you are saying, so we'll go for that. Okay. Right. All right, guys. So thank you so much for joining in for this. Please keep giving the inputs for the same. And, we shall have the next subject coming up for your recall. Not taking much of your time. Please to let me know. Just give me a minute. Okay, there was no hemoptysis in question 3. It all depends, these are all recall based, memory based questions. So, we will definitely look into the majority inputs that we get and modify accordingly. FMG candidates can watch this, absolutely, right? Because there's a lot of overlap between INI-CET and FMG questions as well. And okay. So thank you so much, everyone. Stay tuned for the next subject for recall, and all the very best for your results. Do not get distressed looking at the recalls and realizing, I've done so many mistakes. It's absolutely fine. Everybody does that, right? Just take a chill pill, relax, and best wishes and blessings for the results. Thank you so much.
Okay. Hi everyone. Hi guys. I hope your exam went well. But many students are saying that exam was at a tougher level, especially pharma. So it is the legacy of, I think, INI-CET. They always make tougher exam in pharma. But don't worry. Let's analyze what we have recalled. And there is an immense gratitude to the students who have helped us in recalling all the questions. So, whatever the recall or memory based recall we got is the first question. I think I need all of your help. That which of the following statement regarding dronabinol is correct? I think this was the correct question which was given. Yeah, agreed. So, beta, we discussed dronabinol. NABI word is coming. NABI means it is a cannabinoid. Agreed. We all already discussed cannabinoid because cannabinoid also have NABI word in it. And the two uses of dronabinol which we discussed was that it was given for uh, first chemotherapy induced nausea and vomiting. And we know that if a person takes cannabinoid, bhang, charas, ganja, appetite increase hoti hai. Appetite increase means it is given to promote weight gain. So it is also given for the treatment of weight loss. If a person is having weight loss or cachexia, it is approved. Only these are the two approved condition for dronabinol. Okay, so some student are saying except पूछा गया था. That's great. This is what I need a help from all of you student. Except पूछा गया था. So beta, it is given. Yes, it is approved for AIDS associated weight loss. Yes, it acts on cannabinoid receptor. CB1 receptor को stimulate करता है. It is CB1 agonist. It is also a true statement. Now it is excreted unchanged in urine. My question from you all student is, क्या option C दिया गया था? Was option C was asked? It is excreted unchanged in urine. Was this option was given? Because we know that cannabinoid they enter into our brain. है ना? Cannabinoid brain में जाते हैं. My question from all you student, if it is entering into the brain, it should be lipid soluble drug. इट शुड बी लिपिड सॉल्युबल ड्रग क्योंकि ब्रेन में जा रहा है. डू यू थिंक लिपिड सॉल्युबल ड्रग अनचेंज्ड फॉर्म में यूरिन में निकलेंगे? नो. फर्स्ट दे गो टू द लिवर, दे गेट मेटाबोलाइज इनटू वाटर सॉल्युबल फॉर्म, and that is why they are excreted into the urine in unchanged form. So a very logical explanation. Now is it given for pain relief? Now the point out here is option D correct? क्या ऑप्शन डी दिया गया था बेटा? क्या ऑप्शन डी दिया गया था? Okay, now remember it is not approved for pain relief. It is not approved for pain relief also. It is off label use. Off label matlab approved nahi hai. And sometimes it can be given for neuropathic pain. दे सकते हो neuropathic pain में, पर ये approved नहीं है. Approved सिर्फ दो ही जगह है, nausea vomiting में और cachexia में. Agreed? So yes, CB1 दिया हुआ था. So option C and D are false. Now the point I was wanted to ask, अगर इन दोनों में से आपको एक ऑप्शन चूज करना है, आई जस्ट वांटेड टू आस्क, क्या अप्रूव्ड वर्ड लिखा हुआ था? क्या अप्रूव्ड वर्ड लिखा हुआ था? ओके, तो सारे के सारे इनकरेक्ट थे. सो रिमेंबर ऑप्शन ए और बी इसमें करेक्ट है. एग्रीड? ऑप्शन ए एंड बी आर करेक्ट. ऑप्शन सी बिल्कुल इनकरेक्ट है, मेनली इनकरेक्ट. ऑप्शन डी को हम करेक्ट बोल सकते हैं, बट ये अप्रूव्ड नहीं है, देते हैं न्यूरोपैथिक पेन में. ओके ओके, यूज लिखा था. अगर यूज्ड वर्ड लिखा है तो मतलब इसको हम यूज कर सकते हैं. इन दैट केस ऑप्शन डी जो होगा ये भी ट्रू हो जाएगा. ओके अगर अप्रूव्ड वर्ड नहीं है, यूज्ड वर्ड लिखा है, तब ये ट्रू हो जाएगा. देन द आंसर फॉर दिस क्वेश्चन कम्स आउट टू बी सी. सी इज द फॉल्स स्टेटमेंट. ठीक है, लाइपोफिलिक है. चलो नेक्स्ट क्वेश्चन. Which of the following is not a property of rifampicin? I think this question was given. So I just want a little bit help from all you student. क्या option D किसी को याद है? So first option was it was given with fatty food. False. Remember rifampicin को हम empty stomach देते हैं. सारे ATTs को हम empty stomach ही देते हैं ताकि absorption increase हो जाए. Agreed? So first is false. It should not be given with fatty meals. It should be given empty stomach. सेकेंड है, इट अंडरगोज एंट्रोहेपेटिक सर्कुलेशन, लिवर से निकलता है। यस, ये लिवर से निकलता है, तभी क्या होता है इससे, हमने पढ़ा है हेपाटोटॉक्सिक है। सो दिस इज अ ट्रू स्टेटमेंट। ठीक है। एंड वी वेरी वेल डिस्कस्ड रिफेम्पिसिन पी ग्लाइकोप्रोटीन में, हमने एल आर आर सब में पढ़ा है। सो यस, ये पी ग्लाइकोप्रोटीन का भी सबस्ट्रेट है। एग्रीड। रेजिस्टेंस इज ड्यू टू आरपीओ बी जीन, ये भी बिल्कुल ट्रू स्टेटमेंट हो गया। ओह, जस्ट अ सेकेंड, व्हाट हैपेंड, जस्ट अ सेकेंड, जस्ट गिव मी 1 सेकेंड बेटा। Just give me 1 second. So yes, resistance to RPOB gene is the correct answer. That leads to yes, you are absolutely right. Resistance to rifampicin, RNA polymerase को इनहिबिट करता है, तो RPOB gene हमने ट्रिक भी बना, so that's fine. Okay, that's fine. Just a moment. Yeah. So here we were. So resistance is due to RPOB gene. बिल्कुल ठीक बात है. Due to RPO RNA polymerase B gene. So remember, ऑप्शन नंबर बी भी ट्रू है, सी भी ट्रू है, और डी भी ट्रू है। तो द फॉल्स स्टेटमेंट आउट कम्स आउट टू बी ए इज फॉल्स। यस, ठीक है। तो इसमें हमें फॉल्स ही बताना था। ठीक है, मतलब समथिंग गिवन टू, वो था ना बेटा, लिवर एंट्रोहेपेटिक है ना, तो ए इज फॉल्स। लेट्स कम टू द नेक्स्ट क्वेश्चन। विच ऑफ द फॉलोइंग ड्रग एक्ट्स बाय इनहिबिटिंग वीईजीएफ, वेस्कुलर एंडोथेलियल ग्रोथ फैक्टर, है ना। सो हमने पढ़ा था बेवफा रानी, है ना, 2 ड्रग्स पढ़े थे। तो बी से था बेटा आपका बिवाकीजुमैब, कैंसर में देते हैं, और इंट्राविट्रियल आइस में इंजेक्शन देते हैं टू प्रिवेंट एज रिलेटेड मैक्युलर डिजनरेशन या डायबिटिक रेटिनोपैथी। नेक्स्ट ड्रग जो हॉस्पिटल्स में मिलता है दैट इज रैनीबीजुमैब, रैनीबीजुमैब। ठीक है। सो वीईजीएफ इनहिबिट, ठीक है। सो द आंसर कम्स आउट टू बी रैनीबीजुमैब। ठीक है, वीईजीएफ वेस्कुलर एंडोथेलियल ग्रोथ फैक्टर, जिससे ब्लड वेसल नहीं बनेगी, एंजियोजेनेसिस को इनहिबिट करेगा। एंजियोजेनेसिस कैंसर में देखी जाती है, हॉलमार्क ऑफ कैंसर। डायबिटिक रेटिनोपैथी में भी नियोवैस्कुलराइजेशन। ओके, रैनी रामुकिरुमैब दिया हुआ था, तो वो भी ठीक है आंसर बेटा, ये भी ठीक है। रामुकिरुमैब दिया है तो ये भी ठीक है। ये एक नया ड्रग है, बट हमने आरआर में लिस्ट में लिखा हुआ है ये ड्रग। तो इट इज फर्स्ट टाइम आस्क रामू की रूम मैप, इससे पहले कभी नहीं पूछा गया, बट वी हैव रिटन आउट देयर। तो पेम्ब्रोलिजुमैब हमने पढ़ा, इम्यून चेक पॉइंट इनिबिटर है, ये तो सारे पहले 3 ड्रग है ना, ये तो सारे इम्यून चेक पॉइंट इनिबिटर थे जो कैंसर में देते थे। इम्यूनिटी इंक्रीज होती थी और कैंसर किल हो जाता था। सो यस, द आंसर इज डी। दोनों में से बेटा जो ऑप्शन है, दिस इज द ट्रू आंसर। ठीक है। लेट्स कम टू द नेक्स्ट क्वेश्चन। विच ऑफ द फॉलोइंग ड्रग स्टेटमेंट अबाउट रिमेजीपांट इज नॉट ट्रू, तो हमें फॉल्स स्टेटमेंट ढूंढनी है ना, फॉल्स स्टेटमेंट ढूंढनी है। जिपांट वाले बेटा जितने भी ड्रग थे हमने पढ़ा दैट दे आर CGRP1, सॉरी CGRP2 एंटागनिस्ट होते हैं। ये CGRP को ब्लॉक करते हैं, दैट इज कैल्सिटोनिन जीन रिलेटेड पेप्टाइड। ये एक इन्फ्लेमेटरी मीडिएटर है जिससे माइग्रेन होता है। तो यस, इट इज अ CGRP2 एंटागनिस्ट। सेकंड इससे कहा देते हैं बेटा, माइग्रेन में देते हैं। माइग्रेन के नए ड्रग्स पढ़े थे मेनी टाइम्स, पहले भी पूछा जा चुका है, अब की बार भी पूछा गया है। बेटा पेम्ब्रोलिजुमैब इम्यून चेक पॉइंट इनिबिटर है, वो वीईजीएफ को नहीं इनिबिट करता, वो प्रोग्राम डेथ रिसेप्टर को इनिबिट करता है, लेट मी टेल यू। ठीक है। तो इसमें बेटा ट्रू पूछा गया था। यस, स्टूडेंट्स आर सेइंग हमें ट्रू स्टेटमेंट ढूंढना है। विच ऑफ द फॉलोइंग इज अ ट्रू स्टेटमेंट, ये ढूंढना है। ठीक है। सो व्हाट डू यू थिंक इज द बेस्ट आंसर? अब तो इजी हो गया ना बेटा, अब तो इजी हो गया। तो यस, इट इज गिवन इन द ट्रीटमेंट ऑफ एक्यूट अटैक ऑफ माइग्रेन, ये ट्रू स्टेटमेंट है। रिमेंबर ये तो अपने आप ही फॉल्स हो गया, बिकॉज इट इज नॉट CGRP1। पहली बात, ये तो CGRP2 है, और ये एगोनिस्ट नहीं है, ये एंटागनिस्ट है, ब्लॉक करता है। सेकेंड पॉइंट, इससे वेजो कंस्ट्रिक्शन होती है? नहीं, ये हमने बनाया ही इसीलिए है क्योंकि हम जो सूमा ट्रिप्टान देते हैं, ट्रिप्टान विच आर गिवन फॉर एक्यूट अटैक ऑफ माइग्रेन, इनसे वेजो कंस्ट्रिक्शन होती है। जिपान से वेजो कंस्ट्रिक्शन नहीं होती, इसीलिए हार्ट डिजीज वाले पेशेंट में सेफ होते हैं। तो द आंसर आउट हियर इज सी। ओके, रूट इसका ओरल है बेटा, दे आर ओरल ड्रग्स, दे आर ओरल ड्रग। तो यस, डी ऑप्शन है, इट इज गिवन बाय सबक्यूटेनियस रूट। तो ये भी ऑप्शन जो हो जाएगा हमारा फॉल्स हो जाएगा। तो हमारा सही आंसर है, आंसर ऑफ दिस क्वेश्चन, ट्रू स्टेटमेंट इज ऑप्शन नंबर सी, इट इज गिवन फॉर एक्यूट अटैक ऑफ माइग्रेन। माइग्रेन ऑप्शन में नहीं था बेटा। तो व्हाट अदर ऑप्शन वाज देयर? ओके ओके ओके, सो एनीवन हु कैन रिकॉल कोई और ऑप्शन? ओके, ए, बी एंड डी आर false statement, remember. Okay, any other option you can recall? Any other option which you can recall? तो हम ट्रू का आंसर ढूंढ लेंगे। CGRP1 था, CGRP2, रिमेंबर इट इज CGRP2, पार्शियल CGRP एगोनिस्ट। ओके, तो अगर ये वर्ड लिखा है बेटा पार्शियल, अगर पार्शियल लिखा है वर्ड, तब भी आप इसके साथ जा सकते हो, बिकॉज पार्शियल एगोनिस्ट आर ऑल्सो एंटागनिस्ट, है ना। पार्शियल एगोनिस्ट क्या होता है? एंटागनिस्ट का की तरह काम करते हैं। तो इस केस में ये ट्रू हो जाएगा अगर ये पार्शियल वर्ड लिखा है तो। बट आई जस्ट वांटेड टू आस्क यू, व्हाट इज द फोर्थ ऑप्शन इन दैट केस? अगर माइग्रेन वाला नहीं है ऑप्शन में, तो फोर्थ ऑप्शन क्या था? व्हाट वाज द फोर्थ ऑप्शन इफ माइग्रेन ऑप्शन वाज नॉट गिवन? Okay, so if this is not given, then yes, the true statement will be it is a partial CGRP agonist, because partial agonists, they also act as an antagonist. Okay, they also act as an antagonist during acute attack of a disease. So go with this answer. Partial word लिखा है तो this is the true answer. Okay, controversy is clear. Partial के साथ आप जा सकते हो. Okay, so they were confusing you with the simple concepts. Next question. Which of the following is that? This is the easy one we have discussed. A repetitive question, बहुत बार पूछा गया. What is the following is the treatment of choice for cryptococcal meningitis? Cryptococcal meningitis. Yes, we give a combination of liposomal amphotericin B plus 5-flucytosine. Okay, this is the treatment of choice. Okay, true statement. ठीक है, this is a simple question, many times asked, very old question, very repetitive question. Okay, इसमें किसी को ओके, लैम विथ फ्लूसाइटोसिन है, फ्लूकोनाजोल नहीं है बेटा। अजोल्स को जब हम एम्फोटेरिसिन बी के साथ कंबाइन करते हैं, एंटागनिस्ट, ये एक दूसरे का इफेक्ट कम कर देते हैं। ओके, एंड ओनली फ्लूकोनाजोल इज गिवन फॉर मेंटेनेंस थेरेपी। इसको हम कहा देते हैं मेंटेनेंस थेरेपी में। और सबसे पहला फर्स्ट ट्रीटमेंट क्या होता है? फर्स्ट ट्रीटमेंट इज एम्फोटेरिसिन बी प्लस 5-फ्लूसाइटोसिन। नो, द ओनली ट्रीटमेंट इज ए। इसका आंसर क्या है? सिर्फ ए ही है। द आंसर आउट हियर इज ए ओनली। ठीक है, ए ओनली। अगर ट्रीटमेंट ऑफ चॉइस वर्ड आ गया है तो मतलब आपने बेस्ट आंसर ढूंढना है। इन ट्रीटमेंट ऑफ चॉइस यू हैव टू डू बेस्ट आंसर, है ना। इन दैट केस यू एनीवे हैव टू चूज ओनली वन ऑप्शन। ओके, इनिशियल ट्रीटमेंट भी यही है। ठीक है, इनिशियल ट्रीटमेंट भी यही है। रिमेंबर, इनिशियल ट्रीटमेंट में हम क्या देते हैं? लाइपोसोमल एम्फोटेरिसिन बी प्लस 5-फ्लूसाइटोसिन। ये 1 to 2 वीक्स के लिए देते हैं, और जब फंगल लोड कम हो जाता है, वी गिव मेंटेनेंस थेरेपी फॉर एटलीस्ट 8 वीक्स विद फ्लूकोनाजोल। ये ट्रीटमेंट होता है बेटा क्रिप्टोकोकल मेनिंजाइटिस का। सो इनिशियल ट्रीटमेंट ऑफ चॉइस विल बी लाइपोसोमल एम्फोटेरिसिन बी प्लस 5-फ्लूसाइटोसिन। नो अदर ऑप्शन शुड बी देयर, और कोई ऑप्शन आपने मार्क नहीं करना। अगर बेस्ट या ट्रीटमेंट ऑफ चॉइस पूछे, देन गो विद दिस। ओके, नो कंट्रोवर्सी। अच्छा, लैम प्लस इट्राकोनाजोल नहीं है बेटा, लैम प्लस फ्लूसाइटोसिन ही है। ठीक है, ठीक है। एंड इफ द क्वेश्चन इज कमिंग कि कौन कौन से ड्रग दे सकते हैं, विच ऑल अदर ड्रग्स which all drugs we can give in cryptococcal meningitis? In that case, then the three answers or three option will be: first is liposomal amphotericin B, second is 5-flucytosine, third is fluconazole. If this question is a multiple choice question, then you can choose three drugs which are given for treatment of cryptococcal meningitis. Okay? ठीक है. Done. Let's go to the next one. Which of the following is not a side effect? A very repetitive question. I told you it is a very favorite question of INI-CET. Which of the following is not a side effect of beta agonist? So can you tell me beta agonist like salbutamol? We discussed one mnemonic 2T 2H पढ़ा था ना हमने कुछ ऐसे ही पढ़ा था 2T 2H है ना? Okay. So hyperglycemia, बच्चे are saying are not in the option. Can you tell me what other options were there? Okay, hyperglycemia option में नहीं था. Then can you tell me what other option was there? Let me tell you the four side effect which we have discussed. One was tremors. Most common tremors होता है, हाथ पैर कांपते हैं. Then salbutamol अस्थमा में tachycardia, palpitations होते हैं. It causes hypokalemia. ब्लड में पोटेशियम कम हो जाता है और ब्लड में ग्लूकोज का लेवल ज्यादा हो जाता है, हाइपरग्लाइसीमिया हो जाता है. ये पढ़ा था. सॉरी. यस. हाइपरग्लाइसीमिया. एनीवन व्हाट इज द फोर्थ ऑप्शन? हाइपोनेट्रीमिया दिया हुआ था. हाइपोनेट्रीमिया का तो कोई लेना देना ही नहीं है. ठीक है, पोटेशियम का काम. हाइपोनेट्रीमिया. ओके. पल्मोनरी वेजोडाइलेशन. ओके, पल्मोनरी वेजोडाइलेशन वाज गिवन. ओके. यस, इट विल कॉज पल्मोनरी वेजोडाइलेशन. यस, वेजोडाइलेशन होती है ना बीटा 2 एगोनिस्ट से. अरे साइड इफेक्ट तो नहीं होना चाहिए, वेजोडाइलेशन साइड इफेक्ट नहीं है. So if the question is coming not a side effect, then the best answer is hyperkalemia because it causes hypokalemia, not hyperkalemia. ठीक है? Here the answer is. So answer out here is, answer क्या होगा बेटा? Hypokalemia is a false statement. So this is not the side effect of. ओके, बीटा 2 से हमने पढ़ा था ना वेजोडाइलेशन होती है. ओके, पल्मोनरी वर्ड नहीं था, सिर्फ वेजोडाइलेशन. दिस इज ट्रू, दिस इज ट्रू, दिस इज ट्रू. सो फॉल्स स्टेटमेंट इज हाइपरकैलेमिया. फाइन, इजी क्वेश्चन. ये तो बहुत बार हम स्ट्रेस भी देते हैं कि इस पे सवाल आता है, सब में पढ़ा. नेक्स्ट पे आते हैं बेटा. आई डोंट नो विच चैनल इज रिकॉल्ड आउट हियर. तो कोई ऐसा चैनल था बेटा? हैव यू, कैन यू रिकॉल कुछ ऐसा चैनल वैनल था? Okay, I can't understand this question properly. So what is given out here? तो मुझे तो ये सोडियम पोटेशियम एटीपीएस लग रहा है ना. It seems like sodium potassium ATPase. This is sodium which is going out, and this is potassium which is coming inside. है ना? है ना? है ना? So which drug was inhibiting ADP ATP? हाँ, तो can we call this transporter as sodium potassium ATPase? तो इस ट्रांसपोर्टर का नाम लॉजिकली हमें पता लग जाएगा, सोडियम पोटेशियम एटीपीएस. है ना? है ना? एटीपीएस है तो एक्टिव ट्रांसपोर्ट है, एनर्जी चाहिए. नाउ विच ड्रग? सो आंसर विल बी यस, वेरी वेरी सिंपल, इजी आउट है. तो आंसर क्या हो गया? डी हो गया ना, सोडियम पोटेशियम चैनल. यस यस. ग्लूट नहीं है बेटा, ग्लूट में तो ग्लूकोज होगा ना, सोडियम पोटेशियम नहीं होगा. अच्छा सर, ये नहीं था. ओके, ओनली वन मॉलिक्यूल वाज गिवन. इफ ओनली वन मॉलिक्यूल वाज गिवन. ओके. अच्छा, ये डाइजॉक्सिन वाले क्वेश्चन के ऑप्शन में था. ओके. सो आई थिंक ड्यूरिंग रिकॉल टू क्वेश्चंस वर मिक्स्ड एक्चुअली. सो देयर इज अ सिमिलर क्वेश्चन. तो यस यस. ओके, सोडियम पोटेशियम चैनल था. अच्छा, कई बच्चे कह रहे हैं सोडियम पोटेशियम चैनल और डाइजॉक्सिन वाला सेपरेट क्वेश्चन है. तो यस, वी नो डाइजॉक्सिन इनहिबिट सोडियम पोटेशियम एटीपीएस. एंड सेकंड ग्रुप ऑफ स्टूडेंट और गैंग ऑफ स्टूडेंट आर सेइंग पोटेशियम इनफ्लक्स नहीं था. Okay, there is another question. Don't worry, I'll come to that question. So let me come to that question first. कुछ ऐसा था? Something was this? Something was given out here. एक ये भी question बच्चों ने बताया. Which of the following drugs act by inhibiting the channel marked? Unidirectional with ATP. Okay. 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 तो यूनिडायरेक्शनल तो ये स्पी ग्लाइकोप्रोटीन होता ही है. हाँ. ओके, चलो, ओके। सो मैं आपको आंसर बता देता हूं। आई थिंक द करेक्ट पिक्चर आई एम अनेबल टू रिकॉल, बट आई थिंक बाय हियरिंग द आंसर यू कुड हैव गेस द प्रॉपर वन। कैल्शियम चैनल ब्लॉकर तो सिर्फ क्या करेगा, तो डाइजॉक्सिन क्या करेगा, सोडियम पोटेशियम बाई डायरेक्शनल एटीपीएज, ये इसको इनहिबिट करेगा। कैल्शियम चैनल ब्लॉकर वेरापामिल, वेरापामिल किसको ब्लॉक करेगा, ओनली एंट्री ऑफ कैल्शियम, ये ओनली एंट्री ऑफ कैल्शियम को इनहिबिट करेगा। नाइट्रेट तो किसी चैनल को इनहिबिट नहीं करता। इवाब्रेडीन फनी चैनल्स को इनहिबिट करता है। फनी चैनल्स के केस में बेटा बोथ सोडियम और पोटेशियम को आपको, ये फिजियो का सवाल है, सोडियम और पोटेशियम दोनों को अंदर लाना है, ये आपका इवाब्रेडीन करेगा। इनवर्ड सोडियम पोटेशियम करंट होता है, ये फिजियोलॉजी का क्वेश्चन है। सो एनी ऑप्शन वाज गिवन। Okay. So anonymous G, yes. If sodium potassium was given, then it is digoxin. Only calcium is given, then it is verapamil. Both inward sodium potassium is given, then the answer is ivabradine. अब आंसर क्या हो जाएगा, ivabradine. ओके, ivabradine. चलो, एम्लोडिपिन इज ऑल्सो कैल्शियम चैनल ब्लॉकर, वो हम वेरापामिल के साथ ही लिख सकते हैं। एम्लोडिपिन भी वेरापामिल के साथ। ओनली पोटेशियम वॉज गिवन। अगर बेटा ओनली पोटेशियम वॉज गिवन, इन दैट केस मुझे लगता है नाइट्रेट वर्ड नहीं होना चाहिए, निकोरेंडल वर्ड होना चाहिए। सम स्टूडेंट्स आर सेइंग निकोरेंडल। निकोरेंडल क्या करता है, निकोरेंडल क्या करता है, इट इज अ पोटेशियम चैनल ओपनर। अगर ऐसा कुछ दिया है तो निकोरेंडल है। नाइट्रेट तो ऑप्शन में होगा ही नहीं, नाइट्रेट डज नॉट एक्ट ऑन रिसेप्टर। ओके, पोटेशियम ओपनर वॉज निकोरेंडल। तो बेटा दिस इज द ऑप्शन आई एम गिविंग यू। द फर्स्ट विल बी सोडियम पोटेशियम एटीपीएस। सोडियम अंदर से बाहर जा रहा है, पोटेशियम बाहर से अंदर आ रहे हैं, गो विद डाइजॉक्सिन आउट हेयर। कैल्शियम को ब्लॉक करने वाला वेरापामिल या एम्लोडिपिन, एग्री। ओके, वेरापामिल या एम्लोडिपिन, इनवर्ड मूवमेंट ऑफ कैल्शियम, कैल्शियम चैनल ब्लॉकर। इवाब्रेडीन होगा जो सोडियम और कैल्शियम दोनों की एंट्री को बढ़ाएगा। निकोरेंडल पोटेशियम चैनल को क्या करेगा, ओपन करेगा, एंजाइना वाला ड्रग है। आई थिंक द कंट्रोवर्सी इज एब्सोल्युटली क्लियर। यस, कई स्टूडेंट्स को अलग क्वेश्चन आ सकते हैं, सेम क्वेश्चन सेट नहीं एक्सपेक्ट कर सकते आप INI-CET। Okay, so I think this controversy is clear. Now you would have answered them properly. Okay, next question की बात करते हैं। A patient diagnosed with HIV with cough and fever for past 3 months. क्या, okay, HIV है, cough, pulmonary TB suspected. So again, this is a question which was repeated 6 months before also in INI-CET. तो HIV with TB है, तो पहले किसको ठीक करते हैं हम, TB फिर HIV। तो पहले हम स्टार्ट करेंगे ATT, एंड आफ्टर 2 to 8 weeks वी विल स्टार्ट ART, है ना, अभी हमने पढ़ा भी था। एंड रिमेंबर प्रॉब्लम आती है ATT में रिफेम्पिसिन के साथ। रिफेम्पिसिन दूसरे ड्रग का मेटाबॉलिज्म या डिग्रेडेशन बढ़ा देता है, बिकॉज रिफेम्पिसिन इज अ CYP इंड्यूसर। और हमने एक ट्रिक पढ़ी थी, विद रिफेम्पिसिन डबल द डोज ऑफ डोलूटाग्राविर। डोलूटाग्राविर HIV वाला ड्रग है, इसीलिए हमें डोलूटाग्राविर की डोज बढ़ानी होती थी। एग्री। ओके, डेक्सा वॉज इन द ऑप्शन। ओके, डेक्सा, डोलूटाग्राविर था बेटा, डेक्सा था। Dexamethasone with ART was given with increase the dose of dolutegravir. Yes, just I wanted to ask, pulmonary tuberculosis लिखा है, कहीं और ऑर्गन का ट्यूबरक्लोसिस तो नहीं लिखा था, एनी अदर ऑर्गन लाइक ट्यूबरकुलर meningitis? Because dexamethasone or corticosteroid you will only give when the patient is having extra pulmonary TB, like tubercular meningitis, genitourinary TB, miliary TB, तब देते हैं। So is it pulmonary TB or some extra pulmonary TB was given? तो डेक्सा तो नहीं देंगे, डेक्सा तो सिर्फ हम ट्यूबरकुलर मेनिंजाइटिस वगैरह में, मिलियरी टीबी था, मिलियरी टीबी में देंगे हम। सो आई थिंक लेट्स मी मॉडिफाई द आंसर फॉर यू। ATT पहले देंगे, बिल्कुल ठीक, फॉलोड बाय ART 2 weeks later, ये भी ठीक है। इंक्रीज द डोज ऑफ डोलूटाग्राविर, ठीक है। अगर डेक्सा दिया है तो हम दे सकते हैं, अगर डेक्सामेथासोन लिखा है यू कैन गिव इफ द पेशेंट इज हैविंग सम एक्स्ट्रा पल्मोनरी टीबी, एग्रीड, लाइक ट्यूबरकुलर मेनिंजाइटिस, इडीमा, फाइब्रोसिस को कम करने के लिए डेक्सामेथासोन ऐड करेंगे। So I think the answer out here should be, the best answer should be A. Okay, the best answer should be A. Now, can you tell me other option which was given? ओके। बेटा आई थिंक एटीटी तो पहले ही स्टार्ट करते हैं। ओके, इफ यू आर डेक्सामेथाजोन देन यू कैन स्टार्ट एटीटी टुगेदर ऑल्सो, बिकॉज हमें इम्यून रिकॉन्स्टिट्यूशन सिंड्रोम को हटाना होता है। यस, ये जुनेद कह रहे हैं सर मिलियरी टीबी इज गिवन, तो यस मिलियरी टीबी है तो देना है ना डेक्सामेथाजोन, है ना, एक्स्ट्रा पल्मोनरी टीबी है तो देना है डेक्सामेथाजोन। यस यस, मिलियरी दिया हुआ है, ठीक है। गो विद द ऑप्शन नंबर ए। कोई बात नहीं, पहले एटीटी फिर एआरटी, डेक्सा डोलुटाग्राविर की डोज बढ़ानी है। दिस इज यू हैव टू आंसर। ओके, आंसर ए इज एब्सोल्युटली करेक्ट, नो कंफ्यूजन। ठीक है। हाँ, कोई कोई और टीबी दिया हुआ है देन इट्स फाइन, देन इट्स फाइन। ठीक है, नेक्स्ट पे आते हैं बेटा। लेट्स कम टू द नेक्स्ट क्वेश्चन। लेट्स कम टू द नेक्स्ट क्वेश्चन। आइडेंटिफाई द पैरासाइट शोन इन द इमेज एंड टेल मी द ड्रग ऑफ चॉइस। आई थिंक समथिंग वाज गिवन आउट हियर, कुछ ऐसा दिया था, ये पैरासाइट दिया हुआ था। तो ये क्या है बेटा? दिस इज ऑरेंज, फ्रेश वाटर क्रैब है। क्या आप बता सकते हो कौन सा हेलमिंथिक इन्फेक्शन होता है? इट इज एन इंटीग्रेटेड क्वेश्चन ऑफ माइक्रोबायोलॉजी एंड फार्माकोलॉजी, आई थिंक, है ना? माइक्रो और फार्मा का क्वेश्चन है, तो कैन यू टेल मी, है ना? तो यस, इसकी वजह से एक हेलमिंथिक इन्फेक्शन होता है स्क्रैप की वजह से, दैट इज पैरागोनोमियस। पैरागोनोमस, एंड इट इज नोन एज, आई थिंक, कौन सा फ्लूक होता है? लंग फ्लूक होता है ना? एंड आई हैव टोल्ड यू ऑल फ्लूक्स द मोस्ट कॉमन ड्रग ऑफ चॉइस इज, हमेशा फ्लूक्स में ड्रग ऑफ चॉइस कौन सा होता है? प्राजिक्वेंटल होता है ना? पैरागोनोमियस ड्रग ऑफ चॉइस। ठीक है, फाइन। डीईसी बेटा नहीं है, डीईसी तो हम उसमें देते हैं ना, लिम्फेटिक फिलेरियासिस वगैरह में देंगे। तो इससे कौन सी बीमारी होती है? पैरागोनोमियस। ओके, पैरागोनोमियस, थोड़ी स्पेलिंग गलत तो वही ठीक कर देते हैं। ठीक है। ओके, सो कोरिलेट विद माइक्रोबायोलॉजी। ओके, माइक्रोबायोलॉजी के साथ कोरिलेट करते हैं। नेक्स्ट क्वेश्चन, दिस इज, आई think is the easy one. A chronic patient with schizophrenia psychosis है, आई थिंक ये तो बहुत बार हमने पढ़ा है ना, इसकी तो हमने एड्स भी देखी हैं। ऑन हेलोपेरिडॉल, हेलोपेरिडॉल एंटी साइकोटिक ड्रग, स्टिफनेस और रिजिडिटी हो गई, तो पेशेंट को क्या हो गया? ईपीएस, एक्स्ट्रा पिरामिडल सिम्टम, या फिर पेशेंट को ड्रग इंड्यूस्ड पार्किंसन डिजीज हो गया है। तो विच ऑफ द फॉलोइंग इज द एप्रोप्रिएट ट्रीटमेंट? एक डेंट्रोलिन भी दिया हुआ है। चलो, एनी अदर ऑप्शन? ऑप्शन नंबर सी क्या है और ऑप्शन नंबर डी क्या है? सीपीके इज रेस्ड। ओके, सीपीके इज रेस्ड। ओके, यस, सीपीके रेस्ड है तो मतलब क्या है? पेशेंट की मसल्स जो है डैमेज हो रही हैं, इसीलिए सीपीके क्या आ गया है? मसल से ब्लड में आ गया। और अगर रैप्डोमायोलाइसिस हो गई है तो पेशेंट को क्या हो गया है? न्यूरोलेप्ट मेलिग्नेंट सिंड्रोम। इट इज अ टाइप ऑफ एक्स्ट्रा पिरामिडल सिम्टम। ओके। ओके, यस। तो इसमें पेशेंट को रैप्डोमायोलाइसिस और हाइपरथर्मिया भी होता है ना, मसल डैमेज होंगी। हाइपरथर्मिया, एक्सट्रीम रिजिडिटी। यस यस, टेम्परेचर भी बढ़ा होगा। दिस इज अ फीचर ऑफ मेलिग्नेंट हाइपरथर्मिया, नाम में ही लिखा है ना, न्यूरोलेप्ट मेलिग्नेंट। ओके, एनीवन? ओके, यस, सो आंसर इज ब्रोमोक्रिप्टिन भी है, ब्रोमोक्रिप्टिन भी दे सकते हैं। और हमें स्टॉप करना है एंटी साइकोटिक। ऑप्शन नंबर सी क्या बेटा? स्टॉप एंटी साइकोटिक ड्रग, ऑप्शन नंबर सी क्या है? हाँ, ऑटोनॉमिक डिस्टरबेंस भी होता है, बिल्कुल। हाइपरथर्मिया तो ऑटोनॉमिक डिस्टरबेंस भी होगा। ऑप्शन नंबर सी क्या है बेटा? व्हाट इज ऑप्शन नंबर सी? तो हियर द आंसर इज बी। आंसर तो बेटा इसका बी ही है। ऑप्शन नंबर सी क्या है? ओके, ओके, सो व्हाट वी हैव टू डू, वी हैव टू स्टॉप एंटी साइकोटिक ड्रग। ये तो सबसे पहले करना है क्योंकि लाइफ थ्रेटनिंग कंडीशन है। स्टॉप एंटी साइकोटिक ड्रग तो करना ही है, सभी एक्स्ट्रा पिरामिडल सिम्टम में हमें एंटी साइकोटिक ड्रग स्टॉप करने होते हैं ना, साइड इफेक्ट आ रहा है। और हमें क्या स्टार्ट करना है? डेंट्रोलिन, डेंट्रोलिन नहीं है तो ब्रोमोक्रिप्टिन देना है। ओके, हाइड्रेट भी करना है, बिल्कुल करना है, हाइपरथर्मिया तो हाइड्रेट करना है। नो नो नो, वी शुड नॉट कंटिन्यू एंटीसाइकोटिक। कंटिन्यू एंटीसाइकोटिक नहीं, यू हैव टू स्टॉप। इमरजेंसी है बेटा, आदमी मर जाएगा इसमें। हाइपरथर्मिया तो इमरजेंसी है, ब्रेन डैमेज हो जाएगा। कंटिन्यू एंटीसाइकोटिक ड्रग विद हाइड्रेशन। नाउ दिस इज अ फॉल्स स्टेटमेंट, नहीं करना बेटा ऐसा कुछ भी। दिस इज अ फॉल्स स्टेटमेंट। पहला, बेंचट्रोपिन एंटीकोलिनर्जिक ड्रग हम देते हैं, बट न्यूरोलेप्ट मैलिग्नेंट सिंड्रोम में नहीं देते। इट इज गिवन फॉर मसल डिस्टोनिया, है ना, रैबिट सिंड्रोम, उसमें देते हैं। बेंजोडाइस्पिन भी नहीं देते। स्टॉप एंटीसाइकोटिक। ओके, स्टॉप एंटीसाइकोटिक तो करना ही है बेटा। स्टॉप एंटीसाइकोटिक एपी ड्रग, ये भी करना ही है। ठीक है, तो बेस्ट आंसर इज स्टॉप एंटीसाइकोटिक एंड स्टार्ट डेंट्रोलिन। इज इट मल्टीपल चॉइस क्वेश्चन? मतलब मल्टीपल आंसर्स हो सकते हैं, मल्टीपल करेक्ट टाइप था क्या? वॉज इट मल्टीपल करेक्ट टाइप? अगर बेस्ट आंसर ढूंढना है तो बी है। अच्छा, कई बच्चे यस कह रहे हैं, तो बेस्ट आंसर इज गिव स्टॉप एंटीसाइकोटिक फर्स्ट एंड देन स्टार्ट डेंट्रोलिन। सबसे पहले क्या करना है? स्टॉप एंटीसाइकोटिक, हाइड्रेशन करो, आदमी को ठंडा करो, गर्म है तो, हाइपरथर्मिया है ना, और उसके बाद स्टार्ट डेंट्रोलिन और ब्रोमोक्रिप्टीन। ठीक है। इफ ऑप्शन नंबर if option number they are different, if they are different option, then go with this one first. Okay, there were two similar question and they are getting mixed, so I wanted to ask what was the another question, what do you think out here is? दूसरा क्वेश्चन क्या था? ओके, आई थिंक अनदर क्वेश्चन, दूसरा क्वेश्चन क्या था? तो ये तो हो गया न्यूरोलेप्ट मैलिग्नेंट सिंड्रोम का, इसका तो मैनेजमेंट यही हो गया, इसका तो मैनेजमेंट यही हो गया। ठीक है, स्टॉप एंटीसाइकोटिक, डू हाइड्रेशन एंड स्टार्ट डेंट्रोलिन या ब्रोमोक्रिप्टीन, दिस इज द मैनेजमेंट। ठीक है, ओके, ओके, आई थिंक नाउ यू कैन आंसर इट वाइजली। कोई बात नहीं, प्रॉपर हम रिकॉल नहीं कर पाते, दैट इज, अभी आप बेचारे इतना स्ट्रेस लेके आए हैं, सर और स्ट्रेस दे रहे हैं आपको, डोंट वरी। इट विल गो। आई थिंक दिस इज अ क्वेश्चन ऑफ बायोकेम, आई विल स्किप दिस क्वेश्चन। ओके, नाउ आई जस्ट वांटेड टू आस्क, जस्ट आई नीड अ लिटिल बिट ऑफ रिकॉल। आप बच्चे कोई मुझे रिकॉल बता सकते हैं? एनी अदर क्वेश्चन विच आई हैव मिस्ड? ओके, कोई बात नहीं, एनी अदर क्वेश्चन विच वी हैव मिस्ड, so that it will help your friends and juniors who will be giving upcoming exams. Any other question you remember? Because complete and proper authentic recall will take 1 or 2 days of time and we will upload as we will gather more knowledge. So any other question you want to contribute right now? Okay. So I think कीटामीन से रिलेटेड था, क्या क्वेश्चन था बेटा? कीटामीन रिलेटेड क्वेश्चन, कीटामीन हर बार आ रहा है, 3-4 साल से आ रहा है। ओके, फॉल्स स्टेटमेंट अबाउट फेनेरिनॉन। ओके, एक फेनेरिनॉन का भी क्वेश्चन बच्चा बता रहे हैं। ठीक है, एनी अदर क्वेश्चन? प्री प्रोफाइलेक्सिस ऑफ HIV, प्री है कि प्रो है? ओके, अनदर, प्री प्रोफाइलेक्सिस ऑफ HIV। ठीक है, which is not the advantage of ketamine? Any other options, you know, option number A, B, C, D? अच्छा, डोज रिस्पॉन्स कर्व पे भी आया, ग्रेट, ये तो इजी होगा। Dose response curve. Now, I just want a little bit of help from all of you student. क्या क्वेश्चन था? ओके, अच्छा, एक एसिटाइल कोलिन का भी कुछ आया है। ओके, यस, कीटामीन कॉजेस डिसोसिएटिव एनेस्थीसिया, बिल्कुल ट्रू स्टेटमेंट है। यस, इट कॉजेस डिसोसिएटिव एनेस्थीसिया। यस, अच्छा, ओके, देयर इज अ क्वेश्चन, कुछ एसिटाइल कोलिन था, साथ में कुछ फिजोस्टिग्मिन दिया होगा, and physostigmine inhibit the degradation of acetylcholine, तो जो डोज रिस्पॉन्स कर्व होगा वो और इंक्रीज हो जाएगा, जो डोज रिस्पॉन्स कर्व होगा वो और इंक्रीज हो जाएगा, कुछ ऐसा ही दिया होगा ना। ओके, हाँ, यस यस, सो दिस इज आई थिंक वी हैव डन, है ना, फिजोस्टिगमिन। तो ये सिनर्जिस्टिक कॉम्बिनेशन है, इट शोज सिनर्जिज्म, क्योंकि फिजोस्टिगमिन एसिटाइलकोलिन को डिग्रेड नहीं होने देता, इट इज एन एंटीकोलिनेस्टेरिस। तो चलो बेटा, दिस क्वेश्चन वी आर सॉर्टेड अबाउट, ये तो सॉर्ट आउट हो गया। व्हाई डज बीपी फॉल व्हेन वी इंस्पायर? अरे वो फिजियो का क्वेश्चन है ना, फॉरेक्स का वॉल्यूम बढ़ जाएगा, वेना केवा डायलेट हो जाएंगे, फिजियो वाले बताएंगे। बिथैनिकॉल था। बिथैनिकॉल आंसर नहीं होगा बेटा, बिथैनिकॉल डायरेक्टली एक्टिंग है। आंसर यहां पे होगा फिजोस्टिगमिन, नॉट बिथैनिकॉल, क्योंकि बिथैनिकॉल, कॉल वर्ड आ रहा है, ये भी एसिटाइल कोलिन की तरह है। ये एसिटाइल कोलिन का डिग्रेडेशन नहीं बढ़ाता, बना इनहिबिट करता। डिग्रेडेशन कौन इनहिबिट करता है? फिजोस्टिगमिन। ओके, कीटामीन हेल्प इन ओपियोइड एक्शन, हेल्प इन ओपियोइड एक्शन। अच्छा, नेक्स्ट अनदर क्वेश्चन, नॉट एन एडवांटेज। ये तो है बेटा एडवांटेज, ये भी एडवांटेज ही लग रहा है, एनेस्थीसिया में देते हैं। यूज टू रिड्यूस टॉलरेंस टू ओपियोइड, नो, टॉलरेंस टू ओपियोइड कम हो जाएगी, क्यों हो जाएगी यार, ये दोनों ही एडिक्टिव है। ऐसा तो कुछ नहीं होगा। टॉलर, ओके, डिसोसिएटिव एनेस्थीसिया तो करता है बेटा ये तो इसका एडवांटेज है ना, एडवांटेज है। हेल्प इन ओपियोइड एक्शन, ये भी एडवांटेज है। ये एडवांटेज नहीं लग रहा मुझे। टॉलरेंस क्यों बढ़ानी है यार ओपियोइड, ओपियोइड की, है ना, मतलब। स्टेटस एपिलेप्टिकस में कौन सा नहीं दे सकते? इथोसक्सीमाइड नहीं दे सकते, ओके। ओके, फिनेरिनॉन, यस, फिनेरिनॉन स्पाइरोनोलेक्टोन का भाई है। यस, इट इज एक्सक्रीटेड, इट इज जस्ट लाइक स्पाइरोनोलेक्टोन। इसे डायबिटिक नेफ्रोपैथी में अप्रूव्ड किया गया है। इट इज अप्रूव्ड फॉर डायबिटिक नेफ्रोपैथी। इट इज एक्सक्रीटेड इन यूरिन, मैक्सिमम ड्रग यूरिन में ही निकलते हैं, तो इसमें रटने की क्या जरूरत है, लिख दो, एक्सक्रीटेड इन यूरिन। ओके, ओके, सो आई कम टू दिस क्वेश्चन। ओके, फर्स्ट इज साइकोमाइमेटिक, तो है, बिल्कुल है साइकोमाइमेटिक। तो साइकोमाइमेटिक तो इसका साइड इफेक्ट हो गया ना, रिमेजी पैंट वी आर डन। तो पहले हम इस पे आते हैं, विच ड्रग इज नॉट गिवन इन स्टेटस एपिलेप्टिकस, ये ऑप्शन था ना, तो हमने पढ़ा है पूरा। बेंजोडायस्पिन से शुरुआत करते हैं। द ड्रग विच इज नॉट गिवन इन स्टेटस एपिलेप्टिकस इज इथोसक्सीमाइड, इथोसक्सीमाइड नहीं देते। और कोई ड्रग जो नहीं देते स्टेटस एपिलेप्टिकस में, लैमोट्रिजीन, ये दो ड्रग हम नहीं देते, तो दे आर नॉट गिवन इन स्टेटस एपिलेप्टिकस। फाइन, फाइन, ठीक है। विच डीपीपी फोर इनहिबिटर, विच डीपीपी फोर इनहिबिटर डोज शुड बी रिड्यूस विद कीटोकोनाजोल, कीटोकोनाजोल। इसमें बेटा क्या सीटाग्लिप्टिन था? हमने पढ़ा था ना, सीटाग्लिप्टिन इज द ओनली ग्लिप्टिन विच इज मेटाबोलाइज्ड बाय, सॉरी सीटा नहीं, सेक्साग्लिप्टिन था, सेक्साग्लिप्टिन था। इट इज द ओनली ग्लिप्टिन विच इज मेटाबोलाइज्ड बाय CYP3A4। एक यही ग्लिप्टिन होता है जो CYP3A4 से डिग्रेड होता है। कीटोकोनाजोल क्या करेगा, CYP3 का इनहिबिट करेगा, इस ड्रग की टॉक्सिसिटी आ जाएगी, है ना, हमने पढ़ा था। द ओनली ग्लिप्टिन, सेक्साग्लिप्टिन आंसर है इसका, ठीक है, नो डाउट इन दैट। अच्छा, प्री एक्सपोजर, हाँ, सेक्साग्लिप्टिन इज द करेक्ट आंसर, ठीक है। इसका आंसर इथोसक्सीमाइड है। नेक्स्ट क्वेश्चन, अब बेटा क्या है, प्री एक्सपोजर, ये पोस्ट एक्सपोजर प्रोफाइलिक्सिस है। अच्छा, प्रोस, हाँ, सेक्सा वाज द आंसर, नो डाउट, ये सिंपल क्वेश्चन हो गया। ओके, वन क्वेश्चन, प्री एक्सपोजर प्रोफाइलिक्सिस ऑफ HIV। बेटा प्री एक्सपोजर है, पोस्ट एक्सपोजर है? पोस्ट होना चाहिए। प्री एक्सपोजर HIV प्रोफाइलिक्सिस, इसके लिए सिर्फ एक नया ड्रग अप्रूव हुआ है, जो हमने ग्रुप में भी डाला था, इस साल अप्रूव हुआ है, लिनेका पाविर था इसका आंसर। द ओनली ड्रग विच इज अप्रूव फॉर प्री एक्सपोजर प्रोफाइलिक्सिस ऑफ HIV वाज लिनेका पाविर। कैप वर्ड आ रहा है, कैप्सिड इनहिबिटर था, कुछ ऐसा था नहीं, फिर पोस्ट होगा। पोस्ट एक्सपोजर प्रोफाइलिक्सिस में हम देते हैं बेटा सारे के सारे ड्रग। प्री एक्सपोजर में तो एक ही ड्रग अप्रूव है, ओनली दिस ईयर वाज लिनेकापाविर, नो अदर ड्रग वाज गिवन। अभी एचआईवी हुआ ही नहीं, फिर क्यों प्रोफाइलिक्सिस देना। पोस्ट एक्सपोजर एचआईवी प्रोफाइलिक्सिस में यस, तो इसमें मोस्ट कॉमनली हम देते हैं टीएलडी रेजिमेन। अब आप कह रहे हो टीएलडी, टीएलडी में आप दे सकते हो टीनोफोविर विद लैमिविडीन, दे सकते हो, ठीक है। हेपेटाइटिस बी पोस्ट एक्सपोजर प्रोफाइलिक्सिस, वहां तो बेटा वही वैक्सीन और एंटी एचपीवी सीरम देना है, वो पीएसएम का हो गया। ओके, प्री एक्सपोजर दिया हुआ था बेटा। ओके, अभी मैं आ रहा हूं उसमें। अगर टी है, टी को हम किससे रिप्लेस करते हैं, जेड एल डी। टी को हम किससे रिप्लेस करते हैं बेटा, याद रखना है, टी को हम रिप्लेस कर सकते हैं जेड से, और एल को रिप्लेस कर सकते हैं ई से, ये बात याद रखनी है। मतलब टीनोफोविर के साथ आप क्या दे सकते हो, जीडोविडीन दे सकते हो, लैम्यूडिन के साथ आप एम्ट्रीसिटाबिन दे सकते हो। तो ये रिप्लेसमेंट ड्रग होते हैं, बिकॉज देयर कॉम्बिनेशन इज सिनर्जिस्टिक। तो अब मैं आपको बता रहा हूं, या तो टीनोफोविर लैम्यूडिन दे दो, टीनोफोविर एम्ट्रीसिटाबिन दे दो, जीडोविडीन लैम्यूडिन दे दो, या जीडोविडीन एम्ट्रीसिटाबिन दे दो। ये चार ऑप्शन आप दे सकते हो। ओके, दीज आर द फोर ऑप्शंस यू कैन गिव। टीनोफोविर लैम्यूडिन, टी को हम जेड से रिप्लेस करते हैं, लैम्यूडिन को हम एम्ट्रीसिटाबिन से रिप्लेस करते हैं। तो ये चार ऑप्शंस, फोर ऑप्शंस विच आर पॉसिबल विच वी कैन गिव इज। अब बताओ इनमें से कोई आंसर है। ओके, इनमें से कौन कौन सा ऑप्शन था, टीनोफोविर लैम्यूडिन था ऑप्शन में, देन गो विद दिस आंसर, यही मोस्ट प्रेफर्ड होता है, ठीक है। ठीक है, सो दिस इज द आंसर। ओके, तो बेटा दिस वाज अ मल्टीपल चॉइस क्वेश्चन, क्या मुझे बताओ मल्टीपल आंसर्स करेक्ट है इसमें। तो टीनोफोविर एम्ट्रीसिटाबिन भी दे सकते हो। माय क्वेश्चन फ्रॉम यू स्टूडेंट वाज, क्या इनमें से हमें एक आंसर चूज करना था कि मल्टीपल आंसर्स चूज करने थे, दिस इज द नेक्स्ट पॉइंट आई वांट टू आस्क। You have to choose the best answer. If you have to choose the best answer, then go with the first one, tenofovir lamivudine. Then it is the best answer. This is the order of preference. I don't know why they have asked you this question. ये क्वेश्चन पूछना नहीं चाहिए उनको। ओके, ओनली जिडोविडीन भी था, चलो। Then the best answer should be tenofovir lamivudine. But I want to tell you one thing. बेटा पोस्ट एक्सपोजर प्रोफाइलिक्सिस में हम दो ड्रग्स नहीं देते, वी गिव जनरली थ्री ड्रग्स। I don't know why they are asking you about two drugs. Go with tenofovir lamivudine. The best answer is this one. Best answer यही होगा, tenofovir lamivudine is the best answer. Okay, if they are asking about multiple correct answer, then you can go with these four options. If they are asking with the best answer, go with the first one, tenofovir lamivudine. I hope. Okay, चलो। और आप कह रहे हो प्री एक्सपोजर है, ओ आप कह रहे हो प्री एक्सपोजर है, चलो। I think we have to see this question again. It is becoming a controversial question now, है ना? Okay, controversial question बन गया। चलो, we will see that and we will get back to you. Okay, lastly एक क्वेश्चन बच्चा कह रहा है प्रोस्टासाइक्लिन से रिलेटेड कोई क्वेश्चन था, बताओ बेटा क्या था। डोंट वरी, वी विल सी। अभी बच्चों को धीरे धीरे और मेमोरी इंक्रीज होगी। प्रोस्टासाइक्लिन का बेटा क्या था, है फॉर नीडल प्रिक इंजरी, वहां पे तो बेटा वही वैक्सीन और रेबीज सीरम, वो हेपेटाइटिस बी सीरम, यू विल लर्न शॉर्टली इन पीएसएम, पीएसएम और मेडिसिन में पढ़ोगे। पोस्ट एक्सपोजर ऑफ हेपेटाइटिस में एंटीवायरल ड्रग पूछे हैं तो मैं बता देता हूं आपको। प्रोस्टासाइक्लिन वाला बेटा क्या क्वेश्चन है, नो प्रॉब्लम शाशा जी, डोंट वरी, वी विल गेट बैक टू दिस क्वेश्चन लेटर ऑन। तो फिलहाल हम बेस्ट आंसर लिखते हैं, टीनोफोविर लैम्यूडिन इज द बेस्ट आंसर। ओके, टीनोफोविर लैम्यूडिन इज द बेस्ट आंसर। ओके, ड्रग यूज्ड इन पल्मोनरी आर्टरी हाइपरटेंशन, ओके, ड्रग यूज्ड इन पल्मोनरी आर्टरी। अच्छा, हमने पढ़ा था प्रोस्टासाइक्लिन, सेलेक्सी पैक था ऑप्शन में, पढ़ा था ना सेलेक्सी पैग। इट इज अ आई टाइप ऑफ प्रोस्टासाइक्लिन और प्रोस्टाग्लैंडिन। एजी का मतलब एगोनिस्ट, ये ट्रिक पढ़ी थी ना हमने, ऐसा था कुछ। So this is the selexipag is the answer. Okay. I think I've guessed right. Okay. So that we discussed in LRRRR पढ़ा था हमने, है ना। एक न्यूमोनिक भी पढ़ा था, पेप्सी कोका कोला। ठीक है, पेप्सी कोका कोला। ठीक है, एनी अदर क्वेश्चन? डोंट वरी, दैट प्री एक्सपोजर वाला आई विल टेल नेहा मैम टू टेक दिस क्वेश्चन अगेन। प्री एक्सपोजर इन HIV, what was the correct options? Meanwhile, other students will also contribute and we can recall the proper question. Don't worry. HIV वाला कंट्रोवर्सी अभी सॉल्व हो जाएगी आपका PSM में, मैम विल। हाँ, एगोनिस्ट है ना, एगोनिस्ट का मतलब रिसेप्टर को स्टिमुलेट करने वाले, है ना। सेलेक्सीपैग इज द आंसर। इलोप्रोस्ट इज सिंथेटिक प्रोस्टाग्लैंडिन। इलोप्रोस्ट, इट इज अ सिंथेटिक PGI2। काम तो ये भी रिसेप्टर पे ही करेगा, पर सेलेक्सीपैग इज रिसेप्टर एगोनिस्ट है। ये डिफरेंस था। रिसेप्टर वर्ड है तो बेटा ठीक है, सेलेक्सीपैग भी वैसे रिसेप्टर पे काम करता है। इलोप्रोस्ट भी प्रोस्टाग्लैंडिन I2 है, आई वर्ड आ रहा है ना, आई प्रोस्ट, है ना। If beta single option is given, then go with Selexipag. If it is a multiple correct type of an answer, then go with both of them. Because eventually both of them will stimulate prostacyclin receptor. The only difference is ये तो synthetic prostaglandin है, इसका structure prostaglandin नहीं होता. It is some synthetic molecule. Okay. If multiple options were given, then both are the correct answer. If multiple, then both are. If one option is asking, then go with Selexipag. Okay. So paper was tough. I think paper was tough, but I think most of the questions we have covered also, है ना? Okay. Any other question you can recall, or we can end our session? If it is multiple type, yes. Can you tell me other two option? बाकी के कोई दो ही ऑप्शन बता सकते हो क्या थे पीएच में? एक न्यूमोनिक पढ़ा था ना, पेप्सी कोका कोला, उन्हीं में से ही होगा कोई ना कोई। बोसेंटान था कुछ, रियोसी ग्वाट, बड़े अजीब अजीब से ड्रग है ना। सिल्डेनाफिल, टडालाफिल, है ना, ये सब ड्रग्स थे। ग्राफ वाला बेटा हो गया एसिटाइल कोलिन और फीजोस्टिग्मीन है। एसिटाइल कोलिन विद फीजोस्टिग्मीन, ग्राफ वाला डोज रिस्पॉन्स कर्व। एसिटाइल कोलिन के साथ आप बिथैनिकॉल भी लिख सकते हो, क्योंकि ये डायरेक्टली एक्टिंग ड्रग है, और फीजोस्टिग्मीन एंटी कोलिन एस्टरेस है, इनको डिग्रेड नहीं होने देता। तो एसिटाइल कोलिन विद फीजोस्टिग्मीन इज द बेस्ट आंसर है। ओके, बोसेंटान, बोसेंटान नहीं है, वो तो एंडोथेलिन वाला है। ठीक है, तो ये नहीं है, ये दो हो सकते हैं अगर मल्टीपल है। इलोप्रोस्ट इज एन एनालॉग बट इट विल स्टिमुलेट PGI2 रिसेप्टर ओनली, है ना। फेनेरिनॉन वी हैव डिस्कस्ड। ओके, सो आई थिंक दिस इज ऑल। और तो कोई क्वेश्चंस नहीं आए। एम्ब्रीसेंटान, ठीक है, एम्ब्रीसेंटान भी बोसेंटान का ही भाई है, ये भी आंसर नहीं है। ठीक है, तो आंसर इज सेलेक्सीपैग और इलोप्रोस्ट। हाउ टू डू दिस क्वेश्चन? रिमेंबर दिस क्वेश्चन ट्रिक्स थोड़ी बहुत पता होनी चाहिए। एंड रिमेंबर INI-CET फार्मा इज ऑलवेज टफ, पर ये ट्रिक्स हमने पढ़ी हैं कहीं ना, सेलेक्सीपैग, प्रोस्टाग्लैंडिन, इलोप्रोस्ट। So you have to apply a mind. Anemia with hyperthyroidism, tingling, option B6 and B12. Okay, antidote of benzodiazepine poisoning and methanol poisoning, ये भी था ऑप्शन में। बेंजोडाइस्पिन में तो फ्लूमाजेनिल हो गया आंसर, क्योंकि जेड वर्ड दोनों में आ रहा है। मीथेनॉल में फोमिपिजोल हो गया आंसर। दीज आर द एंटीडोट्स, है ना। लापाटेनिब वाला भी क्वेश्चन था। इपोप्रोस्टिनॉल, ओके, इपोप्रोस्टिनॉल भी भाई फिर यही है। मेनी स्टूडेंट्स आर टेलिंग मी इपोप्रोस्टिनॉल भी क्या है, प्रोस्टाग्लैंडिन I2 रिसेप्टर पे ही काम करता है। यस, इपोप्रोस्टिनॉल भी है। MDR TB ड्रग नाउ डेवलप्ड टिंगलिंग। ओके, जस्ट वन पॉइंट, वन क्वेश्चन। माइस्थीनिया वाला क्वेश्चन विल बी टेकन इन फिजियोलॉजी। आर्सेनिक पॉइजनिंग, ओके, आर्सेनिक पॉइजनिंग की भी एंटीडोट पूछी गई थी, ब्रिटिश एंटी ल्यूसाइट। ठीक है, पढ़ा था हमने। एनी अदर क्वेश्चन? ओके, आर्सेनिक की एंटीडोट थी ब्रिटिश एंटील्यूसाइट या फिर डाइमर कैप्रोल। ओके, एमडीआर टीबी का ड्रग, सो देर आर मेनी क्वेश्चंस इन फार्मा। तो एमडीआर टीबी का ड्रग, ओके, पेशेंट को क्या हो रहा है, टिंगलिंग वगैरह हो रही है या फिर पेरीफेरल न्यूरोपैथी हो रही है। तो बताओ बी पाल एम रेजिमेन में कौन सा ड्रग पेरीफेरल न्यूरोपैथी करता है, न्यूरोटॉक्सिक कौन सा ड्रग आपने पढ़ा है? यस, द आंसर इज एल, एल फॉर लेनेजोलिड। लेनेजोलिड से होता है पेरीफेरल न्यूरोपैथी। ठीक है, यस यस, आंसर इज लेनेजोलिड था आंसर। हाँ, लेनेजोलिड इज आंसर। ओपियोइड की भी एंटीडोट पूछी थी, पता है हमें, है ना, हमने पढ़ लिया। ओपियोइड की एंटीडोट हो गई नैलोक्सोन। तो ये तो हम टेबल बार बार पढ़ते ही रहते हैं। ठीक है, yes, we have covered sodium potassium question. Any other question which we have missed? So I think 20 to 25 questions have been asked in pharma. ठीक है, okay. So the answer of this question is linezolid. Peripheral neuropathy हो रही है। Isolated folate therapy causing neurological problem, biochemistry है ना, वही folate trap आप पढ़ लोगे, है ना। Yes, yes, कोबरा जी, you are absolutely right. लियोफ्लॉक्स ऑफफ्लॉक्सासिन नहीं करते, है ना, वो नहीं करते। मॉक्सीफ्लॉक्स वगैरह वो तो देते ही नहीं हम एमडीआरटीबी में। हम सिर्फ मॉक्सीफ्लॉक्स या लीवोफ्लॉक्स देते हैं। तो इनसे टेंडिनाइटिस वगैरह होता है, न्यूरोपैथी नहीं होता। ओके, सो आंसर आउट हियर इज दिस वन, इट इज नॉट लीवोफ्लॉक्सासिन। लीवोफ्लॉक्स आंसर नहीं है, लिनेजोलिड आंसर है इसका। लिनेजोलिड से न्यूरोपैथी होती है, ठीक है, लिनेजोलिड कॉजेस न्यूरोपैथी। आंसर आउट हियर इज लिनेजोलिड। लिनेजोलिड आंसर है, ठीक है। चलिए, आई थिंक वी कैन एंड आवर सेशन। So again, great gratitude to all of you students who have helped to help me and help our team to recall the questions. Thank you very much. For a moment, sit, relax, don't take any type of stress. थोड़ा अब आपका टाइम शुरू हो गया, थोड़ा रिलैक्स करो, जो होगा देखा जाएगा। ठीक है, तो बेस्ट विशेस, वी कैन एंड आवर सेशन नाउ।
A very big hello to all my dear students. So, how is the exam? And what about ophthalmology? I have got a few questions, the recall questions here. Let's discuss that one by one. So, coming to the first question, Krukenberg spindle is seen in which of the following conditions? I think this was a very, very simple and direct question. We all know there are two conditions where we have learnt what are Krukenberg spindles. We have learnt in the class that these are nothing but KPs. These KPs in pigmentary glaucoma are spindle shaped, and this is what is called Krukenberg spindle, right? Okay. Yeah. So, second condition was pseudo exfoliation. So, first of all, I needed to ask you all, was this given in the option or was it not given in the option? The pseudo exfoliation syndrome. Was it given in the option or not given in the option? So if it was given, even these both the conditions you can get Krukenberg spindles. But yes, here what you will answer is pigmentary glaucoma. Preferred answer would be pigmentary glaucoma. Okay, so this was not given. So if it was not given, even now what happens is the confusion is even removed now, na? No confusion. Okay? Then it becomes even a more simple question if this was not given. Yeah. Good. So this was question number one. I won't take much time here. I know you all are very drained. So this was discussed in the class, and we know what is pigmentary glaucoma, secondary open angle glaucoma, right? So all these things have been discussed. We come to the next question. The next question says, which of the following method is used to assess the visual acuity in pre-verbal children? Right? So if you take one by one, ETDRS chart, I don't know if this was the option. So ETDRS is okay. Closed angle glaucoma was another option. But if there is the mention of pigmentary glaucoma, Deepika, then it's we have to answer pigmentary glaucoma, isn't it? So that's a very straightforward option. Any other confusion in that previous question? Yeah. Multiple था? Okay. तो अगर मल्टीपल था तो क्रुकेनबर्ग स्पिंडल सूडो एक्सफोलिएशन सिंड्रोम में भी होता है और आपके पिगमेंटरी ग्लोकोमा में भी होता है। तो ये दोनों कौन से ग्लोकोमा हुए? सेकेंडरी ओपन एंगल ग्लोकोमा हुए ना, क्लोज एंगल तो भी नहीं हुआ ना। दे आर व्हाट? सेकेंडरी ओपन एंगल ग्लोकोमा। ठीक है। अच्छा, ये मल्टीपल नहीं था। अच्छा, सेकंड वन ये वाला प्री वर्बल वाला मल्टीपल, ठीक है, गॉट इट। सो ये जो मल्टीपल था, आप खुद सोचो, प्री वर्बल में हम लोग ने क्या पढ़ा हुआ है क्लास में कि इन्फेंट्स के लिए कैसे-कैसे हम लोग टेस्ट कर सकते हैं। वी कैन गो फॉर प्रेफरेंशियल acuity test. We can do acuity preferential acuity test. You have learned with me your Teller's card and Keeler's card chart and Teller's chart and Keeler's cards. Yes. Then Cardiff acuity test, isn't it? So this has been taken in the class C. This was the Cardiff acuity where the different shapes are engraved in a cardboard and the patient has to see. So if the child is small, it acts as a preferential looking test. And otherwise, in older children also we do it where the child will tell what he's looking at, whether it is a fish or a house, etc. Isn't it? So what should have been the answer for the multiple? I think both Cardiff acuity and optokinetic nystagmus. टेलर था ऑप्शन में, अगर टेलर था तो वो भी आएगा। टेलर कीलर सब आएगा। टेलर चार्ट, कीलर चार्ट, ये सारे आप यूज कर सकते हो अंडर प्रेफरेंशियल एक्विटी। दूसरा हम ऑप्टिको काइनेटिक ड्रम करते हैं और तीसरा हम लोग विजुअल इवोक पोटेंशियल से देख सकते हैं। इजंट इट? वी कैन सी थ्रू व्हाट इज विजुअल इवोक पोटेंशियल, वी नो दैट। या एक्टिविटी फ्रॉम गैंग्लियन सेल लेयर टू विजुअल कॉर्टेक्स। So not Cardiff. So if Cardiff was not there, Teller was there, even then our answer will be both optokinetic nystagmus as well as Teller card. Is that clear? Okay, so Teller chart and optokinetic nystagmus. Okay, we will modify this. Final हम लोग जब upload करेंगे आपका recall, we will take care that we replace it with Teller chart. Everybody is agreeing to this? Okay. Even then, what is the answer? I think you all are clear. Teller chart with optico-kinetic reflex. Nystagmus. ठीक है ना? चलो next पढ़ो. What is the next question? And how have you answered this? A 30-year-old contact lens wearer presenting with severe pain, redness, and watery discharge. I don't know whether this line was given or not. I'm not very sure. Was this line given? Acanthamoeba keratitis is suspected? All of you, answer me. Was this line given? No, it was not given. I was almost sure that this statement may not be the part of the question. Okay, so even if this is not, was it an image-based question? Okay, it was an image-based. So image was what? Was it a ring lesion? Okay, so can you all describe a little bit about the image? Was it a ring lesion or was it a ring lesion with some abscess formation? See, I'll tell you how we have to think with this question. A most common infection in a contact lens user is Pseudomonas. Okay, so it will all depend on what type of image you all got, whether it was more towards acanthamoeba or it was more towards Pseudomonas. Number one, right? If it was, we know what will be the answer. For Pseudomonas, it will be gram stain. If it is acanthamoeba, then we have to answer your calcofluor white. Now coming to, if the description was this watery discharge and severe pain, it goes more towards acanthamoeba, isn't it? So ring shape opacification was given, then definitely it is acanthamoeba. So actually in a Pseudomonas or a bacterial keratitis, you will not get watery discharge. That is another point to be taken if it was a watery discharge. So it will all depend. So in this question, if watery discharge particularly was given, image had a ring lesion, we will answer according to acanthamoeba keratitis. If it was not watery discharge and the image was towards a bacterial keratitis, then we have to answer according to Pseudomonas. Yeah, true. Yes, exactly. So these were exact options. I just meant a general bacterial keratitis, right? So it was an acanthamoeba ring. Then we have to answer as calcofluor white, right? So this is clear now. So everybody is saying it was acanthamoeba ring. So if it was a ring lesion, then we should answer your calcofluor white, right? Okay. So this is done. Okay, the timeline was mentioned. We will add this. It was after 2 weeks. Everybody agrees to this? It was written after 2 weeks. Right. Okay, modified grams. Okay. So again, it will all depend on the image and the presentation that was mentioned there. Because severe pain can be, because we have learned this in acanthamoeba, pain is disproportionately much larger. If your question said severe pain, if the question says watery discharge, and if the image had a ring lesion, we will answer calcofluor white, right? Yeah. Okay. Pseudomonas is a very acute infection. Do you know now? We have learned this, that which organism can actually even cause corneal perforation within 48 hours. It is pseudo. So it's more acute. Right? Okay. Can we go to the next one? Yeah. So we have discussed all about your acanthamoeba, but most common infection being Pseudomonas. Everything has been taken in the class. Right? So calcofluor white should be the answer of this question. Okay. We next talk about is this question. Again, tell me whether the question recall is correct or not. What I have got is that there is a young myopic patient. He is with astigmatism. So myopia with astigmatism is suddenly presenting with pain, watering, and marked loss of vision. And there are previous reports showing frequent change of spectacles. I hope this was there in the question. Visual acuity is reduced to perception of light. Slit lamp image is shown below. What is the most appropriate management? Okay. So, okay. So options I think are not correct here. Okay, with repeated rubbing of the eyes. Right. And so there is repeated rubbing of the eyes, history of that. Was there history of frequent change of spectacles? So spectacle change and rubbing is all going towards keratoconus. Everybody agrees with that? Okay. So if there is spectacle change with if the diagnosis is going towards keratoconus, what is the condition where suddenly the patient of keratoconus starts presenting with pain, redness, and sudden drop of vision? It has to be acute eye drops, too much of stretching, break in the Descemet's membrane, leading to all corneal edema. Is it not? Right? Okay, so these interventions, can you all see, are these were the options, or you want to change a few of them? So SF6 is mainly a vitreous substitute, so it will not play any role out here, all of you, right? Okay, keyboard user, tell me one thing. Was the history that we are mentioning in this question the exact this history that a patient who is myopia with astigmatism, one of you are saying continuous rubbing of the eyes, then you are also telling about frequent change of spectacles, right? And suddenly drop of vision, isn't it? T3F8 was given as option. History is correct. Okay. Exact history given now. Okay, okay. So if the history is almost correct, that means shouldn't we be thinking in terms of keratoconus? So C3F8 are again vitreous substitutes, right? So I don't think this must be the image then if they're asking you about the different names of the different gases and all. Post procedure picture was given. Okay. Okay, so if the procedure, okay, so if you all are saying that the image was given, which was the image was after doing the procedure, right? So that means they have not asked you about these options are not correct. DALK was the option one of you are saying. I think this question is totally not recalled properly. So keratoconus, how will immediate management of any acute eye drops would be medical management, followed by if there is any opacity formation, then you have to replace this cornea with the donor cornea. That is, we have to go for corneal transplantation. Now, there are two options in keratoconus. Either I do DALK or I go for penetrating keratoplasty. Now, what options I have got? According to that, I have only PK. Okay, post-procedure picture was given. So we can, if the post-procedure picture was given, PK was not in an option. Okay, so PK was not the option. Was DALK or DELK? Which was it? Was it deep endothelial lamellar keratoplasty or deep anterior lamellar keratoplasty? DALK was there. So they are asking you about the management, na? But they are asking you what is the most appropriate management, isn't it? Was this the question? Okay. So, Sayana, if this was the option, then we should be answering DALK, isn't it? Sudden drop of vision means this patient has gone into hydrops. First, you will manage it medically, and then if the opacity is formed, then we have to replace this, isn't it? So the two things that we can do is either we go for deep anterior lamellar keratoplasty or we go for penetrating keratoplasty, right? Okay, okay. So post procedure picture. Okay, so it was a post C3. I think there's a lot of confusion in this question. We will again reframe it and come back to you all in our final version, right? Because mm, some of you are saying it was, yeah. Okay, so what was the procedure that was done and the image was given, right? So we are going to first look at the image and then only we can answer this question here. Can you all just DM me the question again with the image? We will discuss it in our final video. Let's not waste the time. So this was all discussed in astigmatism about the different modes of treatment and about C3R. We know what is C3R, collagen cross-linking with riboflavin. This we know so well. So, but okay, I got this, what you are saying. So some gas was injected. There was an image given to you all, right? And they were asking you about the procedure. No, the history will is not suggesting about retinal detachment here, please. So we won't be thinking in that terms, right? Was this a question on retinal detachment? Is history se to nahi, where the history of rubbing with frequent change of spectacles. Okay, so retinal detachment will present with something more. Of course, if he's a high myope, we may think in terms of that, but the history here is not indicating so, isn't it? Okay, please send this question again. We'll come back to this question. Yeah. Next, I think this was a straightforward. There is no problem in this one. A 60-year-old patient, sudden onset of severe ocular pain, headache, nausea, vomiting, blurred vision, isn't it? With a mid-dilated pupil and steamy-looking cornea. So we all know this, that any mid-dilated pupil, corneal edema, we are talking about your, with the pressures of 60 millimeters of mercury, this is acute angle closure, acute primary angle closure, which is also called acute congestive glaucoma, isn't it? Acha. Okay, Alicia. Got it. So it must be the gas insufflation. The picture must be that only then. Okay. Right. So we will come with a final version of that question. I got it, what you're saying. Right. So here, because the options are still very confusing, so we will come back to that question. We are not able to land up anywhere now. What about this question, all of you? So the last, this was the one, APAC. Yes, it is simple. So it's an acute angle closure glaucoma. Please DM me this question, whatever you all remember, this previous one. We will come back to this again. And all of you, any other question apart from this asked in ophthalmology? Do you all remember something else we can discuss here? Yes, yes. We are leaving the questions which are not clear. Don't worry so much. Okay. Okay. Yes. So we'll come back to this in the final vote. Intracameral C3. Okay. One of the option was neovascular. Right. Still our answer remains the same. I hope you all know this. Even if the option here was neovascular glaucoma. Right? Okay. Any other question apart from the ones that we have discussed? Do you all want to share something more? Any other of the question? No? Done? Okay, so there was a question on retinoblastoma. Okay. What was the question? Any idea? Can you remember something? Retinoblastoma is obviously a very, very important topic. Okay, Vaibhav, I will have a look at it. Thank you so much. Retinoblastoma history, it was always unilateral. Okay, so if you all can let me know what question was there. Okay, correct about RB gene. Okay. So what was the main options? RB gene located at 13q14? No, it's not always unilateral. We all know that. It can be bilateral. Most commonly though it is, but we all know this. Acha, multiple statements about the gene. Yes. Okay. Okay, so that unilateral option was wrong. Okay. It doesn't even seem to me like a off-the question. Okay. Right. So, pathology question. Yeah. So this doesn't look like an off-the question at all. Yeah. Okay, mastermind. Thank you. Any other question? I think this will be in detail, should be discussed in pathology. But yes, not always unilateral should be the answer of this question. Multiple choice था. अच्छा, ठीक है. Okay. Any other question from ophthalmology that you all remember and want to discuss? Krukenberg spindle traveler, we have done that. That was our first discussion. The answer is pigmentary glaucoma. Visual field effects, occipital lobe. Do you mean to say this? Yeah. Recall is not in our hand, Viche. Bad or good, it all depends on you all, na? So whatever we have got, we're trying to put it as close as possible. Okay, I'll see into this visual look thing and come back to you all in my next final video discussion. Again, doesn't seem to be too much of, yeah. Okay, okay. Yeah. Right. So if you remember further questions, just DM me. We will discuss it. We'll wait for 1 or 2 days before we are discussing again with the final version of all the recall questions here. Right? Great. Thank you so much. Thank you.
side.
Hello. Hello, guys. Am I audible and visible clearly? Just give me a thumbs up sign. This is Dr. Jambukeshwaran. Yes. Good evening, sir. Priya. Okay. Yes. Okay. Hi, sir. Kevin. Okay. Chaudhary Singh. Okay. Okay. Right. So, dear guys. Okay. Dear guys, we have in ortho 5 questions. All are straightforward questions, and I think you would have already rocked. Okay. So just we'll move on straight. I'll finish in 5 minutes. We'll move on to the very first question. A 7-year-old boy presented to the emergency department after falling on outstretched hand. X-ray shows this is the catch. Extension type of supracondylar fracture. Okay. Extension type of supracondylar fracture. On examination, he's unable to make an O sign. O sign is this. Okay. With his index finger and thumb. When he is not, this is because of opponent's policies. You know that this perfect O, if you are not able to make, it says that one nerve is gone. Ulnar nerve, median nerve, brachial artery, radial nerve. The answer is very straightforward. All of you would have answered. And here the clue is there, extension type of supracondylar fracture. It should be median nerve. The answer should be median nerve. Okay. Yes. Okay. So have you answered this? Anybody just give me a yes or no. Just hello. Can you please, somebody? Yes. Good. Okay. Yes. Kevin Sangma. Yes. Good. Right. So median nerve answers because extension type, the most common nerve that is involved, all are there in our main recording and in our YouTube sessions. The extension type, the most common nerve that is involved is median nerve, that too anterior interosseous branch of median. That is the correct thing. Okay. If instead of extension, they had given flexion type, it's a very tough question. The answer is different. It should be ulnar nerve. So for this, the right answer is median nerve. We'll move on to the next question. A 60-year-old man presents with generalized bone pain and easy fatigability. X-ray shows diffuse osteoporosis. There is hypercalcemia. Which of the following investigation is most appropriate to confirm the diagnosis? That's the question. Okay. So, a 60-year-old generalized bone pain, easy fatigability, X-ray shows diffuse osteoporosis. There is hypercalcemia. It should be hyperparathyroidism. It should be hyperparathyroidism. Okay. So, hyperparathyroidism, I don't know whether this is purely an ortho question or surgery-based ortho question, but we know the answer. The answer is there. In the choice, we know, yes, Priya has given the answer. MedTube has given the answer. Okay. Hypophosphatemia will be there. Yes. Okay. Hypophosphatemia is there mentioned. Okay. Let it be. The answer is hyperparathyroidism. We all know the specific scan for hyperparathyroidism is your Sestanabi scan. This is a nuclear medicine scan which uses technetium 99. Okay, which uses technetium 99. This is the most appropriate scan to look for parathyroid pathology. We all know it will locate parathyroid adenoma. And we had seen in our videos, the most common cause is parathyroid adenoma. So that is the right answer without controversy. Okay, excellent. Okay, yes. PET scan was in the option. Vishnu Singh is telling that, okay, you add here PET scan, then PET scan is also not the answer because PET scan is not Sestanabi scan. That is positron emission tomography. That is a different scan. Okay. So PET scan, even though if it is an option, that is not the answer. If Sestanabi scan is there in the option, that is the best answer. We will move on to the third question. Okay. Yes. A 13-year-old boy presents with waxing and waning of symptom pain with swelling over the mid shaft. This is the mid shaft of the humerus. That means it is a diaphyseal lesion. It's a diaphyseal lesion. For 3 weeks, there is no history of trauma. X-ray shows periosteal reaction with suggestion of medullary involvement. What is the next best? So first of all, you should think of 1 or 2 differential diagnoses. It is in diaphysis, the age is 13, it can be Ewing's. It can be Ewing's because periosteal reaction is there. It can be Ewing's. Okay. If at all not, if they had not given periosteal reaction in the choice, only medullary involvement and nidus is there, it could be osteoid osteoma. Okay, it can be osteoma. Whatever it is, the 4 choices are there. Best thing, confirmatory, the best thing is doing a biopsy. Doing a biopsy. Biopsy is going to give us what is the thing, whether it is a benign tumor or malignant tumor. Even if you suspect infection, biopsy is going to give. So without controversy, the right answer should be biopsy. ESR was elevated. Yes, ESR will be elevated in Ewing's also, in osteomyelitis also. Okay, ESR is elevated. So good. Next best step. Why not MRI? You are asking. Okay. Why not MRI? You are asking. See, MRI again cannot clinch the diagnosis. Again, it cannot clinch the diagnosis. Okay, that's why. Okay, because in this question, the thing what PrepLadder, the question paper which given few students have answered next best investigation. Few students have said confirmatory test. Okay, confirmatory test. This is the point. If the answer is confirmatory, then we have to go for biopsy. Okay. Yes. Right. Okay. So confirmatory, it should be biopsy. Next best step. What is the thing? Yes. Okay. So Jadhav has answered. Yeah. Okay. Jadhav has answered A. Right. Okay. Right. Good. Okay. Good. Excellent. Oh, in radio recall. Okay. In radio recall, she said, okay, next best step. If it is next best step, you can go for MRI, man. Confirmatory is the question. The answer should be biopsy. Right. We'll move on to the next question. A 30-year-old man presents with history of fall. He complains of severe shoulder pain and inability to move his arm. On examination, the arm is slightly abducted and externally rotated. X-ray is given below. Obviously, this X-ray shows the head has slipped out of the socket and it is lying in front of the glenoid cavity. And moreover, the question also substantiate the point. It's slightly externally rotated. So it should be a case of anterior dislocation shoulder. There is no doubt. If it is posterior, yeah, many of you have answered well. Excellent, man. Farhana has answered. Jadhav has answered. Excellent. Fall on outstretched hand is the, yes, shoulder dislocation. It is fall on outstretched hand is the mechanism. Good. Okay. If the arm is internally rotated, otherwise, if they had mentioned something like this, for example, glenoid cavity is here. The head is lying very separately like this. And it shows a light bulb sign. It is light bulb sign. Then it will be posterior shoulder dislocation. If it is a light bulb sign, it should be posterior shoulder dislocation. If the X-ray is like this is a sure case of anterior shoulder dislocation. Mechanism of injury is push only. Priya, it is only push. Fall on outstretched hand is the mechanism. Fall on outstretched hand in arm in extended, abducted, externally rotated. Everything is there in our video. Okay, we'll move on to the next question. Match the following. They had asked a question. Yes. Okay, match the following type of question. What is equinus, planus, cavus, calcaneus? Okay, so equinus means foot in plantar flexion. Equinus means foot in the plantar flexion, like this equinus. Planus means longitudinal arch is flattened. Cavus means the longitudinal arch of the foot is extended dorsally. Calcaneus means foot in dorsiflexion. Okay, that's all. Very simple. Okay, that's all. Whatever choice they had given, yes. So that completes our session, dear guys and girls. Hope all of you, seeing your answer, most of you have done excellently well. Okay, All the best, guys. Thank you so much.
Sir, is it done?
Yeah, done.
Okay, sir. Thank you.
Thank you.
नेहा मैम को यार चुप ना 1 मिनट यार Sir, you can leave the meeting, sir. Thank you so much.
Thank you. Thank you. Yeah.
Sir, you can leave the meeting, sir. Thank you so much.
Thank you. Thank you.
हेलो
Hi, ma'am.
हेलो सर चलेगा अब मुझे क्या करना है शेयर
Share screen से
शेयर स्क्रीन तो दिख ही नहीं रहा है
नीचे आ रहा होगा ना ऑप्शन मैम जहाँ म्यूट करते हैं
वीडियो पार्टिसिपेंट चैट रिएक्ट मोर लीव
शेयर स्क्रीन आ रहा होगा मैम
नहीं आ रहा Hi everybody. So welcome back and I hope you had a good time giving your exams today. So let us quickly have a look at, without taking too much of your time, let us quickly have a look at your PSM questions that came. I must say PSM was a little tricky this time, starting with the first question that we have. So let's go to the first question, everybody. As you can see over here, am I audible and visible? Everybody, can you all hear me? Am I audible and visible, everybody? Okay, so the first question that you can see over here was, in a population of 500 people, 20 new cases of a disease were reported over 2 years. The total person time observed were 950 person years. Calculate the incidence rate of the disease. Okay, so over here what it was that you have to find the incidence rate. Now I have straight away given you how we can go about calculating. Please don't get confused regarding this 950 thing. Okay, regarding this 950% per year, you all know what is the formula for incidence. Incidence is always number of new cases out of the total population at risk into 1000. Okay, so over here, if you see, if you check the incidence rate, okay, it is number of new cases of a disease upon total person time at risk. Total population at risk होता है ना, यहाँ पे the total person time at risk was 950 person years. Okay, so all you have to do is, that means 950 people are being followed for 1 year, 950 person years. So this comes out to be 0.020 upon 950, 0.02 cases per person per year. But here, if you look at your options, everybody, we have not been given in terms of 0.02. If you look at your options, 0.02 kahin pe bhi nahi tha. Okay, so you have to express it in terms of per 100, or you have to express it in terms of per 1000. तो जब आप इसको per 100 या per 1000 के लिए express करोगे, all you need to do is you have to multiply it with 100 or 1000. Now, if you do 0.02 per 100 into 100, that would be 2.1 per 100. But per 1000, it would have been 21.1 per 1000. So if you look at the options over here, this is incorrect. It would have been 21.1 per 1000. So what is the correct answer over here? 2.1 per 100 person years. Okay. Yeah, so this is what the question we received. In case you have some other version of the question, you're free to send it to us and we will put it out exactly in the accurate form. Okay. Now, this was a pretty easy question, everybody. I will come back to this question once again. Let me just discuss the remaining one. What did you do for this? Now, you know, whenever we teach in the classes or on the app, anywhere that you see, we always say particulate matter, the most dangerous size is always inhaled is a particular size. Okay, up 2.5 micron jo hota hai, where does it go? It goes and sticks to the alveoli. Agar it is 5 and beyond, they are seen in the bronchioles. Here it is 2.5. So 2.5 ka answer kya tha? Alveoli. Did you all mark this? Give me a thumbs up. This was a good conceptual question. Why is it harmful to health? Because now p-value interpretation. Kisne kiya ye wala sawal? Ye sawal it was beautifully framed. We always do the interpretation of p-value in the exam. Now, I'm not in the videos. I'm not sure of all the options, but we have tried to get closer to the option, guys, but you absolutely don't have to worry. If you think the question was asked in some other way or the option was asked in some other way, you're free to message and we will get it this thing. But agar aisa tha, so dekho, p-value less than 0.05 का मतलब क्या होता है? P-value less than 0.05 was statistically significant. Okay, statistically significant. इसका मतलब ये होता है. So over here the result is significant, statistically significant. Now that means this is out of the box. Even if it says option C was clinically significant, that is also over here, not very accurate. We are looking at statistical values. Okay, so over here this is out. Now what is p-value, guys? P-value is the chance of committing a type 1 error. Probability of committing a type 1 error. एक बार देखो, probability of committing a type 1 error. Now, what do you mean by type 1 error? Type 1 error मतलब होता है null hypothesis is true but rejected. Okay, that's a type 1 error. That means that there is no difference in reality. Your drug is not good, but you have shown your drug to be good. But over here, when the value is below 0.05, that means over here it is 0.03. That means we are rejecting a true H0, guys, 3 out of 100 times. Now, if I do my study 100 times, I'm rejecting a true null hypothesis 3 baar. Now, if I reject my true null hypothesis 3 out of 100 times, I might be doing it by chance. Okay, so this is by chance. The 3% probability that the result has occurred due to chance. 97 times the result is statistically significant. Statistically significant ka matlab hota hai favors alternate hypothesis, and that's what we are showing. That means the new drug is good. So over here, your answer is there is a 3% probability that the result has occurred due to chance. 97% confidence that the null hypothesis is true. No, we are 97% confident that the new drug is good, and we have shown that only. The null hypothesis is rejected as the probability of chance is less than 2%. No, since it's given 0.03, the probability of chance is less than 3%. Yeah, everybody, simple sa question tha, not to be worried too much about this question. You just have to do the interpretation of the p-value. Now, what did you do for this one? Again, p-value discussed in biostats. We have discussed Bradford-Hill criteria also in epidemiology, guys. So what was your answer over here? Which of the following is not a component of Bradford-Hill criteria for causation? Anyone? What did you mark for this, everybody? What did you mark for this, guys? Yeah, what did you mark for this, everybody? What was your answer? So which is not a causation of which is not a component of Bradford Hill? So we all know very good the Bradford Hill sensitivity iska nahi tha. Acha, even if these weren't the options, guys, देखो temporality, dose response, biological plausibility ये तो Bradford Hill होते हैं. Sensitivity is not a Bradford Hill criteria. Instead, it is specificity. It is a direct theoretical question. So we're not getting too much into detail, and this we have always discussed in EPID. Come to the next one. Did you have a question like this? A question I would say from pharma also, in a patient co-infected with TB and HIV. What is the gap that we had to do? So this is a repeated question. Again, it keeps coming most of the time. So what you have to do, you have to start ATT first, then ERT 2 weeks later. So over here, start ERT 2 weeks after initiating ATT. What is the this thing? Prevent immune reconstitution syndrome. Okay, so we'll move ahead. What did you do for this? Now, did you discuss this? I hope this will, again, I think will be discussed in some other subject also, but aise batao, a previously vaccinated healthcare worker sustains a needle stick injury from a hepatitis B surface antigen positive patient. Healthcare worker is a known non-responder. What is the next step in the management? Now, I am going to just give you the management. Please have a look at this slide. This is how we do the management, and this is the guideline that is followed. I have given you a detailed management. You just have to know this. Previously vaccinated responder. When we mean responder, that means in our body antibodies are formed. So more than 10. Okay. Source patient ka HBs AG positive hai. So if we are vaccinated and we are responders with anti-HBs more than 10, no treatment needed. But if previously vaccinated, unknown response, we don't know about the values right now. HBs AG positive se hi prick hua hai, we will test anti-HBs less than 10. If it is less than 10, we will treat as non-responder. But if previously vaccinated, non-responder matlab even after 2 full series of vaccination, you all know hepatitis B vaccine dete hain 0, 1 and 6 months. Okay. Now 2 full series means we have taken 6 doses. 2 times it has been done. Still the anti-HBs is below 10. And the source of patient was HBs AG positive. In this, 2 doses of immunoglobulin has to be taken, one now and one after 1 month. You don't need to give any further vaccine because already it's a case of non-responder. But if it was unvaccinated or incompletely vaccinated, status is HBs AG positive, then of course we have to give immunoglobulin 1 dose, and since he's unvaccinated or incompletely, start vaccine series immediately. So if you follow this, it was a case of HBs AG positive patient tha, vaccinated person tha, but non-responder tha. So we are going to give 2 doses of hepatitis B immunoglobulin, one immediately and another one after 4 weeks. No hepatitis B vaccination required because he's as it is a non-responder. Is it clear? So this is what this is a question, because यहाँ पे it's written he was previously vaccinated. Okay, previously vaccinated likha hua hai. So all you have to do is follow this guideline, guys, and that's what is your answer. Okay, according to NP-NCD, which out of the following screening are done? I think it was a multiple choice question. You had multiple answers for this. So let me tell you one by one. Now it is according to NCD program, right? So NCD program, if you check out the notes as well and your videos as well, we have said cervical cancer screening is under the program, is being done by VIA, sub-center maybe, PHC maybe. Okay? Oral cancer के लिए visual inspection है. Some of you mentioned, ma'am, staining was also written. So staining for high risk cases we are doing. That's okay. Screening starts beyond 30 years. Yes, at primary level it is not mammography. If you check out the notes, like over here, A, B, D are correct. Okay, A, B, D are correct. Now, if you check out the video or the app or the notes also, we have said that at primary level, subcenter, PHC level, screening breast cancer का कैसे होता है? There at primary level, it is being done by breast self-examination. It is not being done by mammography. So were you able to answer this, everybody? These are simply conceptual based questions. They have been touched in the program. Here the buzzword was primary, although mammography is the screening test of choice for breast cancer, but not at primary level. Okay? Hello, any other question? Yeah, we have two or more, I think. Something like this came to us. Which of the following represent the role of the family beyond reproduction? So it is again family beyond, what is the role of a family? So beyond reproduction, they said, select all that applies. So they provide support during illness, influence cultural and health related behavior, provide emotional and financial security. Regulate sexual reproduction, sexual behavior and reproduction only? No. Over here, beyond reproduction, A, B, D are correct. Okay. Now, this is what we received the question. If it was asked in any other manner, you can always feel free to message us, guys. ये understanding में भी था. This is roles of family beyond reproduction. Okay, beyond reproduction. You just have to imagine your family beyond reproduction. What are the support that the family offers? Okay. All right, going to one more question, Niti Aayog Health Index. Now, Niti Aayog Health Index, Niti Aayog mein discussed hai. Select all that apply. So, Niti Aayog, everybody has given a health index, okay, जिसमें हम लोग states and UTs को compare करते हैं based on high risk state, medium and this thing. Okay, so over here it helps evaluate and compare the performance of state health program. This is correct. It encourages healthy competition among states. Of course, it supports policy formulation. Yes. It is used for government hospital evaluation only. No, it is also used for other healthcare settings. It is also used for other healthcare settings. So I'm not very sure if this exactly were the terms, but if this was A, B, D are correct. Okay, A, B, D are correct. B, it encourages healthy competition. It is like we have to score. See, Niti Aayog ranks, ranking जहाँ होती है वो competition ही होता है ना? जहाँ पे भी तुम rank दे रहे हो, it is like a competition. So it's ranking states and UTs according to the health performance. 21 largest states, 8 smaller states, 7 UTs, और यहाँ पे 3 domain है, like you can see. But of course, we're doing a ranking. Okay, if it was not multiple choice, that's okay. अगर एक choice में भी था, it is used for performance of state health programs. Like it's for ranking of states. Suppose if it had one single correct answer, so you can let me know the option. Ranking of states कर दो. ठीक है? As I have already written over here, it measures national health performance by ranking of states. So you can go by this option if you have to select one best. ठीक है? Now is it okay? All right, ranking of states. So this is what is the answer. All right, so these are the questions that we got for PSM as of now. You're free to please message us with any other questions that you get. We will get back to you with a detailed discussion on the app. Thank you so much, guys. I hope you had a wonderful day today. Relax and don't be very harsh on yourself. All right, so we'll see you again. Please stay connected for the other recall sessions. Thank you so much. Bye-bye. Have a good day.
live में.
Hello students, welcome to this recall session and I hope your paper went well. As far as dermatology questions are concerned, they were quite easy, I guess, and almost all of them we had discussed in our LRR or our last FMG champion exam. So give me some thumbs up. How was the exam? Tell me about it. And remember, this is a recall session, so I may not give you the exact question or the options, and that is why this recall session is there. Help me out framing the correct questions and correct options. Just chill, relax. We are just discussing it. It may not be the exact question. So if you have marked it wrong, it doesn't matter. You've done your best, and I'm sure you'll get good marks. So give me some inputs on how was dermatology as a paper. How did you find the questions? Are you able to hear me? Are you able to see me? Okay, so I will proceed with the paper and I'll wait for your inputs on about the questions or their options. So the first question which I have is the given lesion is seen on 3 different occasions on the same site. What is the diagnosis? So what do I see here? I see a lichenoid kind of a lesion which has a purplish hue, which is surrounded by erythema, some edema, and it is said that the lesion is recurrent and occurring at the same site. Okay, so tough exam. Don't worry, you'll do well. So yes, I think this is the correct option and the correct question, as most of you are giving me the correct answer. Yes, the answer would be fixed drug eruption. There is no confusion here. Whenever they say a lesion which is recurrent, occurring at the same site, whether they have given you a history of some drug intake or not, it doesn't matter. This is fixed drug eruption because none of the other options happen at the same site. So they may be recurrent, but they're not occurring at the same site. Fixed drug eruption is due to drug and always happen at the same site. And this picture, which I put, probably it was the same picture, was the exact image which you see in FDE. Right, same site nahi tha. Okay, so what was there? Was it like a drug which was given? But it was written that it was recurrent, so you can help me out with the correct options, right? I'll move on to the next question by then. A farmer comes to the OPD with the following lesion. Now, we have repeatedly specified that subcutaneous fungal infection is something which is coming every time in all the exams, either sporotrichosis or mycetoma. And so this has become a very, very important topic, and it is here as well. So a farmer comes to the OPD with the following lesion, and the discharge shows black colored granules. So what is the causative agent? So here, it is not the diagnosis that they are seeking. We all know that this is a subcutaneous fungal infection called as mycetoma. But we have also studied that mycetoma can be eumycetoma or actinomycetoma. Eumycetoma is what is caused by fungus and actinomycetoma is what is caused by bacteria. Now, I have told you that easy way to differentiate between these two categories is the color of the granules. So, black color granules, if you have seen, so black colored granules are a feature of eumycetoma or a mycetoma, which is caused by a fungus. So in the options which have been provided to me, Madurella mycetomatis, Actinomadura madurae, Nocardia, Streptomyces, the option A, which is Madurella mycetomatis, is the correct option if it was this question, this option, because this is a fungus which causes eumycetoma and it produces black colored granules. Actinomycetoma, you would usually see red colored granules, right? So yes, you all giving me the same answer, and I hope this was the question and the image. So in case of any discrepancy, I would wait for your inputs. Wonderful. So this is mycetoma, eumycetoma. Eumycetoma is caused by Madurella mycetomatis. That's the most common organism. And the hint to the diagnosis is black colored granules here, right? So even in the question, if there was discharging sinus, we know mycetoma presents with discharging sinuses, and it is from these sinuses that these granules come out, right? Image looked like botryomycosis. But okay, but was there, but if it said black colored granules, I don't think so. Botryomycosis would have been the image like. So black colored granules we know are a feature of mycetoma, correct? I'll move on to the next question. Most common site of melanoma in Indians. Now, again, repeatedly, skin tumors are becoming a part of the question. So, melanoma we have studied that is usually not seen in Indian population, but there are two special types of melanoma that we have discussed, which is acral melanoma and subungual melanoma is something that you see commonly in Indian population. In fact, these two categories of melanoma has been more commonly defined for Asian and Indian origin people. So most common site of melanoma that you see in India is acral site, and so hands and feet should be the correct answer here, right? Yes, malignant melanoma or melanoma, that is correct. And hands and feet should be the correct answer because acral melanoma, which is seen on hands and feet, is the most common type of malignant melanoma that you see in Indians. Okay. So I assume that this was what the question was asking about since you are giving me the similar inputs. So I'll move on to the next question. Which of the following is not a syndromic management in males? So in STDs and STIs, we have talked about syndromic management. We have discussed various kits and you know about various kits. Now the question was a little twisted. They have just asked you that which of these syndromic management protocols are not used in males. So again, a very clear cut, even if you have not studied the syndromic management, if you look at the options, obviously males urethral discharge or genital discharge would be there. So genital discharge is same as urethral discharge, just that we cover urethral and cervical discharge. Inguinal swelling or buboes are a part of syndromic management. Lower abdominal pain is also a part of syndromic management, but lower abdominal pain is associated with pelvic inflammatory disease, which is seen in females. So this is in females and not in males. So lower abdominal pain protocol of syndromic management is not used for males. So it was more of a logical question rather than something that you needed to memorize. Yes, so again, you've all done it well and you're all giving me similar answers. So I hope this was the correct question. So lower abdominal pain is not for males, it is for females because it caters to pelvic inflammatory disease. But in the other options, were these the similar options, urethral discharge or genital discharge? I was thinking that probably I'll have a different option here. So inguinal swelling, urethral discharge, and genital ulcer maybe. But if you guys do not have any inputs, we'll move on to the next question now. Now, this is something I would say was a little difficult one for you. And but let's figure this out. A 73-year-old female complains of intense itching and white plaque in the genital area. Now, intense itching, white plaque, if I look at the options here, I can just rule out lichen planus, but rest three options can present with itching and with white plaque. But usually leukoplakia does not have intense itching. So I can rule this also out. So no intense itching in leukoplakia and lichen planus does not present with white plaque. Now I'm left with two options. Now if I look at the histopathology, it is showing loss of rete ridges, abundant collagen, and thinned out epithelium. Now, this histopathology is a feature of lichen sclerosis. Absent rete ridges was given, or yeah, so this is loss of rete ridges, chronic candidiasis. So, chronic candidiasis or candidiasis does not matter. Vulvar intraepithelial neoplasia or vulval leukoplakia would fit in here. So, parchment-like skin, if it is mentioned again, parchment-like skin means thinned out skin. Now, loss of rete ridges also means thinned out skin. Abundant collagens means thickening of the subepidermal tissue. So, there is thinning of the epidermis with thickening of the subepidermal tissue, which is a feature of lichen sclerosis. So there is something called as lichen sclerosis, which comes in the same spectrum as morphea. These are a group of connective tissue disorder in which you see loss of rete ridges, epidermal thinning, abundance of collagen, and lichen sclerosis in vaginal area presence with whitish plaques, with intense itching, with atrophy of the skin. So I agree this was a little difficult question here, but I think some of you are giving me the correct answer. At least you can rule out the other options. Even if you did not know about lichen sclerosis, lichen planus, no white plaque, vulval leukoplakia or vulval intraepithelial neoplasia, usually no intense itching. Candidiasis will not show this histopathology. You know that fungus does not show this abundant collagen or thinning of rete ridges. So even as diagnosis of exclusion, lichen sclerosis would fit in as my best answer here, right? Wonderful. Now, next, another question on fungal infection and especially pertaining to subcutaneous fungal infection. Which of the following is not caused by thorn prick? And here I have been given different options, all of which are fungal infection. But what is the difference? Chromoblastomycosis, porotrichosis, and eumycetoma. These are all subcutaneous fungal infection. And you know that subcutaneous fungal infection usually happens by inoculation of fungus. And this inoculation would be happening with thorn prick. So thorn prick leads to inoculation of fungus into the subcutaneous tissue, leading to subcutaneous fungal infection, right? So all these three are subcutaneous fungal infections. So they are caused by thorn prick, whereas dermatophytosis is what we commonly refer as tinea, and we know tinea is not caused by thorn prick. It is spread by fomites, by one person to another person, but not by thorn prick. So another question on subcutaneous fungal infection, but again, more logic-driven question. So very good, you're all giving the right answers. So dermatology was easy. You are all giving me right answers, and no controversies on the questions as well. So here the answer would be dermatophytosis. Moving on to the next question, a very direct question. Strawberry cervix on speculum examination is characteristic of what? So we have read this hundreds of times that Trichomonas vaginalis, which is a cause of vaginal discharge, causes strawberry cervix because of pinpoint hemorrhages that you see on the cervix. So strawberry cervix, we all know, is seen with Trichomonas vaginalis. We don't even need to look at the other option. Excuse me. So again, I think this was a very direct and clear-cut answer. Okay, so even if the image was not there and just they've asked you strawberry cervix, you would have known that. So I agree, we could have given you a better image or clearer image, but we do not need an image in this question, right? So again, a very easy question. The next one, we've talked about these signs, and in fact, there was a question on signs also, which we discussed in the champions exam. So we know this. So let's match the signs and their conditions. I'm not discussing the option here because they may be here and there. You should know the sign and their disease. So Auspitz sign, read hundreds of times, is a feature of psoriasis. We know that. Carpet tack sign is a feature of discoid lupus erythematosus. Darrier sign is a feature of cutaneous mastocytosis, and flag sign you would have studied in derma, in peds, in PSM, is a sign of kwashiorkor. So this one option was wrong in Ames. Which one? Which question was wrong? Option was wrong. Okay, so as I said, I'm not discussing this because this may be variable, but this is what you should have marked. Auspitz sign seen in psoriasis, carpet tack in DLE, Darriers in cutaneous mastocytosis, and flag sign in kwashiorkor. So if we look at it, option A is the correct answer here. Something was different, question options wrong, options were wrong. Okay, so please give me Auspitz was not matching with psoriasis. So can you tell me what were the other options? In exam, questions were wrong. Oh, okay. So you're telling me that in these options, they had not given Auspitz matching to psoriasis. One option was matched. So students, in that case, you would get a bonus marks for this, because see, there is no confusion with auspice at least. In fact, with none of these signs given here, there is no overlap. There is no other condition where you see auspice or carpet tack or diarrheas. So if the options was incorrect, I'm sure the examiners would look into that and you will get a bonus marks for that, or this question will not be marked. So so then it was the fault of the question, because there can be no other option which should be matching auspice sign, right? So please make this thing very, very clear. Don't worry about this question at all. Okay. So I'll move on to the next question then. And I think this is the last question that I have. So in case you have more questions, please feel free to tell me. So this last question that I have is, a histological examination slide was given. Something like this was given, which showed the layers of epidermis, which had hyperkeratosis and some scaly lesion, which was involving the stratum corneum. It was said that this lesion is caused by virus, and this virus infects keratinized squamous epithelium. And probably in the question, they have mentioned warts. So which of the following statements about the virus is true? So they had in the question given you something which pointed towards warts, and we all know warts is caused by HPV or human papilloma virus. So they wanted to know that what about HPV is correct. So if I look at the option, it is an RNA virus. No, it isn't DNA virus. We know that. It is an oncogenic virus. Yes, it is. We know HPV has low risk and high risk strains, and high risk strains are associated with cancers. And so, yes, it is an oncogenic virus. It is an enveloped DNA virus. No, it is a non-enveloped DNA virus. You would have studied in microbiology. We also talked about it in dermatology. No vaccine is available. Obviously incorrect. We know there are a lot of HPV vaccines which are available now, Gardasil, different strains which are available. So here the correct answer is, it is an oncogenic virus. So, but they mentioned DNA in the image. How can they mention DNA in the image? Image wrong. I can understand that image may be wrong, because it was very difficult for us to procure the right image, because we were not able to get the exact question. So this is what we have got. So your inputs are more than welcome. Not HPE. They mentioned DNA in the image, oncogenic, stratum layers. So there was something related to scaling in the stratum corneum, something which said warts, which students told me. And so here we have to talk about HPV as a virus, and oncogenic virus was there in the option. So that would be the correct answer. Option C was different. So probably yes. So they may have given different option here, and there may not be histopathology. Still, my answer would remain the same. So overall, if I understand, the essence of the question was this, and they were asking about HPV DNA. Right now, I want to know if there are any other questions that we have missed in dermatology, because this is what I have. And according to this, I think only LS question was a little tricky, but that also you would have figured out. But rest, all the questions were quite easy. Any other question? If there are, please write it in the chat box. Otherwise, I'll close this dermatology session here, and we'll move on to the next educator. An animated image mentioning DNA virus replication. Oh, so probably you're saying that in the image, instead of histopathology, there was a DNA virus replication which was given. Probably hand-drawn image. Okay, these clues were not there either. Right. So I think there is some confusion about how this question was framed, but I think the essence of the question was this only. All right, thank you so much, and all the very, very best for your result. And I'll close the dermatology session here.
you are live.
Hello, friends. How are you all doing? Hope the exam was easy. I heard it was tough. Okay. Anyways, quickly going to the questions of anesthesia. Basically, this question is a bit of pharma and anesthesia combined, right? Match the following substances with their appropriate antidotes. Okay. So, benzodiazepines, alcohol, opioid, and arsenic was given. So, as you know, benzodiazepine antidote is flumazenil. Alcohol antidote is what? Omeprazole. Opioid, naloxone. And for arsenic, you need to go for a chelating agent, that is dimercaprol, that is BAL. Right. So the answer was A. Right. So 2 or 3 antidotes you might have easily recollected. So this was an easy one. Coming to the next question, guys. Identify the nerve that's being given that's being shown. Identify the nerve block. So inferior alveolar, anterior ethmoidal, maxillary, or greater palatine. As the needle is pointing towards the palate, it is a greater palatine nerve block, usually used for dental surgeries. Yeah, hi guys, hi. Right. Dental surgeries, dental procedures, we use this. Now, when we are blocking the greater palatine nerve, it will block the sensations of hard palate, soft palate, and it is basically used for dental procedures. Now, guys, there is a slight, if at all the needle was pointing towards here, if the needle was pointing towards here, then the answer would be anterior ethmoidal, as you can see over here. Remember, if it was maxillary, they would have given this picture. Maxillary means maxillary nerve block for this picture, right? Over here, if the needle was pointing over here, then it was inferior alveolar nerve block, inferior alveolar nerve block. And anterior ethmoidal nerve block is usually given over here. So in the picture, it was greater palatine. I hope माहौल बन गया है. Towards palatine, right? Towards palatine is greater palatine. Inferior alveolar was not given. Again, guys, this is like just a recall based on some students. Okay. Exactly, we cannot say what was asked, but close to the question. Anyways, if the needle is pointing towards the palate, it is a greater palatine nerve block. Right. Now, coming to the next question. Guys, remember, next question, either it was asked like this or either something else. We'll discuss both the things. Yeah. So, which of the following statements about ketamine when used with combination with other induction agents is incorrect? Now, guys, remember, ketamine we usually combine with other induction agents, such as ketamine I combined with propofol and gave it to the patient with, it becomes ketofol. Okay, ketamine and propofol. It will enhance the effect of induction agent. That's a true statement. Ketamine reduces opioid tolerance. That's also a true statement. Ketamine increases the sensitivity of opioid analgesia. Yes. Ketamine with other induction agent, it will improve the sensitivity to opioid analgesia. But remember, ketamine with other IV induction agent, will it produce dissociative anesthesia? No. When you give ketamine alone to the patient, it will cause dissociative anesthesia. When you are mixing other IV induction agents such as propofol or some other IV induction agent with ketamine, basically it reduces or it blunts the dissociative effects. It blunts the dissociative effects. Okay. Now, regarding the opioid tolerance, guys, you need to remember regarding the opioid tolerance, whenever the patient is taking chronic opioid, what will happen? It will enhance the NMDA receptor effects. Okay. Chronic opioid patient, it will enhance the NMDA receptor effects, that leads to influx of calcium, which reduces the sensitivity of opioids, opioid receptor. Now, if you are giving ketamine, then what will happen? Ketamine is an NMDA receptor blocker. NMDA receptor, it blocks the NMDA receptor. Hence, it reduces the opioid tolerance also. But remember, if you give ketamine with some other IV induction agent, dissociative anesthesia effects are literally very much lowered or very low seen. Okay, similar question was asked. Kindly correct. Question of these ketamine option does not help in anesthetic properties of ketamine or something along those lines. Okay, either this was asked or either just this was asked, guys. Advantages of ketamine include all except relief. It causes relief from pain. It causes sedation. It helps in relief from depression also. Okay, as ketamine, right? But this is not an advantage. Dissociative anesthesia is not an advantage. Okay, either this was asked or either that. But we have discussed both the things. Next, this looks similar. Okay. Coming to the last one, guys. In an emergency center setting, you encounter 3 patients simultaneously. Which of the following will you attend first? Again, this is regarding the triage, guys. Ketamine produces dissociative anesthesia. Dissociative effects are seen with ketamine. Why not? So look over here. In an emergency center setting, you encounter 3 patients simultaneously. Now, which you will attend first? 40-year-old unconscious patient who's having noisy breathing, 25-year-old rapidly breathing and all. First of all, you need to remember, guys, in an emergency, if you want to triage and all, first you need to look for the airway breathing. A, B, C, D, E has to be done. Okay. Over here, in which patient do you feel that the patient's airway or breathing can be compromised very easily? Unconscious patient with a noisy breathing, it could be a gasping kind of state. So I think this is the right answer. Okay, priority should be first this. Second priority should be what? 25-year-old woman with rapid breathing and sweating. Again, this patient can also have an compromised airway. That could be the second priority. 60-year-old conscious patient with trousers soaked in blood. Trousers soaked in blood means some RTA or something, but still he is conscious, means he is maintaining his vitals. By putting a pressure and all, he's still like, he's not the first priority. And girl crying loudly and unconsolably, again, this is not an emergency at all. I guess this was asked as a 6-year-old girl crying with abdominal pain is also not a priority, guys. Also not a priority. Because again, he's crying loudly means her airway is clear and all. They're asking about which one is the priority. So unconscious patient with noisy breathing. Okay. So guys, just a brief review. The first question was, which were the antidotes? We have already discussed. For benzodiazepine, it is flumazenil, alcohol, fomepizole, opioid, naloxone, and arsenic, bal. Okay. Coming to the next question, they asked you about the nerve which is being given, nerve block which is being given, needle pointing towards the palate. It is a greater palatine nerve block. The third question was regarding the ketamine. Again, 2 questions we have discussed. Okay. In any of the 2, remember remember the option that was incorrect was it produces a dissociative state. When you are giving ketamine with some other IV induction agent, the dissociative anesthesia effects of ketamine, this side effect will be blunted. Okay. And this is the last question that we have discussed. Okay. So these were a few questions, guys. Again, if at all regarding ketamine and all, if you are getting that this were not the options and all, please write it down over here in the chat box, or you can just ping me up on the Instagram. We'll go through it. Okay. Is it clear, guys? I hope it went well. Paper was tough, but again, it was not tough only for you. All those who have prepared, it was tough for them. ठीक है? Okay, guys, on this note, can we hang up? If at all any questions, any doubts are there? Thank you. Okay. Okay, thank you, guys. Thank you.
Hello, my dear doctors. Good evening. A very good evening to everyone. This is Dr. Azam here, your faculty of anatomy at PrepLadder. And today, INI-CET exam was conducted, and now we're going to discuss the questions that were asked in anatomy. And as usual, the paper was very, very much predictable. Exactly the same concepts which INI-CET people has been asking always. Number one about the muscles of mastication. Number two about the cranial foramens. Number three about the attachments at the hip joint. So somehow the questions were related to these concepts only. So let us just go through all the questions very quickly. And of course, we know it is like a quick paper analysis right now that we are doing. Afterwards, we are going to come up with detailed questions with the proper options and all. It's all about just letting you know immediately after the exam how the questions were and what was asked exactly. So don't worry about the language of the question. Don't worry about the options over there. We are going to come up surely with exact paper, exact questions, and exact answers over there. Fine. So let's get started with the very first one. In the given image, the mark structure articulates which of the following bone? Previously, also in the INI-CET paper, once the Atlas image-based question was given, and at that time the question was about the third part of the vertebral artery. But this time they have asked about the arrow mark is at this place over here, and they're asking like which bone is going to articulate at this one here. Fine. Now, this is the atlas here, that is your C1, the first cervical vertebra. And this articular surface, it is going to articulate with the occipital bone. So the correct answer here will be the occipital bone here. That is actually telling you about the atlanto-occipital joint, which is required for yes movement here. You know? So that is the answer. Now moving on to the second question here. Among the following foramina, which nerve supplying muscles of mastication passes through? So muscles of mastication, there are totally four of them. That is your masseter, temporalis, medial pterygoid, and the lateral pterygoid muscle. And we know that all the four muscles of mastication will be supplied by mandibular nerve, or we can say the mandibular branch of trigeminal nerve. That is your 5-3. And 5-3 is actually going to pass through foramen ovale. We remember with the mnemonic as male. Now in this male, M stands for the mandibular nerve, A stands for accessory meningeal artery, L stands for lesser petrosal nerve, and E stands for the emissary vein. So mandibular nerve is the one which will be supplying to all the muscles of mastication. And yes, of course, it is going to pass through the foramen ovale. Yes, sir, exactly. The image was also given here. Now in this image, the marking A here is actually about the optic canal. And in this, the marking B here, this one will be the foramen ovale. And we remember that as ROS. In almost all the classes we have learned as ROS, foramen rotundum, then ovale, then spinosum. And then option C here, this is actually the jugular foramen. And finally, option D here will be the foramen magnum. This is the biggest of all of them. Fine. Now moving on to the next question here. In the given image, which of the following shows the correct matching of the regions marked with the respective structure? Okay. So we need to actually match the structures which are marked in the given image with the options given here. Now, first of all, in the image, you can see here, option A is actually marked here. Basically, this image is about the dorsal aspect of the brainstem. We know that very well. And brainstem, one of the hot favorite of INI-CET again. And even the dorsal aspect of brainstem has been repeated a number of times. Fine. So here you'll be able to see behind the midbrain, there will be like corpora quadrigemina, where you have got the two superior colliculi here, and there'll be two inferior colliculi. So option A, which is marked here, is inferior colliculi. That is perfectly correct. Now in this one, option B here, superior cerebellar peduncle, option C here, middle cerebellar peduncle, and D will be the inferior cerebellar peduncle. Now, first of all, let me tell you, if you have attended my lectures, we have been drawing this diagram. For example, if this one here will be our brain. Fine. Now in the brain, this will be your midbrain here, then there'll be pons, medulla oblongata, and followed by the spinal cord. And then you have got your cerebellum here. Now, we'll be drawing the schematic diagram in the classes, and we know that the midbrain is connected to the cerebellum with the help of superior cerebellar peduncle. And then pons is connected to cerebellum with the help of middle cerebellar peduncle. And finally, the medulla oblongata is connected to the cerebellum with the help of inferior cerebellar peduncle. So these three will be the cerebellar peduncles, and they are going to connect the midbrain, pons, and medulla with the cerebellum. Fine. But here, the students are actually thinking they're connecting straight over here. Please remember, they're not connecting straight like this here. What's happening here? The superior cerebellar peduncle is coming down into the cerebellum, whereas the inferior cerebellar peduncle is coming up into the cerebellum, and the middle will be remaining there only, the thickest one. So because of this reason, what is going to happen? When you draw the diagram of dorsal aspect of the brainstem, so first you'll be having the two superior colliculi, and then there will be two inferior colliculi. They're present behind the midbrain here. And then after that, you'll be able to appreciate the floor of the fourth ventricle over here. Now here, please try to remember that the middle cerebellar peduncle is actually not forming the floor here. The middle cerebellar peduncle is a little bit away here. The middle cerebellar peduncle will be a bit away here like this. Okay, this one here will be the middle cerebellar peduncle. So the floor of the fourth ventricle is just formed by the superior cerebellar peduncle and the inferior cerebellar peduncle. And remember, the floor of the fourth ventricle, the boundaries, in the boundaries, the middle cerebellar peduncle is not going to be contributing to the boundaries of that one. Okay. So in this diagram, you can clearly appreciate in this diagram here, yes, option B here will be the superior cerebellar peduncle. Option B here will be the superior cerebellar peduncle. Sorry, option D here will be the superior cerebellar peduncle. And then option C, the one which is like on the outer side there, that will be the middle cerebellar peduncle. So now what is the question that is being asked here in the given image? Which of the following shows the correct matching of the regions marked with the respective structure? Yes, option A, inferior colliculus will be absolutely correct marking here. Option B is actually a wrong marking there. And option D is also the wrong marking there. Why? Because inferior cerebellar peduncle wo nahi hota hai. That is actually superior cerebellar peduncle. Whereas option C is the middle cerebellar peduncle. Yes, this is also the right marking here. So multiple choice of question. You can follow this one here, sir. Okay. Next one. Now, once you have understood the concept over there, which of the following structures are associated with the dysphagia and dysarthria, except which one here? Now, dysphagia here, difficulty swallowing here. Actually, I tried to get the image very clearly from the students that in the image, like which muscles are exactly marked over there, exactly marked over here. Now, please remember, out of the given image, the muscles which are actually marked over there, one will be your stylopharyngeus muscle, another one will be the palatopharyngeus muscle, and the next one here will be the tensor veli palatini and the pharyngeal constrictor. Now, all this one here, they'll be actually helping in swallowing in some way or the other. Fine. But here they're asking which are associated with the dysphagia as well as dysarthria here. Remember, stylopharyngeus, yes, of course, it is concerned with swallowing. Palatopharyngeus is also concerned with the swallowing over there. And pharyngeal constrictor muscles are also concerned with the swallowing. But tensor veli palatini, yes, it is not that much involved in the part of that one. That is why it is not associated with the dysphagia. So all of the following will be associated except which one? The tensor veli palatini. But apart from that, yes. Yes, exactly. But apart from that, I would like to tell you that, I'm just looking at your comment section over here. Please let me know about the clear image and the markings in the image here. Because simultaneously I've asked for the names of the muscles. So because of that, we got it. So please let me know exactly which image was given and marking in that one so that we can come up with this one. And onto that, remember, if dysarthria is also concerned, then answers will change. Okay, because the main muscles which are involved in that one. So we'll come up with a clarity in this question. So please, you let me know the image which was given exactly what are the muscles which are marked. Then I'll come up with a clarity like which one should be the appropriate answer for this one concerning both dysphagia as well as dysarthria. Fine. Kind of cadaveric image was given. Okay, fine. If you can just let me know, you can send me the image, guys. Okay. Fine. Now the next one, through which of the following bones do the cranial nerve pass? Now see, the question is a little bit incomplete here. Which of the following bones do the cranial nerve pass, which are concerned with your central nervous system? The cranial nerve which is concerned with your CNS, which is related with your CNS. Now, if you look at the options over there, yes, we are having the temporal bone there, we are having sphenoid bone, we are having maxilla, and we know that some or the other cranial nerve is going to pass from here. ये हमको अच्छे से पता है. But the one which is concerned or related with your CNS, central nervous system, will be the cranial nerve number 1 and the cranial nerve number 2. Okay, the olfactory and the optic one. And the optic nerve is actually the one which is going to pass through the optic canal, which is located on the medial aspect of anterior clinoid process. And that will be related with your sphenoid bone here. Okay, so if this word is given in the question, then yes, of course, the answer has to be the sphenoid bone then. Understanding? Otherwise, if you just plainly read the question there, through which of the following bones do the cranial nerve is going to pass, of course, the answer will be even temporal also. है ना, वहां से facial nerve pass हो रहा है. तो इसीलिए the one which is related with the CNS I got from one of the student. If it is right, then you'd let me know. So they were asking CNS nerve. Yes. Thank you, Dr. Vinayak. Yes, CNS word. So if it is given there, definitely it has to be like either olfactory or optic. An olfactory nerve we know very well that is going to pass through the cribriform plate. An optic nerve is the one which is going to pass through optic canal, and that is located on the medial side of the anterior clinoid process, and that has to be the sphenoid bone. That is the right answer. Dr. Ali, olfactory is going to pass through the cribriform plate. cribriform plate. Okay, तो यहाँ पर वो वाली bone नहीं दी गई है. That bone is not given in the options over here. Fine. Yes. Option A is actually your temporal bone. Facial nerve is going to pass. Okay, now related with CNS they're asking. That is why I'm including the two options there, 1 and 2 there. Okay, let us go ahead now. Now, one histology question was given. Which among the following is not associated with the endometrial function? I hope you found it little bit tougher here. तो यहाँ पर आपको क्या करना पड़ेगा? You know, before the exams, when we tell you how to answer the question, sometimes you have to actually use the rule out wala option, odd one out. If you are unable to identify all the images over here, you can go ahead with the fourth image, जो हमने कई बार exams में देखा है. Many times it was given. That is actually the thyroid gland वाला image with that follicles, the follicular cells and the parafollicular cells. So of course, that is not concerned with the endometrial function. You can rule out. Apart from that, the other three options which are given there, other three options are actually the histological images and endometrium only, but at different physiological stages. You know, the follicular phase and all those things. So different physiological stages these images are given. But fourth one is actually ruled out one. Fine. Now let me just look at the chat box over here. Dr. Abhinav is telling endocrine was given. Oh, not endometrial. अच्छा, ये तो पूरा गड़बड़ी हो जाएगा फिर. ठीक है, fine. ठीक है, fine. No issues with that one. So we'll completely revise this question. ये question अपने को completely revise करना पड़ेगा अपने को. Okay. And if possible, you try to, you know, share the images with me. Like which endocrine images were given, which endocrine glands images were given. Please try to share with me. Fine. Badhiya, done. Now moving on to the next one here, a muscle of mastication involved in opening the mouth. Opening the mouth will be obviously the lateral pterygoid muscle. I told you many a times, L for lateral, L for lowering the jaw. So opening the jaw, opening the mouth will be the lateral pterygoid muscle. And has the following features. Which of the following statement about that is incorrect? We need to find out the incorrect statement here. Now, lateral pterygoid muscle, we know very well it will be attached to the medial side of the ramus of the mandible. This is a correct statement over here. Sorry, it is about the lateral pterygoid muscle. No. So lateral pterygoid muscle will not be attached onto the ramus of the mandible here. That will be the medial pterygoid muscle attached over here. Okay, medial pterygoid muscle attached onto the medial side of the ramus, and on the outer side here, that will be your masseter muscle. Okay. Images of testis, ovaries, thyroid, and endometrium was asked. Fine, I'll include them. I will include them. Testis, ovaries, thyroid. Fine. And endometrium was also given. Fine. Attached to medial pterygoid plate was the option. Achha, medial pterygoid plate. Fine. ये भी चेंज कर दिया जाएगा. Yes, apart from that, attached near the TMJ temporomandibular joint, हमको पता है lateral pterygoid muscle दो heads होते हैं. That will be attached near the temporomandibular joint. In fact, what is going to happen? The articular disc inside that one is actually the remnant of your tendon of temporomandibular joint here. Fine. And then innervated by, of course, the mandibular nerve. All the muscles of mastication will be innervated by 5-3. That is your mandibular nerve. Assist in protrusion of the mandible. Yes, of course. The lateral pterygoid muscle is also helping in opening the jaw, lowering the jaw, as well as protrusion of the mandible also. There are two heads and they have got both the functions. And we also have studied that retraction of the mandible is done by only and only temporalis, and remaining all the three muscles will be helping in protraction. So that is also helping in protraction also, protrusion of the mandible also. Taken. Patient having problem in opening the mouth, but closing is normally. Okay, that was the question. I'll just take a screenshot of this one. Don't worry. Done. Thank you. Exocrine, endocrine. भाई ये confusion मत करो अभी ना. Just now we have come to a conclusion. It was not endometrium. Now someone is writing exocrine there. No. So it was endocrine, and we got the four options also. Testis, ovaries, thyroid, and endometrium. ये correct हो गया. Fine. We got that. चलो. Pterygoid plate वाला भी हमने update कर लिया है. Now, in the given image, which of the following structure is not associated with the marked area? Now here, I'll tell you, not associated with the marked area. Marked area, we know very well. In INI-CET exam, always they'll be giving about the attachments at the hip bone. In our classes, in our videos, I have discussed a separate topic onto the attachments of the hip bone as well as the upper part of the femur also. We have discussed that one. Fine. Now the marked area here is ischial spine. Now, ischial spine, what is going to happen? The three structures which are going to take a turn here will be learned very famously right from our first year MBBS days as PIN. Pudendal nerve, internal pudendal artery and vein, and N stands for nerve to obturator internus. So this is going to take a turn here, this is going to take a turn here, but it is not tendon, it's actually nerve which is going to take a turn here. Okay, not the tendon here, it is a nerve which is going to take a turn here. So ये answer नहीं हो सकता है. In fact, the tendon of obturator internus muscle, not externus here. Okay, now tendon of obturator internus muscle is going to pass through from where? It is the one which is going to pass from lesser sciatic foramen. So ये इससे related नहीं होता है. Fine. तो ऑप्शन हियर ऑप्शन डी इश्कियोकॉक्सिजियस मसल या फिर कॉक्सिजियस मसल हमने पेल्विस और पेरिनियम टॉपिक में डिस्कस किया था कि इनफैक्ट ये मसल यहीं पर तो अटैच होता है. द मसल इज गेटिंग अटैच्ड ओवर हियर एंड इट विल बी the coccygeus muscle which is going to form a part of your, it will be forming the part of your pelvic diaphragm also. So that is also related or associated. Now I got like two terms from the students that sir it was given as not associated या फिर not related करके दिया गया था. This time they are not asking the structures which are going to take a turn, a related one. So of course this muscle is also related with the structure, right? Ischial spine is also related with the structures, right? है ना? So remember the correct answer here should be, which is not related with this one, should be the tendon of obturator externus. Obturator externus tendon इसके साथ में related नहीं है. Is it okay? Perfect. Now, no, that was a different question. Dr. Kevin, the one question you're asking is actually a different question about that. Match the following was given about the aortic arches. Again, expected question in the INI-CET exam. Always there'll be a question related with your pharyngeal arches. And this time the match the following was given and the arches were given and the arteries which are derived from that has been given. We discussed about that in detail in the development of arterial system, guys. Embryology part. Hai na? So we know the artery is the first arch artery, the remnant of them, not the derivative, it is a remnant. The remnant of that one will be the maxillary artery. The second arch artery, the remnant will be the hyoid artery and the stapedial arteries. Third arch artery, of course, it is the one which is going to form your common carotid artery. The proximal part of that is going to form the common carotid artery. Distal part is going to form the internal carotid artery. And after that, the fourth arch artery is only on the right side. Remember, it is the one which is going to form your right subclavian artery. And apart from that, the left fourth arch artery is going to form the arch of aorta. Fine. अगर आपको arteries में एक और भी include करना है तो you can also include the sixth arch artery here and that is the one which is going to form your right and left pulmonary arteries also. Fine. So therefore, my dear friends, we know very well which arteries are derived from which arch, which pharyngeal arch. We know this very well. I hope you'll be easily able to, relate that one. Third option was given as external carotid artery also. No problem, no problem. That itself is going to give rise to a bud-like structure and that bud is going to form external carotid artery. वो भी हम यहाँ पर include कर लेते हैं. Dr. Palak Sharma is telling sixth artery. Okay, मैंने यहाँ पर include कर दिया है. वो भी multiple choice question में आ जाएगा. Done. Sixth arch artery with arch of aorta was given. No. Sixth arch artery is going to form the pulmonary artery, that too the proximal part. And left sixth arch artery distal part is going to form the ductus arteriosus, which is going to be between the pulmonary artery and arch of aorta. Fine. So it cannot be like directly arch of aorta derived from there. वैसे तो wrong हो जाएगा अगर match the following दिया गया है. Is it okay? So these were all the concepts given, my dear friends. I hope like anatomy questions as expected in the INI-CET exam was like very much easier from all the expected areas, from all the expected concepts the questions were given. And it's like damn easy questions from anatomy. I hope you've answered that very well. All the best for your results. God bless you all. Thank you.
ठीक है मैं कॉल रखूँगी हाँ कर दीजिए ठीक है
Hello, dear students. A very good evening to all of you. Can someone please confirm if my screen is visible and if I'm audible so that we can start? Yes? Quick confirmation. Thank you, Abdul, Kalp Jain, Falak Sharma, Mandeep, Yukes. Okay, so very good to hear from all of you. So, welcome to this recall session of INI-CET November 2025, where we'll be discussing the pediatrics questions. The paper overall, the impression is probably that it was a moderate and a tougher side paper. But surprisingly, I would say not surprisingly rather, the pediatrics questions were quite easy this time. So there were almost 10-11 questions that I've got till now recalled from pediatrics. And most of the questions were from the previously asked topics, and they were like, I would rate it as a pretty simple paper from the pediatrics perspective. So I'm sure most of you have answered the pediatrics questions correctly. Please confirm if my screen is visible. Can someone please confirm if my screen is visible so that we can start? Can you see my first question? Yes? Okay, thank you. So this was almost a direct repeat, sans minus the image. Last time, there was this image was also there in this question. So this was a full-term newborn who developed tachypnea and shortly after birth. So full term is the thing to note, okay? Full-term newborn who developed tachypnea shortly after birth and the breathing difficulty resolved within 48 hours. So there was some self-limiting sort of illness which resolved within 48 hours also. Chest X-ray shows prominent vascular markings with fluid in the interlobar fissure. So all these, clearly tell us that the diagnosis is what? Yes. So it is transient tachypnea of newborn. So in the previous year question, there was almost a similar question, very, very similar to this. And probably in that question, the X-ray was also given. So here the radiological findings have been mentioned in the question, but the X-ray image was probably not given this time. So a clear-cut question. It is not pneumonia because the baby does not have any features of sepsis and the respiratory distress settled within 48 hours, and the X-ray findings, that is vascular markings and fluid in interlobar fissure, all suggest transient tachypnea of newborn. Neonatal respiratory distress syndrome we would suspect in a preterm neonate where there is deficiency of surfactant and there will be ground glass haziness of the lungs, which we do not see here. Meconium aspiration syndrome, again the history of meconium stain LICA is not there and the X-ray features are not, as per meconium aspiration syndrome. So was this the question or was there any change in the question or any of the options? Please confirm. This was the question and the options. Can someone give a quick confirmation so that we move ahead? Yes? Was this question there with these options? Yuke says no. Anyone else? Yes. So Priya says yes, this only, ma'am. Thanks, Priya. Okay. And Alicia also says yes. Okay. So we are good to go. The next question. So a boy. So this is a boy with developmental delay, progressive obesity, hypotonia, and hypogonadism is found to have a deletion on the chromosome 15q11-13. The karyotype is 46XY. So it is a boy and the karyotype is 46XY. And we have features of developmental delay, progressive obesity, hypotonia, hypogonadism. So all these are features of Prader-Willi syndrome. We all know all these are features of Prader-Willi syndrome, right? And this chromosome area 15q11-13 is also the site where, which is affected in Prader-Willi syndrome. We know Prader-Willi syndrome has got multiple modes of inheritance. So it can be due to paternal gene deletion or it can be due to genetic imprinting, right? So multiple mechanisms can be responsible, okay? So the typical clinical features of obesity, hypotonia, hypogonadism, and the affected area and the developmental delay give us the diagnosis. Okay. So Patau was also an option. I think so. Instead of Fragile X, was Patau the option? So Patau syndrome was also an option. Was Fragile X not there in the option? I think Fragile X was not there in the option then. Prader-Willi and Angelman were there in the option. Angelman syndrome, also the same genetic area is affected, but it is happy puppet syndrome, where the child has intellectual disability and gelastic seizures. So there are incessant bouts of laughter. But this obesity, hypogonadism, hypotonia, they are not a feature of Angelman syndrome. Cry-do-chat syndrome, again, it is 5p minus. So there's a deletion in the short arm of chromosome 5, but the 15q11 to 13 region is not affected in Cry-do-chat syndrome. Okay, so Manya Jyoti is telling no history was given. Okay, so it was probably only then karyotype 46XY and chromosome area was mentioned. Obesity history was not given. Jyoti is telling, okay, obesity was not there. So what all was there in the history? Was hypotonia, hypogonadism, that was there in the history or not? Okay, only chromosome was given. Fine. So can someone confirm what else was given in the question? Yes. So you can type in the chat. Okay, so only genetics was there. Okay. So can someone type the exact question if they recall something different in the chat box? Okay, karyotype and chromosome deletion, that's all. Okay, and what were the options then? So what were the options? So karyotype was there, that means 46XY, the genetic deletion was there. So what else were there and what was the options? So we can come back to this question if you can complete this question further. Okay. So moving ahead, another question that I got was a 10. Then again, this is an often repeated question. Nowadays, we get lots of questions on DKA, that is diabetic ketoacidosis. So there was this 10-year-old child who presents with abdominal pain and vomiting. Arterial blood gas shows pH 7 and bicarbonate 8. Was this the question? Was a blood sugar value mentioned in the question? Yes. Was this the question? To me, with this severe acidosis, it looks, and abdominal pain and vomiting looks like a case of DKA. So was this the question, or the question was something else, something different? Potassium levels given in the question. Okay, so potassium levels were also given in the question. What was the potassium level? Potassium level, okay, sugar level was 340. Okay, so sugar level was 340. So this confirms that yes, this was DKA. Okay, DKA, because blood sugar level is more than 200. There is acidosis, severe acidosis is there. Okay, right? Sodium was 145. So somebody is telling sodium was 145 and potassium was 4.8. Okay, perfect. So this is a case of severe DKA then. Okay, so the sugar is more than 200. There is severe acidosis, the pH is 7, bicarbonate is 8. So severe DKA, how will you treat? So first we will give a fluid bolus. So we'll give a normal saline 20 ml per kg over 1 hour. And after that we will start insulin infusion. So I would go with choice A, IV fluid 20 ml per kg followed by insulin. Okay. Because it is severe DKA, we are expecting severe dehydration. So we'll give 20 ml per kg fluid, not 10 ml per kg or 7 ml per kg. And despite being severe acidosis, we will not give bicarbonate, because giving fluids and taking care of the blood glucose, giving insulin will resolve the acidosis by itself in most of the cases. We give bicarbonate only if the pH is less than 6.9 accompanied with myocardial dysfunction and it is not getting corrected despite your fluids and insulin. Only then we give bicarbonate, otherwise not. Okay, so what was the fourth option? So one option was N/2 with insulin, someone is telling. N/2 with insulin was one of the options. So our fluid of choice would be normal saline, not N/2. Okay. So there was, okay, anyone else? So N/2 normal saline with 10% undercorrection. Okay, N/2 with insulin. Bicarbonate was 4. Okay, bicarbonate was 4. Someone is telling the bicarbonate was 4 in the question. Okay. So bicarbonate was 4 again indicates that it is severe acidosis. So no doubt this is a case of severe diabetic ketoacidosis. And as we've already discussed in our main videos also, rapid revision videos also, RRR sessions also. So that the treatment for severe DKA would be initially you will give fluid, normal saline 20 ml per kg over 1 hour if there is no shock, rapidly if there is shock. Followed by that we start insulin infusion. Okay. So what were the other options? Yes. So what were the other options? Can anyone recall? So we are dealing with a case of severe diabetic ketoacidosis. What were the options? So one option was like insulin, then NS. Okay. So one option was probably insulin, then NS, 10% deficit. So this is also wrong. Okay. This is incorrect because first you have to give fluid. Okay. First, you have to always give fluid. We start insulin later. Otherwise, there are more chances of cerebral edema. So first, we have to give fluid. Yes, insulin infusion has to be given, but insulin infusion is started 1 hour after starting fluid therapy. Okay. So the best answer would be normal saline 20 ml per kg over 1 hour followed by insulin infusion. And it is usually given at a dose of 0.05 units per kg per hour. Okay. Right. So moving ahead, this was again a very simple question on developmental milestones. Which of the following milestones is correctly matched with age? Yes, so was this the question? So mature pincer grasp 9 months we know is wrong. Immature pincer grasp comes at 9 months. So bolus IV fluid was one of the questions. Okay, bolus IV fluid is also not correct. Okay, so one option someone is telling 10 ml plus insulin plus bicarbonate. So 10 ml per kg plus insulin plus bicarbonate was the option. Okay, bolus IV fluid also. So bolus IV fluid what was the option? So NS followed by NS 20 ml followed by N by 2 saline and insulin. So that also appears to be correct. Yes, so if this was the option NS 20 ml per kg followed by N by 2 saline and insulin. Okay. Yes. So one option was about KCL correction. So KCL correction of course is not required here because the potassium is already 4.8. So you do not need to do KCL correction. So if these four were the options, KCL correction, N by 2 with insulin, insulin then NS and NS 20 ml per kg followed by N by 2 saline and insulin, then the fourth one NS followed by NS 20 ml per kg followed by N by 2 saline and insulin will be the best answer. Okay. Yes. So the principle of therapy would be first a fluid 20 ml per kg normal saline over 1 hour. After that you start insulin infusion. Along with that you also continue the fluids. Okay. Right. So apps is telling all the options mentioned are incorrect. So apps, please help us with the correct options. Then we can discuss it further and come to the right answer. Can you please type all the 4 options as you recall and we can discuss it again. Okay. KCL was there in every option he is telling. So was KCL there in every option? Yes. Can someone confirm was KCL there in every option? Yes. Can someone else confirm? Was potassium chloride there in each of the options? Okay. So Dhiman, Jyoti, Sarvesh and Satishi are telling yes. Okay. KCL was then all the options. So what else was there in the options then? So just KCL correction of course we are not going to give. We can add the maintenance requirement of potassium. And as it is, decay is a condition where as you give insulin, potassium will go intracellular. So we can add potassium, but only potassium of course will not help. You will have to give initially fluid followed by insulin infusion. So RL was also there in one of the options. So can someone please type all the 4 options as you remember and we can come back to the best option based on the, so best answer based on the options given. So one option was only insulin. So only insulin option will also not be correct. Only insulin option will also not be correct. Okay. Only insulin will not help. The main pillar of decay therapy is fluid therapy. Treatment of decay is fluid therapy. Okay. So one option was kind of mixed up. So someone, Kevin is telling no KCL. So please come up with the most probable options that you remember and then we can come back to this question. But the principle of therapy as I discussed remains normal saline 20 ml per kg followed by insulin infusion. You can, and along with that of course you will continue giving fluid. 10% dehydration correction we are going to do and you can add KCL. Okay. So we are sorted. Which of the following milestones is correctly matched with age? So mature pincer grasp 9 months is not correct. We know mature pincer grasp comes at 12 months, immature comes at 9 months. Transfer of objects comes at 6 to 7 months. Yes, this appears to be correct. Unidextrous grasp or palmar grasp comes at 6 months. So no, 8 months is not correct. And tower of 2 blocks at 2 years. No, at 2 years a child can make a tower of 6 to 7 cubes. Okay. Okay, Gajanan is telling some options with 20 ml KCL, some with 40 ml KCL. So please requesting you to frame all the 4 options as someone, if someone remembers them correctly and post them, and I will definitely reply back with the correct answer out of the 4 options. So please come to a consensus on the options and you can get back to me with those options and I'll help you discuss and find out the best amongst them. Okay. So was this the question on developmental milestones? So I'm sure all of you have got it correct. It is a pretty simple, straightforward question. Yes. So was this the question? Okay, Vinayak says it was the question, so we are good to go. Right. Then there was a question on short stature. A child presents with short stature. Upper segment to lower segment ratio is 1:1.4. Does anyone remember was the age of the question mentioned in the question? Was the age of the child mentioned in the question? Age of the child? and no other systemic abnormalities on examination. What is the most likely diagnosis? Okay. So ratio was 1.4. So was the ratio 1.4:1 or 1:1.4? So what was the ratio? Ratio was 1.4:1 or 1:1.4. Please come up with the correct ratio. What was the ratio? So age is 7 years. So someone is telling age is 7 years. Okay. And the ratio was 1.4. Okay. So the ratio was 1.4. So ratio was 1.4. So if age was 7 and the ratio was simple 1.4, okay, 1.4, then of course it becomes short limb dwarfism, okay. Then the limbs are short. Then out of the given options, of course, we would go with achondroplasia. Spondyloepiphyseal dysplasia would be short trunk dwarfism. The trunk will be short and upper segment, lower segment ratio will be less. Severe PEM and growth hormone deficiency, both are proportionate short stature. Okay, it was mentioned that the child had adequate diet. Okay, adequate diet. And were the options same or some other options were there? Head circumference was normal was mentioned. Okay, head circumference normal. Okay. Anything else? Okay, same. Priya is telling. Okay. So then we go with achondroplasia, right? So which of the following is or are seen in Hirschsprung disease? So there was a question on Hirschsprung disease. So we all know in Hirschsprung disease, there is number 1, failure of migration of ganglion cells is correct. Causes intestinal obstruction postnatally is also correct. Okay. So the child can present with constipation and features of intestinal obstruction. Distal segment dilated is not correct. The distal segment is constricted because that is the aganglionic segment. Proximal segment constricted is again not correct. Proximal segment is dilated. Non-cooperative peristalsis is correct. So non-cooperative peristalsis, was this the term mentioned in the question? Because you know what happens, the upper part is doing peristalsis, lower part is not doing so. The normal peristalsis is not taking place. So option 3 was not present. Somebody saying distal segment dilated was not there in the options. Anything else? So out of the options which I have got, the options 1, 2 and 5 appear to be correct. So my best answer is C out of the given options. Okay, non-coordinated. Yes, so non-coordinated sounds better. Probably somebody mentioned it as non-cooperative. So it is non-coordinated peristalsis. Okay. Yes. Okay. So option 3 was not there. So there were only 4 options then. Yes. Proximal constricted was the option. Okay. Proximal constricted we are there. So distal segment dilated was not there in the options. Okay, fine. Right. So the correct options we've already seen. Okay. So one more option was that child won't pass meconium post-birth. Yeah. So causes intestinal obstruction postnatally means that only. So child will not pass meconium. Child will not pass meconium after birth. So this is also correct. If this was mentioned, this is also correct, we know. Right? Alright. So we are sorted on this question. Moving ahead. So there was this question on nephrotic syndrome. So a 10-year-old child, so there was this question, a 10-year-old child who presents with generalized edema, urine analysis shows 3+ proteinuria, 24-hour urine protein is more than 3.5 gram per day, there is no hypertension or hematuria. Serum albumin is low, kidney biopsy shows segmental fibrosis and hyalinosis. The child shows poor response to steroid. What is the most likely diagnosis? So here, this is definitely a case of nephrotic syndrome. And you know, as the kidney biopsy is showing segmental fibrosis and hyalinosis, this is our first clue, and poor response to steroid is our second clue, that it is a non-minimal change disease. Yes, so non-responsive to steroid. Poor response means non-responsive, okay? Non-responsive. Okay, no response to steroid. So our best answer is focal segmental glomerulosclerosis. It is not minimal change disease because, you know, then the child would have responded to steroids and you will not get segmental fibrosis and hyalinosis in minimal change disease. Okay, so segmental sclerosis was mentioned. Okay, segmental sclerosis. Okay, segmental sclerosis. So our diagnosis here is FSGS, focal segmental glomerulosclerosis. Okay, right? So again, we are sorted on this one. Moving ahead. So there was this question on so this was this question on the diagnostic criteria of acute rheumatic fever. Again, a very important topic we've discussed so many times in the LRR, RRR, and in our main videos, of course. So acute rheumatic fever is diagnosed by minor and major components of Jones criteria. Which of the following are components in Jones minor major criteria? Select all that apply. So this time many of the questions had these, multiple options correct type, adding on a difficulty level to the questions, and they will consume, of course, more time as you solve them. Okay, so short PR was an option. So prolonged PR was not there. Somebody is telling short PR was the option. Okay, short PR was the option. So out of these, the correct options, of course, are carditis is correct, erythema nodosum is not correct. We know it is erythema marginatum, not nodosum. Polyarthralgia is correct, chorea is correct, and short PR interval is correct. Okay, so we have carditis is correct, polyarthralgia is correct, chorea is correct, and short PR interval, if it was there, then it is not correct. Okay, so prolonged PR interval is correct. Okay, shortened PR interval was given. Okay, so carditis, polyarthralgia, and chorea. So an option which will have carditis, polyarthralgia, and chorea will be correct. Okay, right? So the option which will have 1, 3, and 4 will be correct. Okay, one option was 1, 2, 3, 4. Erythema nodosum, of course, is not correct, we know, right? Okay, erythema nodosum is not correct. Erythema marginatum should be there, right? So moving ahead, infant with 3 months progressive jaundice. So there was an infant with 3 months progressive jaundice, pale stools, high colored urine. So pale stools and high colored urine tells me that this is a conjugated hyperbilirubinemia, obstructive kind of jaundice, where there is some obstruction to the flow of bile. Okay, so that is why pale stools and okay, so somebody is selling short PR, somebody is selling prolonged PR only. So whatever it was, we should not fret about that, but we know the diagnostic criteria of the modified Jones criteria and we'll go along with that. That means if short PR interval was there, then of course we'll not take it. Am I not audible? Yes, can someone please confirm if I'm audible? Kalp Jain says I'm not audible. Can someone please confirm? Can someone please confirm so that we can move ahead? Audible, thanks. Thanks, Priya, Alicia, Mastermind. Okay. So this progressive jaundice, pale stool, high colored urine tells me it is an obstructive kind of a jaundice. The child was healthy, gaining weight and feeding well. HIDA scan showed no excretion. So HIDA scan is showing no excretion. So what we are thinking of? We are thinking of biliary atresia. So my most probable diagnosis here is biliary atresia, right? So neonatal cholestasis was option C. Okay, option C was neonatal cholestasis. Neonatal cholestasis. Okay. But of course, biliary atresia we are suspecting, we would go for liver biopsy as the confirmatory diagnosis. Okay. So breast milk jaundice, of course, it doesn't look like, because in breast milk jaundice, you will not get high colored urine. Okay. You will not get high colored urine and pale stools. Okay. Galactosemia, again, if it would have been there, the baby would have had cataract, and the baby would have some other manifestations, diarrhea, vomiting, reducing substance positive in urine, and so on, right? So neonatal cholestasis, again, we will not think of, because HIDA scan is showing no excretion and pale stools and high colored urine is there. So out of these options, liver biopsy I would go ahead with. So one option was genetic condition. So genetic condition, genetic testing, if it was there, I would even go with that also. So can someone confirm what were the options and what exactly was there in the question? Was something else there in the question that we are missing? So it is as per the question that I have got here, it appears to be a case of biliary atresia. If it is biliary atresia, then of course liver biopsy would provide the confirmatory diagnosis. But if suppose these pale stools was not there, this HIDA scan finding was not there, then in this case of conjugated hyperbilirubinemia, I would even think of PFIC, or progressive familiar intrahepatic cholestasis. So if I think of PFIC, then of course I would go with genetic testing. So okay, so B was cholestasis requiring further genetic testing. Requiring genetic testing, right? So anything else in the question? Can someone help whether this HIDA scan finding was there in the question or not? And whether, this pale stools were there in the question or not? Yes? Can someone confirm what was the exact question? So HIDA was there. Okay, HIDA scan was there, right? So HIDA scan, of course, is a screening test and we would like to confirm the diagnosis. Pale stools was also there. Then we must do a liver biopsy to rule out biliary atresia. Okay, right. So was liver biopsy one of the options? Liver biopsy was there in the options? Yes? Please confirm if liver biopsy was there in the options. Can anyone confirm if liver biopsy was there in the options? Yes, it was there. Okay, so as of now, as per the given question and options, I would go with liver biopsy. Okay, right? I would go with liver biopsy. Right? So moving ahead, there was a question on dengue management, I believe. So a child with fever and abdominal pain tested positive for dengue on day 5 of fever. His BP was 110 by 70 millimeters of mercury. Platelet count was 20,000. Was it 20,000, 50,000? What was it? And there was no bleeding manifestations. What is the next step? Was this? Acha. So Saurav is telling for the previous question that HIDA scan showed no excretion problems. So was it HIDA scan showed no excretion or no excretion problem? So if it was HIDA scan showed no excretion problem, then I would go ahead with genetic testing. But if HIDA scan showed no excretion, I would go with biliary atresia. Can someone confirm what was the question exactly? So HIDA scan showed no excretion or HIDA scan showed no excretion problem? So Vinayak says no excretion, Vamp says no excretion, Sayali no excretion. Akshit says it showed problem. Okay. Not no excretion problem. Okay. So no excretion, then we are good here. We will go ahead in the lines of biliary atresia. Okay. So this dengue question. So was this the question and were these the options or was anything else in the question or any other option? So was anything else in the question or any other options? So here, as per the given question that I have here, there is thrombocytopenia, but there is no bleeding. So I would not do a platelet transfusion. Okay. 20,000 only was there, Yuks is telling. All right. Then 10 ml per kg per hour RL or 7 ml per kg per hour RL or 20 ml per kg RL. So were these the options? What were the options? So Himanshu is telling platelet count was 50,000. Yuks is telling 20,000. So can someone confirm what was the platelet count? But irrespective of the platelet count, whether it was 20,000 or 50,000, if the child has no bleeding, we will not transfuse platelets. Okay. If it is 10,000, of course, then we'll transfuse. But if it was 50,000 or 20,000, but no bleeding, we might not transfuse. So some people are telling 50,000, some are telling 20,000, almost 50-50 ratio. Okay. So 20 ml per kg NS was option. 20 ml per kg NS was option. Anything else? So out of these options, I would go with 7 ml per kg per hour of ringer lactate. Okay. As the child is not in shock currently, his BP is 110 by 70 millimeters of mercury. Okay. So it was multiple answer question. So what were the other options? What were the other options? Or if there was anything else in the question, if you can remember. So there were two questions on dengue. Somebody is telling one had platelet count 20,000, another had platelet count 50,000. Okay, paracetamol was also there in the option. Yes, if paracetamol was there and if the child is running fever, we will give paracetamol also. Somebody is telling it is a single choice question. Blood transfusion, platelet transfusion. Okay, PRBC transfusion was also an option. RBC transfusion, of course, we are not going to give in dengue. So there's no shock. We'll not give 10 ml per kg. We'll not give 20 ml per kg. We'll not give PRBC transfusion. So as of now, I'll go with 7 ml per kg per hour of RL and paracetamol. Okay, PRBC transfusion, of course, will not give. Already there is hemo concentration. We don't want to give PRBC transfusion unless the child is having bleeding. If life-threatening bleeding is there, hematocrit is falling, and the patient is having shock, if there is significant bleeding, then we'll give PRBC, otherwise not. So hemoglobin, somebody is telling, is 9. So please confirm, what was this exact question and what were the options. So 2 different questions on dengue is there is what we gather as of now. If someone can pose the 2 different questions, then we can discuss them. Okay. So meanwhile, dengue, if there is a dengue child with warning signs meaning pain abdomen. Okay. So pain abdomen is one of the warning signs. If the child is in shock or hemo concentration, if all that is there, then what we'll do? So we usually start with 5 to 7 ml per kg per hour of ringer lactate, and then we monitor the hematocrits and platelet. and we monitor the child clinically, of course, and we titrate the fluid accordingly. So usually we'll start with 5 to 7 ml per kg per hour. Okay, right? So that was it. So I think if these were the options, we would go with 7 and paracetamol. If the child was bleeding, of course, we will have to give platelet transfusion as well. Or if the platelet count is less than 20,000, again, we will give platelet transfusion. Okay, right. So somebody is telling hemoglobin was 9, platelet was 20,000 and fever. So fever is there. So paracetamol, hemoglobin was 9. We don't know the baseline hemoglobin, so we cannot comment. Okay, the management in first hour. Okay, so I think 7 ml per kg per hour and paracetamol should be okay. So the last question, I believe, from my side, which of the following is or are true about Gaucher disease? So Gaucher disease occurs, so this was a multiple answer correct type question. Gaucher disease, a hot favorite of all the exams. Again, n number of times we've discussed in our main videos, LRR, RRR, everywhere. So Gaucher disease usually comes as a question. So it occurs due to, so which of the following are true about Gaucher disease is the question. Occurs due to deficiency of glucocerebrosidase is correct. Cells with crumpled tissue paper appearance of cytoplasm are seen is also correct. Bone pains, if it is mentioned in the question, is also correct. Occurs due to deficiency of ceramidase is not correct. Deficiency of ceramidase causes Farber disease, where there are some nodules, subcutaneous nodules and all are there. So Farber's disease. So the options 1, 2, 3 are correct. Okay, so somebody is telling it was not multiple correct. Okay. So what were the options? Can someone say, okay, options are not matching. So bone pain was not given. So can someone help me? What were the options? Ceramidase was an option. Many people told me, many of the students told me ceramidase was an option. Yes, Balu Raj is also telling it was. So what was the other option? So sphingomyelinase was option. Okay, fine. So if sphingomyelinase was there, then that is sphingomyelinase deficiency again is Niemann-Pick disease. It still remains a wrong statement. Okay, sphingomyelinase was there in the option instead of ceramidase. Okay. Foam cells. Okay. So foam cells are also usually not seen in Gaucher disease. Okay. Foam cells are usually not seen in Gaucher disease, though you can get it in some other lysosomal storage disorders, like you can get it in Niemann-Pick disease. You can get them in even GM1 gangliosidosis, GM2 gangliosidosis, very, very rarely in Gaucher disease. Not common in Gaucher disease at all. Okay. So only 2 correct options were there. Occurs due to deficiency of glucocerebrosidase and cells with crumpled tissue paper appearance of cytoplasm was seen. Foam cells are not seen and sphingomyelinase not seen. Okay. So we are sorted on this. So we will choose an option which has got only 1 and 2 correct. Okay. Only 1 and 2 correct if these were the options. Right. So these were the questions that I could recall from pediatrics. Right. So if there are any other topics or any other questions that you think were also there from pediatrics, then you can message me here or write in the comments, or you can send me a message on my personal window and we'll be happy to discuss. So this time, surprisingly, no question as such was there from immunization, no direct question from immunization, right? So we got a question on growth, short stature, we got developmental milestones, we got a question. Genetics, of course, there were questions. Inborn errors of metabolism, we got this Gaucher question. Immunization was not there. So diagnostic criteria for nephrotic syndrome, somebody is telling, was a question, but it is a cross-cutting question again between pediatrics and medicine. So, but diagnostic criteria, we all know hypoalbuminemia is there and massive proteinuria and edema. They are the majorly they are the diagnostic criteria, and hyperlipidemia is an associated finding, usually not considered a diagnostic criteria as such. Okay, anything else? Any other question that we missed upon? So there was surprisingly no question again from pediatric cardiology. I didn't get a question. Yes, pediatric cardiology. I think there was no question this time. Then even from pediatric, so gastroenterology, we saw Hirschsprung disease. Respiratory, so newborn respiratory distress was there, but pediatric respiratory, so there was no question. Pranay is telling, okay, PDA, there was a question. What was the question on PDA? Does someone remember what was the question on PDA, patent ductus arteriosus? What was the question? So PDA was given. Okay, so what exactly was the question? So ASD, VSD, PDA, but what was the question? Can someone please recall and share? Okay, so continuous murmur was there in the question, then of course the answer becomes PDA. So continuous murmur and acyanotic child. So if this was there, continuous murmur and acyanotic child, of course, then our diagnosis becomes PDA. Anything else was there? Okay, non-cyanotic heart disease, left clavicle murmur, continuous murmur, then our diagnosis becomes PDA for sure. So no question again from seizures, neural tube defects. So pediatric neurology, we didn't get any question as such. Okay, continuous murmur in the left infrascapular region. Yes, we'll go with PDA. Okay, PDA. Right. So infraclavicular, left infraclavicular region. Okay. So there was no question surprisingly again from pediatric neurology, from the musculoskeletal disorders. Okay, drug was asked in seizure. What seizure? What drug? So drug in seizure, what seizure? What was the question? So can someone remember what was the question about the drug in seizures? Yes, does someone remember what was the question? So which of the following drug is not used in status epilepticus? Not used in status epilepticus. And what were the options? What were the options? Yes, not used in status epilepticus. Does someone remember what were the options? Yes. So valproate, ethosuximide, phosphenitoin. Valproate, okay, here bounding pulse was also there. Okay, that is also a feature of PDA. Thank you for mentioning. Okay, so drug not used में ethosuximide, phosphenitoin, valproate, lorazepam, midazolam, इनमें से any option was there? Levetiracetam. These were the options. So were these the options? Of course, out of these, we do not use ethosuximide. Ethosuximide is not there. So status epilepticus, we do the airway breathing circulation, stabilize the child, and then what do? We give lorazepam as the drug of choice to abort the seizures, or we can give midazolam also, and then we load the child with phosphenitoin or phenytoin. That is usually the first line. If that doesn't work, then we can go ahead to valproate or levetiracetam or even phenobarbital. Okay? Yes? So I love you all too. So it was really a pleasure interacting with you. So I hope you have been able to give your best in this INI-CET exam, and I'm sure many of you are going to qualify for the same also. So very well done. Kudos to you for maintaining this momentum, and even after the exam you're listening to this recall session and actively contributing. Shows how much you have the energy and the passion of doing your best. So all the very best, guys. God bless you. I'm sure you will come out with flying colors. Thank you so much for watching this recall session and contributing. We'll surely get back with a refined version of these questions soon. And if you have any other questions in mind, any other options, any change, feel free to message me, right? Or post in the comments. Thank you so much. Thank you. हेलो कर दूँ हाँ ओके
Hi everyone, good evening. I hope I'm audible and visible. Hi everyone, good evening. Yes. So welcome to this paper analysis of INI-CET November 2025 biochemistry part. And before I start the session, I congratulate all of you for having crossed one step, right? You have written your exam, you have done your part. Leave the rest to the universe, right? You will be successful for all the hard work that you have put in. And now it's not the time for you to repent about what could have been done better. It is the time for you to appreciate yourself for having come this far, right? And let's stay calm and let's try to see what are the probable answers for all the MCQs that came in this examination, right? So before we start the session, based on students' feedback, let me give you an overview of how this paper has been, right? So 58% of the students who are in my Telegram group have said that this paper was moderate. And not only from Telegram group, I've been receiving this input from many students all over the country. So the paper has not been easy, which means if you found it difficult, now you're not alone. right? Most of you have found it to be a moderate paper. And then when I asked about the biochemistry part of INI-CET November 2025, 47% of students said that it was difficult. So if you also found it to be difficult, then you're not alone. Okay. And I know the reason. The reason clearly is there were 19 MCQs, totally 19 MCQs in biochemistry. Out of these 19 MCQs, 5 MCQs were from genetics. And when I say genetics, it is not like the usual MCQ which they ask in replication or transcription or in DNA or RNA. Not most, all the 5 MCQs were applied aspects of genetics, right? Either related to epigenetics or related to a technique. And then 4 MCQs were on inborn errors of metabolism, again with, I would say, ambiguous choices, right? Choosing the right answer would have been difficult for all of you, I understand that. And then in vitamins and fat metabolism, 2 MCQs each, and then the remaining MCQs got equally spread. Okay, so this is how the question was. Yes, Roy, many of you found the question to be difficult. I also find it to be difficult in the sense the way questions are being asked. So don't worry about it. Let's try to find out the answers. So I've divided the parts into the exact sequence in which I showed you in the first part. First, we'll finish all genetics-based MCQs, and then we'll discuss IEM-based MCQs. The steps of PCR are, this you all must have gotten it right. Yeah, so it is choice A, denaturation, followed by annealing, followed by extension. So you know PCR is a replication process. For any replication, the first step has to be denaturation. So the answer is choice A. If you had a confusion about hybridization is never a part of PCR. After PCR, if you're doing a hybridization step, then that is called the southern blotting, right? If you're amplifying DNA and then if you're hybridizing, then that's called as southern blotting. That's not a part of PCR, okay? Extension, elongation, both are the same, okay? Yeah. So then this MCQ, in rheumatoid arthritis patients, synovial tissue shows increased expression of TNF-alpha and interleukin-6, contributing to inflammation. Which epigenetic change most likely explains this? I will tell you the right answer first, and then I'll tell you why. The answer is inhibition of DNA methylation, right? The answer is choice B. Can you all hear me? I think one person is saying that the person is not able to hear Mohammed Sufyan. Am I audible? The answer is choice B, inhibition of DNA methylation. Okay, so the reason is, as you all know, methylation. 1 second. So as you all know, methylation of cytidine residues of CG islands, right? Methylation of cytidine residues of CG island can cause DNA silencing. So whenever there is demethylation or inhibition of methylation of DNA residues, that will cause overexpression of the gene. And overexpression of genes related to TNF-alpha and interleukin-6 will cause inflammation. So the answer here is, thanks all of you. The answer here is choice B, inhibition of DNA methylation. Okay. Cancer cells show increased length of a specific RNA transcript or fragment when compared to normal cells. The most likely reason for this is, the answer is choice B, alternative RNA splicing. Okay, the answer for this question is alternative RNA splicing. I will help you to understand how to answer such MCQs because this can be asked in your NEET PG as well, right? So how am I going to exclude other choices? I'm going to straight away exclude gene silencing because what is gene silencing? I've explained this in detail. It is down regulation of gene expression, wherein the number of times a gene is expressed is going to be reduced. So the number of mRNA can be reduced. It is not going to reduce or increase the length of the RNA. You understand this? It can only play with the number, not with the length. Similarly, gene amplification. What is gene amplification? Increasing the number of RNAs that are produced. Again, there is an increase in the number, not an increase in the length. When will there be an increase in the length? Only whenever abnormally more and more introns get transcribed, right? When will intron also get transcribed? Whenever the splicing is abnormal. So it is alternative RNA splicing that can cause an increase in the length of specific RNA that can cause cancer. Example is, have you all heard of BCLX? Right? BCLX is an apoptotic gene. And the product is BCLX protein, which causes apoptosis. Whenever there is an alternating splicing site, because of which a longer BCLX is produced, that is called as BCLXL, long, right? BCLXL, that becomes anti-apoptotic. When there is no apoptosis, that causes cancer, right? So BCLXL mutation or alternative splicing site resulting in BCLXL makes a person prone to develop breast cancer, lung cancer, and even colon cancer. Similarly, MDM2, alternating splicing sites in MDM2 can also cause cancer. Okay, so what is the right answer here? The right answer here is alternative RNA splicing. This is another interesting question. The question might look as if it's complex, but if you are mindful while you're reading this question, you'll be able to get the right answer. They've given you already M13 bacteriophage vector, right? So the answer should be logically phage expression, right? So M13 bacteriophage vector, it is actually a single-stranded DNA containing bacteriophage, which goes and infects the bacteria. But what is it used for? It is used to understand expression of a protein, which is called as phage expression. Okay, so M13 bacteriophage vector has been used in molecular biology to identify specific gene sequences, such as those related to the SARS-CoV-2 spike protein, through expression of the inserted gene fragment. So a gene fragment is inserted into the bacteriophage, and then the bacteriophage is expressing the protein. So what will you call it as? You will call it as phage expression. Okay. So if bacteriophage was not given, then it means you should know M13 is a bacteriophage vector. Okay. It's a bacteriophage vector. It is, it's a bacteriophage which infects E. coli. The answer is phage expression. I think they gave you that SCF protein here, right? Spike protein is SCF protein. Okay. So this question has been repeatedly asked in INI-CET. This was asked in INI-CET May 2022 also. And that is why I always ask you to watch all recall sessions. And even in May 2022 recall session, I explained this in detail, right? During B cell maturation in the bone marrow, only one of the immunoglobulin heavy chain alleles is expressed in each B cell to ensure that all antibodies produced by that cell has a single gene specificity. This process is known as allelic exclusion. So I've told you allelic exclusion is because of VDJ rearrangements. What is the right answer for this question? The right answer for this question is choice A, VDJ rearrangements. So those of you who are watching the session, watch this session continuously for the next 3 minutes. In the next 3 minutes, I'll help you to understand what is VDJ rearrangement, what is alternative splicing, what is alternative polyadenylation site, what is somatic hypermutation, so that in future, if you come across this MCQ, you will be able to answer this. Okay. So when you look at immunoglobulins, right? If you look at antibody structure, all immunoglobulins have 2 light chains and 2 heavy chains. And both light and heavy chains have variable region, right? They have variable region, which would determine antigen binding site. This determines the antigen binding site. And then there is a constant region. What does constant region determine? Constant region of light chain determines whether it's going to be a lambda type or kappa type of light chain. The constant region of the heavy chain will determine whether it is mu type. If it's mu type, it is IgM. If it is gamma type, it is IgG. If it's alpha type, it is IgA. Delta type, it is IgD. Epsilon type is IgE. So heavy chain and light chain, constant region will determine the type of heavy chain and the type of light chain. And if you look at this heavy chain, between the variable region and the constant region, you see a diverse region and a joining region. Okay. Now the gene which represents the heavy chain, of immunoglobulin is represented in long arm of chromosome 6. And if you look at the long arm of chromosome 6, there are 4 loci. The first locus is V locus, followed by D, followed by J locus, and finally constant locus. Okay, just this V locus has 300 alleles. I'm explaining what is allelic exclusion. So V locus alone has got 300 alleles. C locus, J locus, and C locus each have 5 alleles. Okay, each have 5 alleles. What are the 5 alleles of the C locus? I told you the allele that is close to the centromere is called as the mu allele, followed by gamma allele. Just now I told you gamma, followed by alpha, delta, and epsilon. Okay, so this is a heavy chain gene that is present in all your cells. Now, if a stem cell decides to become a B cell, the only criteria that it should satisfy is it should have an antigen binding site. Only when a cell has got an antigen binding site, it will be called as a B cell. Which is the antigen binding site on a B cell? That is surface IgM. For a cell to be able to express surface IgM, you should choose that particular B allele. For example, if a B cell decides to react against glycoprotein antigens, okay, then you should choose only one particular B allele. You should exclude all other alleles. This is called as allelic exclusion. So you choose one particular V allele, you combine it with one particular D allele, with one particular J allele to call it as VDJ rearrangement. After VDJ rearrangement is done, the remaining alleles are all excluded. And then the first allele that is seen in the constant region is mu allele. When this is expressed, that becomes surface IgM. So after VDJ rearrangement, the first antibody that as B cell starts expressing a surface IgM. The following VDJ rearrangement, surface IgM is expressed, then it is called as the B cell. Okay, so this is called as allelic exclusion. And then once this B cell gets exposed to an antigen, it should start secreting secretory IgM. Now it is surface IgM. Now it should start secreting secretory IgM if it's for the first time the B cell has been exposed to this antigen. What is the difference between a surface IgM and a secretory IgM? As long as an IgM has got an adsorption site, as long as it has an adsorption site, it will be a surface IgM. Once there is no adsorption site, it becomes a secretory IgM. Okay, so how will you be able to convert surface IgM to secretory IgM? The chosen B allele will be expressed, the chosen D allele will be expressed, the chosen J allele will be expressed. When the mu allele is expressed, the poly A tail gets added well ahead. When the poly A tail gets added well ahead, the terminal adsorption site will not be expressed. When there is no adsorption site, it becomes a secretory IgM. How will you miss the adsorption site? That is by alternating polyadenylation site. So alternating polyadenylation site will shift from surface IgM production to secretory IgM production. Okay. Whereas if it's for the nth time your body is getting exposed to an antigen, then your body should start producing IgG. For it to be producing IgG, what should it do? It should express the B allele, D allele, J allele. Mu allele should be expressed. Gamma allele should also be expressed. And then the poly A tail gets added. But this mu allele should be spliced out. Right? The mu allele should be spliced out. Only then it starts producing IgG. This is called as alternating splicing sites. So whenever you alternate splicing sites, you start producing other types of antibodies, IgG. If you want IgA, surface immunity, I want IgA. What will I do? I express mu allele, I express gamma allele, I express alpha allele, and then I add poly A tail. And then I splice out gamma sequences and mu sequences. That is how I start expressing surface antigen, surface IgA. Okay. So by alternating splicing sites and by alternating polyadenylation site, I will be able to produce all types of antibodies. That is called as isotype switching. You understand this? This is called as isotype switching. What do you mean by isotype switching? The allelic part is maintained, meaning the B allele is maintained. I'm only changing the constant region. That is called as isotype switching. Okay. And then when I make more and more mutations in the V locus, that is called as somatic hypermutation. The somatic hypermutation will cause affinity maturation of B cell. So that after that, this B cell is it is destined only for one particular antigen. That's called a somatic hypermutation or affinity maturation of B cell. So whenever they ask you about allelic exclusion, what is responsible for allelic exclusion? It is BDJ rearrangements. Okay. And if the question is what is the technique that is used to detect VDJ rearrangement, then that is Southern blotting. Because only by Southern blotting, you will be able to identify DNA sequences. VDJ rearrangement happens at DNA. And then if they ask you if there was Northern blotting, that is also possible. But it's very difficult. If you see both Southern blotting and Northern blotting, I would go for Southern blotting. Okay. Vitamin deficiency. So that's all about genetics. It was not that difficult after I explained, right? So it's all about being mindful, applying your knowledge and trying to answer the MCQ. Which vitamin deficiency causes the conversion of 3-hydroxykinine to xanthurenic acid? The answer is pyridoxal phosphate. This we have discussed so many times. Kinineurinase. The enzyme is kinineurinase, which is B6 dependent. When that enzyme is defective, the precursor 3-hydroxykinine gets converted to xanthurenic acid. No, ELISA cannot be used. The answer is Southern blotting. Okay, answer is pyridoxal phosphate. Which of the following is true about Gaucher's disease? Can you try to answer this question? B and D. We all know this for sure. Gaucher's disease is caused by the defect of beta glucosidase and it is characterized by crumpled tissue paper appearance. So the answer is B and D. Foamy macrophages are not seen in Gaucher's disease, right? Foamy macrophages are seen in leprosy, it is seen in tuberculosis, it is seen in Whipple's disease, not in Gaucher's disease. 2025 Nobel Prize in Medicine is awarded for peripheral immune tolerance, right? The latest Nobel Prize was offered for identifying peripheral immune tolerance. We have something called as Treg or Reg-T, regulatory T cells, which are responsible for immune tolerance. Particularly, they received this Nobel Prize for their work on FOXP3 gene. Mutation of FOXP3 gene is the most common cause for all autoimmune disorders. So that is about this MCQ. Match the following amino acids with their derivatives. I've already matched it. Tyrosine has to be matched with thyroid hormone. Tryptophan becomes serotonin. Serotonin becomes melatonin. For creatine, the mnemonic that I told you is, this is an LRR session I told you. Creatine, it is gain. Glycine, arginine, and methionine, right? So glycine is necessary for creatine synthesis. Cysteine is necessary for taurine synthesis. So this is the link: tyrosine with thyroid hormone, tryptophan with melatonin, glycine with creatine, cysteine with taurine. Plasma magnesium levels are maintained by, this also we discussed, right? Plasma magnesium levels are maintained principally by renal reabsorption, right? It is absorbed along the intestine. 30 to 50% of dietary magnesium gets absorbed constantly. The intestinal absorption is not controlled. It is only the renal reabsorption that controls the magnesium level. So the answer here is renal reabsorption. Deficiency of which enzyme leads to increased 2,3-BPG levels and low glucose values in vitro? So this is a very tricky MCQ. I know most of you would have answered it as pyruvate kinase defect, because I told you in pyruvate kinase defect, the precursor 2,3-BPG would accumulate. But they've given you low glucose values. Look at this. If it was pyruvate kinase defect, right? The block is here. If it was pyruvate kinase defect, as the precursor 2,3-BPG would accumulate, but glucose level should have been high. What have they told you? Glucose level is low. Hence, the answer is phosphoglycerate kinase defect. What happens whenever there is a phosphoglycerate kinase defect? The defect is here. When the defect is here, the precursor 1,3-bisphosphoglycerate can become 2,3-bisphosphoglycerate, causing elevated 2,3-BPG levels. And you know, phosphoglycerate kinase is an enzyme of gluconeogenesis. So when that enzyme is defective, gluconeogenesis cannot happen and there will be low glucose. So what is the right answer here? The right answer here is phosphoglycerate kinase defect. Okay, answer is choice B. A 6-month-old boy presented with doll face, hepatomegaly, acidosis, anemia. Diagnosis was confirmed by light and electron microscopic examination of liver biopsy specimen. They've given you the diagnosis. I don't know if this is exactly what they had given you. I know that clinical features were given for glucose 6-phosphatase deficiency. And which of the following is the characteristic lab finding in this condition? Okay, so what would be your answer? Was it the most common lab finding or was it the most characteristic finding? Can anybody give me the answer? Yes. Was it the most common finding? If the question was most common finding, then the answer would be fasting hypoglycemia. But had they asked you which is the most characteristic lab finding, then I would say high cholesterol. Because there are so many conditions, so many glycogen storage disorders which can present with fasting hypoglycemia, low ketosis, high lactate, all these are found. But the only disorder wherein cholesterol level is high and triglyceride level is high among glycogen storage disorders would be von Gierke's disease. If it was most common, then it is fasting hypoglycemia. Okay, the answer is very simple. It is fasting hypoglycemia. Which intermediate of the citric acid cycle is used for fatty acid synthesis? We have discussed this, right? Fatty acid synthesis, the precursor is acetyl-CoA, right? But acetyl-CoA is formed only in mitochondria. As such, acetyl-CoA cannot cross the mitochondrial membrane. So I said acetyl-CoA reacts with oxaloacetate to form citrate. And only a citrate, it crosses the mitochondrial membrane. In cytoplasm, citrate becomes acetyl-CoA, then it enters into fatty acid synthesis. So what is the right answer? The right answer here is citrate. Okay. A patient with megaloblastic anemia, this also we discussed in LRR session. A patient with megaloblastic anemia is mistakenly treated with folate supplementation alone. And I told you that will aggravate neurological manifestations. The reason for this is folate trap, right? What is the answer here? The answer is folate trap. And for those of you who want to know why, right? So B12, there are two forms of B12. One is adenosyl B12. The other one is methyl B12. Methyl B12 acts as a coenzyme for methionine synthase, which converts homocysteine to methionine. Okay. And methyl B12 gets its methyl group from methyl tetrahydrofolate. Okay. Now, adenosyl B12 acts as the coenzyme for methyl malonyl-CoA mutase, which converts methyl malonyl-CoA to succinyl-CoA. So tell me what happens in B12 deficiency. I'm going to write it here for you. Whenever there is B12 deficiency, all tetrahydrofolate get trapped as methyl tetrahydrofolate. That is called as methylfolate trap. This causes folate deficiency. That folate deficiency causes macrocytic anemia. When there is B12 deficiency, then adenosyl B12 is not available. Methyl malonyl-CoA accumulates. That causes methylmalonic aciduria. This methylmalonic aciduria is responsible for neurological manifestations. So all of you, those who are watching this session, B12 deficiency causes both macrocytic anemia and neurological manifestations. Macrocytic anemia is because of methylfolate trap. Neurological manifestations is because of methylmalonyl-CoA accumulation. In this scenario, a person is treated for megaloblastic anemia or macrocytic anemia with only folate. In that case, all folate would become methylfolate. All methylfolate will transfer the methyl group to B12, forming methyl B12. So any B12 that is available becomes methyl B12. There is nothing to form adenosyl B12. When there is no adenosyl B12, methylmalonic acid accumulates more and more. That aggravates neurological manifestations. That is why I told you in B12 deficiency, supplementing with folate alone should be avoided because that will aggravate neurological manifestations. That is because of methylfolate trap. You all understand this? So the answer here is methylfolate trap. Okay. Now this question is about G6PD deficiency, right? And the question is features of HMP shunt are. What is the right answer? This also we discussed in LRR. I said HMP shunt is one pathway wherein ATP is neither utilized nor produced, right? So this is false. And I told you it generates ribose 5-phosphate and NADPH, not NADH. This is also false. Okay. Trans-ketolase requires thiamine. Yes. Trans-ketolase is an enzyme of HMP shunt which needs thiamine. And then I told you HMP shunt happens in two phases. The first phase is an oxidative phase, which is irreversible. The next phase is a non-oxidative phase, which is reversible. So non-oxidative phase is reversible. So which is the features of HMP shunt are? So answer is it does not produce ATP. That's a true statement, right? Trans-ketolase requires thiamine as a cofactor. That's a true statement. So 1 and 3 are true. Non-oxidative phase is reversible. If that was the choice, then that is also true, right? If they had given you non-oxidative phase is reversible, that is true. In that case, there are three choices which are true. It does not produce ATP. Thiamine is necessary as a cofactor, and then non-oxidative phase is reversible. Okay. Three choices which are true. So what is the transporter used across cell membrane? Does this image depict? Okay. So what have they shown you? They've shown you here transmembrane domain. And this is a nucleotide binding domain, which binds ATP. It hydrolyzes ATP. And thereby it is moving the drug outside. Okay. So this is an ATP binding cassette transporter. And you know, ATP binding cassette transporters are all examples of primary active transport. So that is P-glycoprotein. The answer is P-glycoprotein, which is a drug efflux protein. Okay. So how did I exclude all other choices? GLUT transporter, you know, is an example of facilitated passive diffusion. Passive diffusion does not need ATP. Sodium glucose cotransporter 1 is an example of secondary active transport. Secondary active transport is also not going to hydrolyze ATP directly. Okay. Organic anion transporter, again, indirectly is dependent on ATP. That is why what is the right answer here? The right answer here is P-glycoprotein. The option was, yeah, the answer is choice A. It is P-glycoprotein because it is the primary active transport that you have shown here. It's a drug export protein, drug efflux protein. Which of the curves represent diabetes mellitus? There are two curves, D and E. Okay, D and E both represent diabetes. How to answer such MCQs? Okay, if they're asking you diabetes mellitus curve, find out what is the fasting plasma glucose. So look at it, fasting plasma glucose. The criteria for diabetes is it should be more than 126 milligram per deciliter. So if it's more than 126 milligram per deciliter, that is when you can call it as diabetes. That way, only two curves meet the criteria. Another criteria for diabetes is 2R, right? 2R postprandial glucose should be more than 200. So where do you see that? More than 200 2R glucose. Again, that is met by only two curves, D and E. So what is the right answer here? The right answer here is D and E. C is not diabetes. Why am I saying it is not diabetes? What is the fasting plasma glucose here? It is so low. Okay. And then there is a quick rise in glucose that crosses the renal threshold. So glucose will be found in urine. And then there is a steep fall. So whenever you see a steep rise and a steep fall and the glucose level crosses renal threshold quickly, that is alimentary glycosuria. Do you understand this? C is alimentary glycosuria. The answer here is D and E because they asked you only about diabetes mellitus. Okay. Have you all understood this? Which is not true about Conn syndrome, right? So Conn syndrome, you know, is primary hyperaldosteronism. So if it is primary hyperaldosteronism, you know aldosterone causes sodium and water reabsorption. So it causes hypernatremia and it causes potassium and H plus secretion. So it causes hypokalemia and metabolic alkalosis. This also we discussed in LRR. Conn syndrome or primary hyperaldosteronism presents with hypernatremia, hypokalemia and alkalosis. So what is the right answer? Hyponatremia is not true. B was not in the option. So was there edema, which is an option? Because Conn syndrome does not present with edema, though there is hypernatremia because of escape phenomenon. Okay, it is not a feature. Because of escape phenomenon, edema or hypertension cannot be a feature, though there is hypernatremia. You all understand this? You should remember about escape phenomenon. Atrial natriuretic peptide causes diuresis. That is why for a very long time they don't present with hypertension. This is the last MCQ, 19th MCQ. Which of the following is not true about beta oxidation of fatty acids? Okay, it is not true. The answer is choice A. ATP is utilized in the transport of fatty acids across mitochondrial membrane is a false statement. Okay, because we know carnitine acyl transferase 1 and carnitine acyl transferase 2, both these are involved in the transport of fatty acids across mitochondrial membrane. Carnitine acyl transferase 1 is present in the outer mitochondrial membrane. When it takes acyl-CoA, converts acyl-CoA to acyl-carnitine, releasing CoA. Okay, so CoA is released in the cytosol while forming acyl-carnitine. And then carnitine acyl transferase 2 is present along the inner mitochondrial membrane, which releases the carrier. So carnitine is released in the mitochondrial side. So what is the right answer here? The right answer here is escape phenomenon is something which happens in Conn syndrome. Conn syndrome is primary hyperaldosteronism, which first causes sodium and water reabsorption. That causes water retention and hypertension. But because of an increase in the intravascular volume, atrial stretch happens. Atrial stretch receptors get activated. They release atrial natriuretic peptide. That atrial natriuretic peptide causes diuresis. And because of this diuresis, edema and hypertension are not a feature of Conn syndrome. You all understand that? Neeraj Singh. So the answer here is ATP is utilized in the transport of fatty acid across mitochondrial membrane. That's a false statement. The other three statements are true. Okay. So to summarize, there were 19 MCQs in biochemistry. Most of the MCQs were in genetics. We discussed about epigenetics, probably not in the exact form of question that was asked, but I told you about methylation of cytidine residues. We discussed about histone acetylation and impact on gene expression. So when it comes to INI-CET, it is not going to be the exact fact that you learn. Based on the fact they twist the MCQ and they ask you. That is why just being mindful during the exam is enough. But having said that, right, you're done with your exam. You have given your best. So now it is not the time for you to repent about how you should have behaved during the exam, right? So you have done your best. The rest universe takes care. Now it is time for you to relax and just watch these recall sessions to understand what is the right answer, so that in case, right, most of you will be attempting the NEET PG exam, the upcoming NEET PG exam or the next INI-CET exam. The next time you don't commit such mistakes. Okay. So all the best. See you sometime soon. Thank you.
you're live.
Hello, friends. Welcome to the analysis now. So, your INI-CET exam this year, talking about OBG. Not many questions were there, but that's okay as long as you attempted them all correctly, right? So there were how many questions so far? I think we've got 9 questions of OBG. So let's see. And start with the analysis, and I will have a look at your chats as well, so that since these are recall questions, you will have to give authenticity to the recall also, because you'll have to tell whether those questions are correctly recalled or not, and then you'll also have to tell the answers as well at the same time. So what we actually saw with the OBGY paper this time, the questions were mainly from your previous year exams only. Previous year questions were there, previous year topics were repeated, right? So it was fairly straightforward in that sense, and not much difficulty in OBG paper so far. So which of the following instrument combinations is typically used during a lower segment cesarean section, right? And I believe that the options were given to you as multiple, options were placed like this, right? So we all know that the Doyen's retractor is definitely used to retract the bladder, right? Your green armitage forceps are also used. They are the forceps that are used to hold the uterine angle. We know that as well, right? And your Alice forceps are used, your scalpel and BP handle definitely is used. So your correct answer to this question is option number A, right? So Shirodkar's clamp is not used at all. I mean, it is used in gynae surgeries, but it is basically a uterine holding clamp that is used, right? It is not used during cesarean section, and definitely your Cusco speculum, we all know, is not used at all, right? All right. So the options and question is correct. Can we get a feedback on that? Yes. Can we get it in the chat box that this question has been recalled correctly? So I think this was a correct recall of the question. So we can move ahead with the next question. A 30-week primigravida presents with placenta previa. So again, APH is a very important and hot topic. It has been for all your exams. I mean, be it INI-CET or be it your NEET PG or be it your FMG also, right? So 30-week primigravida presents with placenta previa and complains of mild vaginal bleeding. Her blood pressure is 110 by 70 mmHg, right? So placenta previa, mild vaginal bleeding, blood pressure 110 by 70, fetal heart rate is 140 beats per minute, and there are no uterine contractions. What is the most appropriate next step in management? So what did we mark for this? Yes, anybody responding? What did we mark for this? Now see, here the woman is also stable, right? And the bleeding is also mild. She's preterm as well. She's preterm as well, as we can see here, right? And the mother and baby otherwise are doing well because the fetal heart rate is also okay. She's not in labor also, not in labor, right? And we all know that when there is bleeding from placenta previa, the first episode of bleeding is usually the warning hemorrhage, right? So right now, what would be the good idea? Yes, very good. I think you all have attempted it correctly. If you've managed, admit and manage expectantly, right? So we can see that all the criteria for expectant management are there. Okay, you may have gotten confused possibly
maybe with mild vaginal bleeding, but here right now it is the first episode of bleeding. She's preterm, we'll admit her, and we'll have the opportunity to at least, start with the steroid administration for lung maturity of the fetus. So that would be the appropriate next step in management, right? If bleeding continues despite, conservative management, or if she were to go into labor or contractions would start while on the conservative management, or she starts becoming hemodynamically unstable or the fetus distress starts happening, I mean, then we would have thought of taking up, dropping the or stopping the conservative management and taking up for cesarean section. So that would have been a different scenario. But for now, next step would be admit and manage expectantly. There is no question of labor induction at all. Placenta previas are delivered by cesarean section, and so not immediate cesarean section. Immediate cesarean delivery would not be the answer right now, and definitely no amniotomy to augment labor. So no vaginal deliveries in placenta previas, right? So this is an easy question, I would say, clinical, but you all have, if you've seen my LRR sessions also, then this is something, APH is something that we discuss in detail. Next question. A 40-year-old woman presents with intermenstrual bleeding and the transvaginal sonography shows an endometrial thickness of 15 mm. So they have been repeating this question over and over again. So I hope that this question has been attempted correctly by you people. What is the most appropriate next step in evaluation? Yes. So yeah, 45 years old, if they say 45, the answer would not change, right? ET is 15 mm, that is, more than 12 mm in reproductive age group. Now 12 mm is the cutoff in reproductive age group. So 45 years old, answer would not have changed. She's also having intermenstrual bleeding. Intermenstrual bleeding, I keep telling you, is a very specific complaint which goes in favor of some endometrial pathology, right? So a good idea would be to go for hysteroscopy and endometrial biopsy. I believe that these two options were given together. The options were hysteroscopy and endometrial biopsy. I think that was there. 40, 45, it's okay. It's a recall thing. It doesn't matter if it was 40 or 45 years. You were saying that one of the option was pap smear and endometrial biopsy. Was it like that? One of the students is saying it was pap smear and endometrial biopsy, not hysteroscopy and endometrial biopsy. Or are you confusing it with two different set of questions? Because I have a recall question in which they are talking about atypical cells, right? Okay. Now, Deeman, what are you saying? No different given. I mean, they were given separately, hysteroscopy, endometrial biopsy. Was it like that, or were they placed together? So we are not proceeding to hysterectomy directly. That much is clear. We're not starting empirical hormone therapy without ruling out endometrial pathology. That much is clear. Possibility of hyperplasia, endometrial hyperplasia could be there, right? Similarly, we are not prescribing Mirena, or we're not introducing Mirena without having a histopath of the endometrium, right? So these three options are anyways ruled out. Okay, so hysteroscopy and endometrial biopsy was there, or what was there? Even if it was pap smear, like somebody saying it was pap smear and plus biopsy. Hysteroscopy and curate was one option and endometrial biopsy was another. See, there again, I'm getting multiple, these things about the multiple recalls here, which and none of the recalls are, similar. So you're saying that hysteroscopy was a separate option. Okay. And endometrial biopsy alone given and hysteroscopy plus curettage was given. Are you sure? Because one of the students' recall was that there was dilatation and curettage that was given. There was was it dilatation and curettage or hysteroscopy plus curettage? What was it? See, we have to do endometrial biopsy. We have to do endometrial biopsy. Whichever option had endometrial biopsy, that would be your answer. So if it was pap smear plus endometrial biopsy, that would have been your answer. Okay, maybe hysteroscopy was given separately. Okay, priority is to go for endometrial biopsy. And if it was given along with pap smear and endometrial biopsy would have been your answer. Okay, and if it was different alone, like for example, if you're saying A option was endometrial biopsy, B was hysteroscopy, then your answer would have been endometrial biopsy. Okay. If it was hysteroscopy and curettage, was there an option like this, hysteroscopy and curettage? Was there an option as hysteroscopy and curettage? Yes. Okay, so you are saying these were the options. It's EB and one was hysteroscopy and curettage. Was it like this? Were these the two options? Endometrial biopsy alone, hysteroscopy and curettage was there? If these were the two choices and you were confused between these two choices, then hysteroscopy and curettage would be your answer. Okay. All right. If these two were there and you had to choose one, then hysteroscopy and curettage would become the answer. Wherever the curettage is there, that would be the answer. If hysteroscopy and curettage was there, then this would be the answer. And I would say why hysteroscopy and curettage would be a better answer, because she's also having intermenstrual bleeding. Again, I keep reminding you, intermenstrual bleeding, very specific for endometrial pathology, could be, and with a thickened endometrium and thickened endometrial lining, could be the possibility of polyps also, endometrial polyps also. So better would be, rather than to go blind endometrial biopsy, hysteroscopy and curettage would have been a better answer if these two were there together. Okay, if these two were there together, then, right? So again, coming from recall, if the recall that I have gotten, hysteroscopy and endometrial biopsy was the answer according to the options that I am provided with, based on, again, students' responses of the recall, right? But since you are saying that maybe the options were different, then I have discussed with you, the answer would maybe look a little bit different if options were placed differently. Okay. All right, Akshay. Fine. So we've discussed this. Endometrial biopsy was a standalone option, and hysteroscopy and endometrial biopsy were not given together. So then again, answer would change if they were not placed together. Okay. All right. Priyank Kohli, best answer if EB and hysteroscopy and curettage. If these two options were also there like this, separately placed, I'm writing it down, A and B separately placed, then this would have been the answer. If these two were there, then you would have chosen hysteroscopy and curettage. Okay. Fine, Priya Kohli. Okay, can we move ahead with the next question? Yes, we move ahead with the next question. All right. Okay. A 30-year-old woman presents with intermenstrual bleeding. So there's one symptom of intermenstrual bleeding. Her pap smear report shows atypical glandular cells. Atypical glandular cells. What is the most appropriate next step in management? Yes, what have you chosen? Are these options looking correct to you? She's 30-year-old. Okay. She is having symptoms. She's symptomatic also, and she has atypical glandular cells, right? So pathology is also there. Screening is positive, right? So repeating the pap smear makes no sense right now. We have to investigate further. Okay. Now, conization would be out. She's young and 30-year-old. I mean, I don't think an complete conization at this point in time is necessary. Hysterectomy is definitely out. Definitely out. Right. So answer becomes colposcopy with endometrial sampling. Right. So we have atypical glandular cells. Right. Whenever we have glandular cells must be coming either from, they must be coming from the endocervical region. That is where glandular cells will come from, right? And she's having intermenstrual bleeding also, so endometrial pathology could also be there. So if you look at the patient in totality, right, you need to evaluate her cervix also, you need to evaluate the ectocervix as well as the endocervical canal, as well as evaluate the endometrial lining, right? So that is the reason why your answer becomes colposcopy with endometrial sampling, right? So again, what do we see the pattern? Again, they've been asking you about postcoital bleeding, intermenstrual bleeding, and abnormal uterine bleeding. Such clinical scenarios, they have been asking you repeatedly in your exams, right? And the conceptual understanding of these topics is very, very important. And then if you know the concepts, you generally will pick up the right choice answer, right? Okay. So yes, it will be C. The correct answer would be C. Okay. And such patients also need endocervical curettage also. Such patients also need endocervical curettage as well. Okay, so we move with the other question. We move with the next question. This one is done. We can wrap it up. Or any other feedback regarding the options? Any other feedback regarding the options or the question? Or we can, wrap this question up and move on to the next one. Yes? All right. So I think we should move on with the next one. All right. At what time is immediate postpartum IUCD insertion ideally performed? So, what do we make of this question? Yes. What is the answer? What have you chosen? Yes, immediate postpartum IUCD insertion ideally performed as when? So this is something that I really had to, again, this becomes a little controversial as to what the examiner is wanting to ask here. Because typically when you say postpartum is after delivery, right? And your 24 to 48 hours after delivery means within 48 hours postpartum, we can insert copper T. That is correct. But they're asking ideally, what I mean, see, this is a recall question. You'll have to help me out a little bit here. What were the exact words in the question is something that we're struggling with, right? Because if they had mentioned ideally, and they have mentioned immediate, words like this have been mentioned, like immediate postpartum, ideally. See, the best situation would be that after placental delivery, within 10 minutes you put. That would be the ideal situation. Okay. So this would be, then by that logic, answer would be A. Okay. So if ideally they have mentioned and immediate they had mentioned, then within 10 minutes of placental delivery would be the answer. Okay. Yeah, if words like ideally or immediate postpartum mentioned was there, then, or immediate was not mentioned, ideally was mentioned, then within 10 minutes of placental delivery. Okay, because that is what also the government of India is actually promoting. Okay, fine. Because see, it is an ideal time. Okay, immediate was not there, ideal was there. Okay, immediate was not mentioned, only ideally word was given. Then also answer would have been A. It is a better ideal time. Why? Because, placenta is just delivered, patient is there already with you, in front of you, right? And it's an easy insertion technique in the sense that the os is still, open, and using the sponge holding forceps or Kelly forceps, those are specially designed forceps. In the labor room itself, at the same time, the insertion can be done. So that is why it becomes a more ideal of a scenario, okay, more ideal of a situation to insert. Okay, so that's why if they have mentioned ideally, then go ahead with option number A as the answer. Okay, within 10 minutes of placental delivery. Okay, so do we move with the next question? All right, wrap this question up, move ahead with the next question. Okay, it didn't say 10 minutes, it said post placental. हाँ तो post placental भी सही है ना? This means the same thing. If Alicia, if they had said post placental insertion, then that's also fine. That would be your answer. If 10 minutes was not mentioned, if they had mentioned post placental insertion, then that would have been your answer. Right? So post placental insertion, we can do this question, we can do the insertion, let's say during cesarean also, during cesarean after placental delivery, we can do the post placental insertion at that time also. It doesn't matter vaginal delivery, it doesn't matter if it is a cesarean section. Okay? All right. So again, you people are recalling differently. So that is why this is always happens with the recalls, so I can give you the most approximate answer with this, right? So again, this became controversial because none of the people have recalled it entirely, and 100% recalls we don't know now how, because you have given the paper. So if you are saying that option was post placental insertion, then that would be your answer. Okay. Fine. But yes, postpartum insertion, within 48 hours we can do, but ideally post-placental would have been the better answer if you had to choose between the option A and option B, if you had to choose. Okay? Okay. Shall we move to the next question? Wrap this up. Shall we move to the next question? Wrap this up. This question is done, dusted. We're clear with this. Maybe at a later point in time, if we get more accurate recall on this as to exact wording of the options, as to the exact wording of this of the stem of the question, it would be different. But I think for now, I think this should be your best choice answer. Next question. Which of the following is not typically used to assess ovarian reserve? So what did you mark here? AMH is used, we know. Antral follicular count is also used, we know, and FSH we know. We also use that. What did you use here? What did you mark here? The answer would be estradiol. Estradiol would be the answer. Okay, so serum estradiol levels, that's as standalone test, they are not, we don't typically use it. Okay, we don't typically use it. Okay, early follicular estradiol. Okay, if they had mentioned, koi baat nahi, early follicular estradiol. If that was also mentioned, no worries, that would have been your answer. That would have been your answer from among the options provided, right? So whenever we have, when we have a reproductive, reproductive aging, that is what we're talking about. Now, older women, ovarian reserve is falling. So those follicles, the smaller antral follicles, and early follicular phase FSH, early follicular phase FSH, you are saying this was the other option, right? So follicular phase, that means we do not day 3 estradiol, we do day 3 FSH. Okay, so that would also fine, no? Day 3 estradiol, day 3 FSH, right? That is what we do. So let me just make you understand that estradiol as a standalone test is not going to be very useful, because estradiol levels will fall down very late in reproductive, in years, a couple of years after menopause, they fall down to postmenopausal levels. In fact, with reproductive aging, early follicular phase estradiol levels are slightly on the higher side. See what is happening when we have declining ovarian reserve. When we have declining ovarian reserve, what is happening is that the inhibin levels, okay, the inhibin levels are decreasing. Okay, because inhibin is coming from the smaller antral follicles, right? The residual follicular pool and the smaller follicles that are growing. So inhibin decreases, and that is why there is less of inhibition, less of feedback inhibition on the pituitary during the early follicular phase of the cycle, and FSH is on the higher side. FSH is on the higher side. Day 3 FSH is on the higher side. FSH is more sensitive here. It is going to rise first, all right? And with FSH rising early on in the cycle and higher levels of FSH, the follicles will go faster. At a faster rate, they would grow. And in fact, there will be day 3 estradiol levels initially will be higher. Initially will be on the higher side, right? So in clinical practice, I think FSH is something that we use more often, and actually we take the FSH and estradiol ratio into consideration, you know, when we are, assessing the ovarian reserve for these patients. We are actually taking FSH and estradiol ratios into consideration. Here they had asked you which is not typically used. You had to pick one best answer. One best answer would be estradiol. Okay. All right. It is not typically used. They had asked not typically used. Okay. Most commonly used, and something that is most preferred used is actually AMH, is actually serum AMH levels. Okay. Divyesh. So in this question, the single best answer would be option number B. All right. So done and dusting with this question. Let's move on to the next question. 30-year-old woman experiences PPH following a normal vaginal delivery. Despite uterine massage and uterotonics, bleeding continues. Most appropriate next step in management. See, they asked a similar question in your previous exam, right? Where it was post cesarean or during cesarean section. And we've discussed this in the LRR sessions also. We discussed this in the rapid revision lives also. So what is the most appropriate next step in management? Yes, it's hysterectomy is the last resort. Okay. Artery embolization is something that we consider in, stable patients and, with very little of ongoing bleeding and everything. And here they are, the kind of profile they are mentioning is that the uterotonics are exhausted. So the uterus is still atonic, and despite uterine massage also. So now you have to go ahead with balloon uterine tamponade. So balloon tamponade would be your answer. Very good, right? So I think that's fine. And devascularization surgeries, they would need a laparotomy, and we have one choice right now. She's delivered vaginally. We would want to avoid a laparotomy straight away, so we can attempt a balloon uterine tamponade, right? And this is not the answer, right? So here, no doubts about the options and questions, I believe. So this is fine. We'll move on to the next question. A 24-year-old primee presents with blood pressure of 150 by 105. So she's hypertensive, definitely. Which of the following are symptoms of developing eclampsia in the future, right? And again, time and again, with the clinical questions, with direct one-liners, we have discussed this so many times. The signs and symptoms of impending eclampsia. Signs and symptoms of impending eclampsia. Okay, so many times we have discussed this. This should not be wrong, right? All of these is not the answer. Persistent pedal edema will not be a sign and symptom of impending eclampsia. It's headache, blurring of vision, epigastric pain, right? So it answer would be A, B, and C. Okay. Persistent pedal edema would not be
a symptom of impending eclampsia. Okay, fine. Headache would be a sign and symptom, blurring of vision, it would be there, epigastric pain would be there. Okay, fine. So why are we picking B? Which of these are symptoms of developing eclampsia in the future? Yes, epigastric pain as a sign and symptom of impending eclampsia. Right hypochondriac pain, epigastric pain, yes. Liver involvement in severe preeclampsia cases, yes. That happens, right? And the stretching of the liver capsule, the periportal hemorrhages that happen, and because of that, there is stretching of the liver capsule that causes epigastric pain. So a woman with severe preeclampsia starts mentioning epigastric pain or right hypochondriac pain, it goes towards pointing that hepatic involvement is going on, and hepatic involvement again is a sign of severe preeclampsia, right? And is considered as a sign and symptom of impending eclampsia. That's why C will also be there. Okay, fine. Chalo. So this is your answer here, right? And why pedal edema will not be there? Because persistent pedal edema will not be there. No, pedal edema is not even a prerequisite to make the diagnosis of preeclampsia. Okay, it is not even in the diagnostic criteria. Yes, women with preeclampsia, they have a lot of edema, pathological edema is there. They may even have generalized facial puffiness and everything, right? But it does not quantify severity. It does not quantify severity. Degree of proteinuria also does not quantify severity. Okay, what quantifies severity? Headache and blurring of vision. Headache meaning that cerebral edema or cerebral hyperperfusion is setting in. Okay, this headache is because of cerebral hyperperfusion. And recall that this cerebral hyperperfusion has a predilection for the occipital lobes. So that's why blurring of vision also, right? That is why these three are very, very important. Headache, blurring of vision, epigastric pain. Okay, fine. All right. So now that we have answered all your doubts regarding why C, why B, and why A, let's move on, and why not D. Let's move on to the next question. All right. Which of the following is the most likely causative organism for the cervix as shown in the image? Now in the LRR session, in the rapid revision live, this is the question that I gave you people, and I hope all of you have attempted it correctly. This is strawberry cervix, right? And the causative agent is Trichomonas vaginalis. Very simple, straightforward question. Trichomoniasis, again, genital infections are a very hot topic again. They repeatedly ask about it. Generally, they ask kit-based questions. This time, they have asked simple question on the diagnosis. They generally also tend to ask your treatment and management and next steps. But this is your answer for this question, right? So fairly simple questions, but yes, some confusions you made regarding so one question which I will say was very close would be again the ovarian reserve question, and controversial based on what exactly the examiner wanted to ask was with this IUCD insertion, right? So we are just guessing now that the examiner who set up the paper wanted to ask that, ideal circumstances would be that, it is done in the labor room after the placental expulsion. And when we do it after placental expulsion, which we call as post-placental insertion, we do it within 10 minutes. So that is there. And again, you people raise some doubts about the way the options have been recalled for the particular question on endometrial biopsy. So I've told you the reasons why the answer may change depending upon the combination of options that were provided to you. All right. So all in all, good questions from OBG, but yes, less questions. I hope that you have attempted them correctly. They were doable, definitely so, right? Would we say that the obs gynae questions were doable? They were clinical questions, but still they were doable with the concepts. So few direct questions and few clinical questions coming from OBG, as they maintain always, and they've stuck to the previous year topics in the important areas. Is where they have framed questions from, right? Repeatedly, they are asking you, woman comes with symptoms like postcoital bleeding, abnormal bleeding, intermenstrual bleeding, and all they are and they will frame it in different permutation combinations of the stem of the question or of the options. And again, with conceptual clarity, you will be and should be able to attempt them. And thank you so much. You've benefited from the recent LRR session. I'm very glad that that was helpful to you people. So I will end this discussion now. The OBG part is done, and you can continue with your rest of the recalls, right? All the best.
Hi everyone, this is Dr. Vaishnavi, and we are here to discuss the ENT questions. As far as ENT is concerned, core ENT questions were typically from what we've already discussed during the classes and during the RR sessions and during the LRR sessions. But if you look at some overlaps between the anatomy and ENT, there were a few questions which were a little different and unusual. So let's begin with the first question. We have a 65-year-old male who's come with hearing loss in the high frequency region. Which part of the cochlea is affected? So clearly they have mentioned about high frequency hearing loss, and we have already discussed during our sessions that the basal turn of cochlea is responsible for recognizing high frequency sounds, and the apical turn of the cochlea is responsible for recognizing the low frequency sounds. So we've already done this, which is called as tonotopic organization of cochlea, and we have discussed this multiple times, innumerable times, whether it was in physiology of hearing or Meniere's disease, we've discussed this. So we know that the basal turn recognizes high frequency. So when there is a high frequency hearing loss, we know that the turn to be affected is the base of cochlea. So I think that this is not something new, and this is a question which has occurred in the past, and we have seen this question occurring in the past as well. So this, I think, I'm sure that almost all of you have answered it rightly. If there's any difference in the language of question, or if you think any other options were given, please feel free to answer in the chat box, and we'll go to the next question. So we have a question here, which again we have discussed in the LRR series and in the rapid revision series multiple times on carcinoma of larynx. And I've been time and again telling you that this is a very, very, very important topic when it comes to exams. So here they have given a question on carcinoma larynx where they have told you that there is involvement of right true cord and the anterior commissure, left 1/3 of the vocal cord involving the paraglottis and involving the inner perichondrium of the cartilage, thyroid cartilage. So the right vocal cord is fixed. So what are the clues given here? There is a carcinoma. It is involving the right side true cord, anterior commissure, left side true cord in the anterior part, in the anterior 1/3. And then we have got paraglottic space involvement. We have inner perichondrium of the thyroid involved and the vocal cord is fixed, right? So this question, particularly in terms of, the laryngeal cancer staging, we already know that whenever we have discussed this, we have discussed that whenever we say T3, what are the 3 rules? It has to involve more than one subside. The vocal cords has to be fixed. So I've told 3 rules. Vocal cord has to be fixed. Involvement of inner perichondrium of the thyroid cartilage or the cricoid cartilage or any other cartilages of the larynx, and involvement of spaces. So this has been clearly discussed in our RR LRR series, meaning that whenever there is an intralaryngeal tumor, it is T3. And if the tumor becomes extralaryngeal with a local spread, then we say T4A, and a distant spread we call T4B. So here, since it is a local, it is intralaryngeal, we are going to say that it is T3. Okay. So I think this part is clear. All of you are clear about this? Yes. Now let's go to the next question where they have asked you about what is the marked structure. Now, if you see, the marked structure is the anatomy of the petrous part of the temporal bone. We know this leaf-like bone is the petrous part of the temporal bone. Again, we have discussed the anatomy of the petrous apex in multiple times during our sessions. We have identified the internal auditory canal as well. So on the anterior slant and posterior slant is what we discussed. On the posterior slant of the petrous bone, we have a canal which is called as the internal auditory canal, through which 2 nerves pass, which is the 7th nerve and 8th nerve. So very clearly we know that the canal that has been marked is going to be your internal auditory canal. Of course, external auditory canal will be the outer portion that you see. Carotid canal is this canal which is located much anteriorly on the near the anterior slant of the petrous apex, not near the posterior slant. So what structure we see here that has been marked and that was asked for you is going to be the internal auditory canal. Yeah. So that is, I think, again discussed during all our sessions. Let's do the next question. What is not done in an infant? Again, when we talk about infant, can we do any subjective test? Because in a subjective test, the patient has to give a response and that's when you're going to diagnose, right? So when a patient or an infant is just a small baby, can the child be tested with tuning forks or with an audiometry? No. So pure tone audiometry cannot be done. Photoacoustic emission is a screening test for assessment of hearing because it's an objective test, a machine-generated test, and BERA is the confirmatory test that you do. Again, both of them are objective tests and they are not subjective tests where the infant has to give a response. Pre-filled audiometry or arousal response are types of audiometry where you give sound stimulus and see whether the child is getting aroused to that sound stimulus or responding to that sound stimulus. Again, it is not a commonly performed test. It is a test that we do in screening where there is no availability of OAE and BERA at all. So again, these 3 tests can be done for screening in infants, but pure tone audiometry, where we expect the patient, when we give a sound, to raise the hand when he hears the sound, and then we increase and decrease by 5 or 10 decibels, is something we cannot expect in infants and children. So that is why PTA is not a test that is done in infants. So again, we have discussed subjective test, which is the screening test, which is the confirmatory test. Both of them are objective. We've discussed all this during our rapid revision and LRR sessions as well. The next question is arrange the steps of FES. FES is functional endoscopic sinus surgery, which is a very commonly performed surgeries in today's time for patients who suffer from chronic sinusitis. It has other indications as well. So when we talk about FES, we have to first open the middle meatus. And the first step to open the middle meatus is to do an uncinectomy. Okay, so the first step is to do an uncinectomy. The second step after you do an uncinectomy is to identify the maxillary sinus ostium and widen the maxillary sinus ostium, and that we call it as maxillary sinusotomy or maxillary sinus ostium opening. Then we go to the bulla and we remove the bulla, or which is the biggest anterior ethmoid layer cell. We call it as bullectomy. Now with the bulla intact, we can go to frontal recess. Even without the bulla intact, we can do the frontal recess surgery. So it is frontal recess is something that can be done before the ethmoidectomy or after the ethmoidectomy. There are various techniques. So the next step ideally will be to do a bullectomy where we remove the anterior ethmoidal cells. Now, after we do the bullectomy, we will identify the ground lamella or basal lamella of the middle turbinate and then approach the posterior ethmoidal cells, where we do the posterior ethmoidectomy. And last, we will come back from posterior to anterior, clearing all the cells in the base of the skull and then going towards the frontal recess area to widen the frontal sinus ostium. Yes. So I hope this is very, very clear. So what are we going to do? A, C, B, and D. So the correct answer will be A, C, B, and D. Got it? That is the correct order of doing the surgery. And if you see here, I have described the surgery entire FES on the app with the video lecture showing you every step that we do in FES. I have shown with a real surgical video in our version X so that you can understand all these steps better. And it is no more imaginative, but you can actually see the endoscopic video as well. Now we have the next question here. Which nerve is blocked by this procedure? So you see here a nerve block is trying to be given here. Ideally, this is a procedure that you do for dental problems like extraction of the third molar or extraction of any teeth, or if there is a local procedure of the palate that you want to do, then you give this block, which is your greater palatine block. So let's presume you don't even know this block. You know, nasociliary block, we do it near the medial wall of the orbit. Ethmoidal nerve block again will be done near the medial wall of the orbit. Maxillary block has nothing to do with the palate. So even if you didn't know, it is okay to answer this question because we know at the palate will be the greater palatine foramen. And in the greater palatine foramen, you will block the greater palatine nerve. And that block that is seen here is the greater palatine block. And in ENT, if you ask me, what is the significance of this procedure, ma'am? If we have a patient who has posterior epistaxis, bleeding from the posterior part of the nose, if we want to stop or reduce the bleeding from the posterior part, and if we want to aid in posterior nasal packing, we can give this block, which is the greater palatine block. Here we mix xylocaine plus adrenaline and we insert it in the greater palatine foramen. And when we do that, the greater palatine artery supplies the posterior end of the septum. So there will be reduced bleeding because of the vasospasm that occurs to the greater palatine artery. And in ENT, it can help in controlling posterior epistaxis. Although not a standard procedure, you can do this as an add-on procedure when nothing else is working. Okay. So that's the significance of greater palatine block in ENT. And the last question which we have, which of the following structures are associated with dysphagia and dysarthria except? So if we see here, whenever we talk of swallowing or speech, genioglossus is extremely important because that forms the bulk of muscle of your tongue. So genioglossus is necessary for good swallowing and good speech. Posterior pharyngeal wall has got constrictors which has to contract to propel the food downward. So it is absolutely necessary. The soft palate has to move upwards and backwards so that the bolus can be propelled down. So this is also necessary, but nasopharynx has nothing to do in terms of speech or swallowing. Nasopharynx is a part of your respiratory tract and it is responsible for breathing and not responsible for any articulation of the words or with swallowing. If it has to be associated with anything, then it is going to be resonance of the voice. Okay, so what is it going to be responsible for? resonance of the voice. So we can get a hyponasal or a hypernasal voice because of nasopharyngeal problems, but it has nothing to do with dysphagia and dysarthria. I think this was a comprehensive understanding of the questions that were there. I think ENT per se, core ENT 5 questions were absolutely simple. 2 questions, I think they could be easily sorted. And if there's anything in ENT that you felt was difficult or you have any other questions, please feel free to leave them in the chat box. If you feel there were any corrections, again, leave them in the chat box. We will upload the final presentation on the app once we get a feedback from all of you. Hope you did all the questions rightly and wishing you good luck for your results. Until then, take care and bye-bye.
You are live.
Hi guys, hope you're doing great and I hope the paper went well. So you would have been rested by this particular point of time and I am very sure that the mind would have been zapped because of the options in the paper. But what I have tried to do is try to, recall the options closest to whatever was possible. I will obviously require your inputs regarding refining the options further so that we can come up with a more consolidated approach. But yeah, this is like a good to go one that we can proceed with today. So I think you can just comment on the options and their accuracy, and meanwhile I'll keep on refining the question. We start with the first one. This talks about athlete who died. Very standard question. I mean, I think you would have been like laughing at this one, that banana-shaped cavity of the left ventricle, and there would be a subendocardial ischemia in this guy, which would have triggered an arrhythmia and then contribute to sudden death. This is autosomal dominant in inheritance. So, like the guy has been declared dead on arrival. The reason for death in this patient is a cardiomyopathy, considering a septal hypertrophy, and the free wall of the heart is also bigger in size. Plus, the cavity size of the left ventricle is like super super small. तो बड़े दिल वाला, लेकिन बड़े दिल वाला होने के बावजूद भी the guy, unfortunately had a demise. So the correct answer for this one is option number B. This was a piece of cake, I think, and you guys would have been able to crack it right in the first go. So we move to the next one. Do comment if there is any alternation. Yeah, arrhythmia. Arrhythmia. Okay, one option is due to arrhythmias. Fine. Due to arrhythmia and a heart block. Okay, guys. Cardiac arrest due to arrhythmia and a heart block. Got it. So point against that is that first and foremost, we have to identify the structural damage. Na? That the structural damage in the patient is in the form of a cardiomyopathy only. But yeah, Tarun, a point taken well there. I thought it was drug abuse. Yeah, I got it. Arrhythmia and a heart block. Then is, which of the following conditions does not share the same initial mechanism leading to heart failure as the others? Anemia, fever, thyrotoxicosis, sabhi mein there would be disproportionate tachycardia. And because there's a disproportionate tachycardia, there would be increase in oxygen consumption. Now there's a limit, no, how much oxygen can be provided, because coronary arteries have a limited diameter. So ultimately the heart will fail, because if you have a disproportionate tachycardia, the heart will not be able to perform better. But high salt intake will work in a different way. One, like it would not be a very common cause of heart failure, but yeah, somebody with a cardiomyopathy, high salt intake is of concern, and it will act by, causing a volume expansion. So when I read this question, I think in a 30-second period, I can logically work out that salt intake will result in somebody with a pre-existing heart damage. That's where it will cause a problem. So the correct answer in this question would be given as option number A. Yeah, mastermind, we have taken care of the tall P wave in a patient. That would be P pulmonale due to pulmonary artery hypertension, usually seen with mitral stenosis. So we are sorted for the current one on the screen, and we move on to the next one. This lady had SLE, and then she had come with these moon faces, buffalo hump. So he's basically giving us a case of a exogenous cause of Cushing syndrome. And in any exogenous cause of Cushing syndrome, the logical aspect is that if somebody is taking prednisolone, then the cortisol levels in the body would be elevated and ACTH values would be suppressed in a patient. But yeah, I think if you look at the inferior part, suppression test is done for ectopic causes, like it could be lung cause or it could be endogenous cause, for differentiation, right? And to identify those ectopic and endogenous causes or even autonomous causes, that is where we shall be going ahead with a suppression test, especially for ectopic versus endogenous. So in this particular case, no, not tricuspid stenosis, man. Tricuspid stenosis में तो large A wave आ जाएगा ना, P wave पूछा है बच्चे. He asked a P wave. Tricuspid stenosis में तो pulmonary artery hypertension नहीं होगा ना. पल्मरी आर्टरी हाइपरटेंशन इज अ फीचर, राइट? तो अगर आप उसको कंफ्यूज कैसे किए, मैं समझ गया आप कंफ्यूजन कहाँ पे, लार्ज ए वेव और लार्ज पी वेव के बीच में कंफ्यूजन क्या है, आई जस्ट क्लैरिफाई. Large A wave in the JVP is tricuspid stenosis. But if I say large P wave in the ECG, it's due to pulmonary artery hypertension. Now, so TS will not contribute to pulmonary artery hypertension, because you need to have a obstruction. Pulmonary artery hypertension, either it should be left to right shunt, or it should be like disease in the left side of the heart, which will directly cause PS to occur in a patient. Best to diagnose kar do. It would not change the answer. I'm not going to change my answer with that. So even if I say what is the best way to analyze this question, then the answer would be given as serum cortisol. Yeah, initially क्या करते हैं? First test to be done in any patient is like we have to go for a 24-hour urinary cortisol values, or we can go for a serum cortisol values as well. So the point is cortisol to check करना ही करना है ना, first and foremost is. So whether you say best test, whether you say the most appropriate initial test in this patient, तो हाँ best बोल दो, appropriate बोल दो, still it will go with the initial data. And like the best test तो वैसे भी I've explained to you ना, that is रात को 12 बजे patient को जगाएंगे, and then we'll do a salivary cortisol in a patient. So I mean the best test भी देखोगे तो तब भी तो यही बन जाता ना. Okay, guys. So I think we are sorted for this one. I have explained this now. The best way to identify Cushing is to go ahead with a 12 p रात को 12 बजे जगा के पेशेंट को salivary cortisol check करेंगे. So it's the same concept which is being asked here as well. Okay. What is the common site of Berry aneurysm in the circle of Willis? So this would be ACOM, anterior communicating artery, at the junction of the anterior cerebral artery. So he did not have that word in the options, like, that is ACOM, but then anterior cerebral artery is the most common location. We have discussed, that Berry aneurysm at posterior location is more vulnerable for rupture. So suppose he was talking about third nerve palsy, rupture, and, top of the basilar artery would have been answered. But in this case, like, it would be answered as A, that would be an anterior cerebral artery. Okay, mastermind, I take your point, whether it is low followed by high dose dexamethasone suppression test or low and high separately. The point is DST is done not in cases where there would be iatrogenic cause, because यहाँ तो iatrogenic cause है ना, तो it is like we just demonstrate that cortisol values are high and ACTH is less in the patient. All the other testing is done for like ectopic and endogenous one. Okay, we are sorted for Berry aneurysm location. I think this was more in anatomy than the medicine part, but still, like, I got the question, so I thought I should not leave the opportunity to speak about it. And yeah, low followed by high. Okay. Okay, fine. Low dose dexamethasone by followed by a high dose. The bottom line is that there is no role of any DST is not done for diagnosis of like an iatrogenic cause. Yeah, I got it. Monocer 1 gram. I got that option, right? It is like both of these are like followed by one and another for the options. I get it. So once we come out with the refined version, but I'm not gonna change my answer for the question. Okay. Very sorted. We move to the next one. The child has come with a periorbital edema and a pedal edema. बच्चे को नेफ्रोटिक सिंड्रोम हो गया, तो मिनिमल चेन डिजीज ही होगा. और मिनिमल चेन डिजीज में तो सीरम क्रिएटिनिन नॉर्मल होता है ना. सीरम क्रिएटिनिन को वैसे भी इंक्रीज वर्ड ना भी लिखा हो, I mean, like some people said, sir, increase serum creatinine नहीं था. It's okay. I mean, the point is, like, for diagnosis, I need a proteinuria, I need a hyperlipidemia that can be present, and then would be hypoalbuminemia in a patient. So we will have to look for like 3 things that are present. So if I look at this would be A, B, and then D is also coming up in the options. Okay, so it is A, B, and D that would come in the questions. Fine, man. I get the point for this one. ओके फाइन. तो इट्स देखो, पॉइंट ये है कि जिस भी ऑप्शन में डेक्सामेथासोन सप्रेशन टेस्ट है ना, उसको नहीं करते हैं. दैट्स द पॉइंट दैट आई एम ट्राइंग टू एक्सप्लेन. फाइन. कॉर्टिसोल के बिना तो मतलब कुशिंग सिंड्रोम का डायग्नोसिस बन नहीं सकता ना. तो ACTH एंड कॉर्टिसोल का कोई ना कोई कॉम्बिनेशन तो वो देगा ना बच्चे. इट कैन नॉट बी लाइक बिना कॉर्टिसोल के वो कुशिंग सिंड्रोम पूछ रहा है. ओके, सो मिनिमल चेन डिजीज हैज अ गुड प्रोग्नोसिस. इसमें KFT यूजुअली नॉर्मल होता है, इस वजह से मैंने सीरम क्रिएटिनिन को इसमें इंक्लूड नहीं किया है. 3 right answers, but only 2 right answers in an option. Okay, चलो आगे देख लेते हैं wherever like those options would be working out. But this is how the current question would frame out for diagnosis. Mark my words there. Essentials or diagnosis नहीं है. It's like what are the features that would be seen in nephrotic. So we have a hyperlipidemia and we have oval fat bodies also. But if you go into essential, if I say the word essentials or diagnosis, then for the essentials part, then the essentials would be only 2 of them. That is proteinuria and a hypoalbuminemia in a patient. So cool, guys. I think we will be able to solve minimal chain disease easily. And we come to major and minor Jones criteria for diagnosis of rheumatic fever. So erythema marginatum, not seen in Indian population, but is a major one. Then for a country like India, I don't need, I mean, that migratory polyarthritis and polyarthralgia would also be taken in a diagnostic criteria. Carditis also, I mean, subclinical carditis likho, clinical carditis likho, both would be included. But then we have is Ashkoff nodules between the SA node and the AV node. So we have is a prolongation of the PR interval. So if I look at the options here, like I'll not include option number D for this one. Do comment here. Was it to select only the major ones? Was it only to select the minor ones? Some people said it was for both of them. उसने ऐसा कुछ specify नहीं किया कि major अलग से बताने हैं या minor बताने हैं. Because what I was thinking initially on listening to this question was that you had to select only the major criteria for diagnosis and not the minor ones. But anyway, the way it is shaping up, it is like this only, that short PR interval is the odd thing for this particular discussion that I have currently mentioned. So both major and minor were mentioned. Fine, man. So this would be easy one for you. I think rheumatic is what I mean, Meenakshi ma'am has taught very well. I've also discussed in my discussion. So this would be easy. Even in pathology, you read about rheumatic fever criteria. So this would not have been causing any issues. चलो अब ये थोड़ा इंटरेस्टिंग वाला है. Hypothyroidism lady had completed a 14-hour flight, and like what are the risk factors for pulmonary embolism / deep vein thrombosis in a patient? इसका मैंने डिस्कशन भी दिया है. लॉन्ग डिस्टेंस फ्लाइट पे अगर जाते हैं तो दे ऑलवेज मेक अनाउंसमेंट, स्ट्रेच योर लेग्स अ बिट एंड यू कैन डू सम योगा, because that's equivalent to the major criteria. That's like one of the important features or important causes that can result in deep vein thrombosis in a patient. Okay, D option was thyrotoxicosis. Okay, Dharmesh, I want your options for there. Okay, erythema nodosum was there. Okay, fine, got it. This was erythema nodosum, and it was not erythema marginatum. Got it. Then we'll go with like B and C for this one. I noted that very interesting observation, monoseph. That was erythema nodosum and not erythema marginatum. Even I was thinking, that it cannot be so simple. But yeah, you just removed that word from there. Okay. Okay, patient with hypothyroidism. Okay, fine. Here I got it. Like he has not mentioned cancer in the options. That is what somebody is trying to say. So a lady with hypothyroidism has taken a long distance flight. I have a reference from Harrison also, which says that long distance flight, though I've explained it in my regular videos, but yeah, long distance flight is a risk factor for pulmonary embolism. So is gonna be OCPs, and yep, it is mentioned estrogen containing oral contraceptive pills for long demobilization, smoking. So it would be like, that hypothyroidism part would not be contributing here. So we'll go with A, B, and C for this one. Not included in the list of is hypothyroidism. So we are sorted. I mean, hypothyroidism, I can say, can contribute to hypercholesterolemia. Right. One of the side effects, I mean, one of the problems with hypothyroidism is that it can result in increase of cholesterol, and that cholesterol is a indirect risk factor. But then the point is, like, would all patients of hypothyroidism have clinically significant hypercholesterolemia to contribute to development of deep vein thrombosis? So I think we'll go with the more obvious things rather than overthinking in this question. I mean, if I'm overthinking, I'll include even hypothyroidism in the options as well. But yeah, I mean, that is a point to be taken care of, that, people with hypercholesterolemia tend to have higher incidence, but that's atherosclerotic risk factors. Like I have said that all patients of hypothyroidism tend to have accelerated atherosclerosis, and all these patients have increased incidence of DVT. But considering it the face value, like, would everybody be having there's so many hypothyroidism patients, then none of them should be traveling. So we'll go with the more common sense kind of an observation for this one. Okay, fine. We are sorted for this one at the moment. Then is a child with recurrent lung infections and subclavicular continuous murmur. So for a continuous murmur that is below the left clavicle, that would be patent ductus arteriosus. The cardio part, I think, was simple. Maybe that one or two can be like where you could be confused between options, but the remaining ones were like pretty straightforward there. Okay, Ji. Then anion gap status, I think Dr. Fuse and Dr. Cult would have come to your rescue here. Dr. Fuse is for NAGMA and Cult is for high anion gap metabolic acidosis. So if you just deploy that Cult mnemonic, starvation causes ketoacidosis, diabetic ketoacidosis is on, but in vomiting there is a metabolic alkalosis occurring in a person. So we'll go with A and B for this one. So the answer in this case would be, that would be A and B are correct for this one. Okay, Alicia, you mean to say that for the previous one, the question said which is not a risk factor. Okay, so still we'll go with the D component, no? Because if you look at it, then A, B, C are the risk factors. Okay, so at least the gist was, yeah, got it, Alicia Jindal, I got your point. We still are on the same page, right? So I mean, instead of touching like this, we're touching the ear in a different way, but then we are still on the same page for the diagnosis of this particular case and the analysis of the same as well. Okay, so we have a patient to the ER with puking and he's deteriorating. He says he's gone into coma, stupor, like I think lucid interval word was written or maybe was not written. But then what you can pick up is that classical extradural hemorrhage, a midline shift happening in this patient. And he says that what would you be doing in this particular case? So yeah, guys, if it is gonna be we don't give mannitol because mannitol will increase the amount of bleeding in this case. Conservative obviously will not do because patient is having a midline shift. Decompressive hemicraniectomy is different from a craniotomy. Craniotomy is where you open up the skull, evacuate, and then subsequently put the bone flap back in. But in decompressive hemicraniectomy, that bone flap is removed and then it may be placed in the peritoneal cavity, and only when the swelling of the brain will go down, that you would be putting that bone flap back in. So malignant cerebral edema, mark my words there. If somebody had like a multi-lobar stroke and there's a malignant cerebral edema, that is where we go in for a decompressive hemicraniectomy. For this one, it's like an immediate management to be done in this patient. So we'll go with the burr-hole evacuation if that, but the reason, there's a valid reason for it. I mean, you can see the midline shift happening. So that's why we would prefer a burr-hole evacuation for this particular patient. And craniotomy and craniectomy are two different things. What we do in these patients is a craniotomy and not a craniectomy. I mean, we may do a craniectomy, but then craniectomy is more for a diffuse swelling of the brain. That's usually seen after a MCA territory stroke, like the main stem of the MCA is obstructed. That's when you get a malignant cerebral edema after 24 hours, and then the decompressive hemicraniectomy is done. Okay, then he says, which of the following drugs is not indicated in management of status epilepticus? So we give IV valproate, fosphenytoin, lorazepam, but ethosuximide would not be given for status epilepticus. Okay, then an interesting one on diabetes. This kid was having a potassium of 4 or 4.8, I think. Bicarbonate was also given here. Like bicarbonate, though I have written like the word diabetic ketoacidosis, bicarbonate values in this question were fairly low. Okay, so I'll just add that. You guys can comment on the bicarbonate value of this question, and I think I'll be then in a better position to justify my answer. Yes, guys. Yeah, the bicarbonate value is something like 4 millicoulomb for this guy. So considering that the bicarbonate value of this patient will work out to be 4, then we can say that, I mean, this is an easy pickup for us. The correct answer for this one would be option number B. And the correct answer that will say for this one is B here only. Ringer lactate versus normal saline, there is always a controversy that is going on. But considering the fact that if I look at the options, normal saline is always preferred over ringer lactate. And why we are giving potassium? Well, though potassium values are normal, if it is 4.8 also, I'm still comfortable with the, giving potassium for this patient. The rationale is redistribution of potassium caused by insulin. That is why like we will be giving potassium chloride for this patient. तो पीडीएस साइनोसिस कराता नहीं बच्चे, किसने बोला आपको पीडीएस साइनोसिस नहीं नहीं कराता है? Patent ductus arteriosus is not going to result in development of cyanosis in a patient. It is a acyanotic heart disease, ना? तो वही जो acyanotic heart disease होता है, that results in recurrent lung infections in a bicarbonate. बच्चे मैंने बहुत बार explain किया, soda bicarbonate has no role. Soda bicarbonate has absolutely no role in management of diabetic ketoacidosis unless the value of potassium in that patient turns out to be सिग्निफिकेंटली रिड्यूस। मैंने अगर पोटेशियम अगर बाइकार्बोनेट की वैल्यू जो है वो 4 के टीएच की वैल्यू 6.9 या 6.8 अलग अलग रेफरेंसेस हैं, उनके बेसिस पे बाइकार्बोनेट को देने का परमिशन है, अदरवाइज बाइकार्बोनेट को यूज नहीं करते हैं। So I think we are sorted here. Okay, there are two options with 20 ml also. So usually the resuscitation is 10 ml ka bolus na, and then we give a insulin infusion to the patient and then KCL. So the most appropriate answer for this one is option number B. So certainly my pen is not working, but yeah, the answer to this one is option number B. And we can move on to the next one, which is a very interesting one. So इसमें बड़ा मजा आने वाला है in discussing this question. Okay, guys. We have a chronic smoker and he is presented with this right-sided ptosis, meiosis and anhidrosis. So there's a pancreas tumor का clinical presentation that is given, and he says, पहले तो ये comment कर दो इसमें कि multiple correct था या सिर्फ single best answer था. Yes guys, quickly please let me know. फिर मैं आंसर बोलता हूँ. हाँ, CT gated biopsy भी जा रहा है यहाँ पे. Okay, MRI was not in the options. Okay, तो मैं that is what I'm trying to say, because Harrison ये बोलता है कि pancreas tumor के लिए जो main test होता है वो MRI होता है. तो if MRI was in the options, तो then we'll go with option number C for this question. But if अच्छा आप comment कर दो, was MRI in the options or not? MRI in the options or not for this one? Yes guys. वेटिंग फॉर योर कमेंट सर. एमआरआई था या नहीं था? क्योंकि किसी ने बोला कि सर एमआरआई ऑप्शन में नहीं था, क्योंकि नेक्स्ट इन्वेस्टिगेशन तो एमआरआई है ना. सॉफ्ट टिश्यू पैनकोस्ट ट्यूमर में वर्ड है पैनकोस्ट, तो हम पहले ट्यूमर से पहले पैनकोस्ट को भी तो डेमोन्स्ट्रेट करेंगे ना. Okay, so if there is no MRI in the options, then I'll go with option number A for this one. But yeah, in this particular question, If he mentions regarding the fact that, if he mentions what is next investigation, we'll go with an MRI. Otherwise, okay, ultrasound was there. So then it makes it easy, man. Then तो it's a piece of cake. Pancreas tumor है. Tumor के लिए क्या करेंगे तो भाई tissue diagnosis करना पड़ेगा ना. And the tissue diagnosis would be with help of a biopsy. So I think we are sorted for this one, guys. This would be option number A for the correct one in this particular patient. Okay. Fine. The answer to this goes as A, considering that it's not MRI in the options. I think this has already been discussed. HIV infection with cough and hemoptysis, the chest X-ray image of the patient is given. So in this patient, what I need to do is primarily, okay, now my pen is working, so I'll do the marking here also. MRI is not there, so we'll go with ultrasound. MRI hota to bahut mazedar ho gaya hota ye question, so it became easier, right? So I'll do the markings here also. चलो जी एड्स के पेशेंट हैं और उनको हेमोप्टाइसिस हो रहा है तो फिर एक्स्ट्रा पल्मरी टीबी भी सोच सकते हैं और पल्मरी टीबी का डिटेरिएशन भी सोच सकते हैं. सो विल गो विद पल्मरी ट्यूबरकुलोसिस फॉर दिस पर्टिकुलर क्वेश्चन. द आंसर हियर इज ऑप्शन नंबर ए, fairly straightforward one. Then for PrEP, that is pre-exposure prophylaxis, CD4 count less than 50. Okay. So that makes him even more vulnerable to the impact of tuberculosis. Okay, lung abscess. Lung abscess को मैं बैकअप में रखूंगा. आई नॉट कंसिडर लंग एब्सेस इज द फर्स्ट आंसर कि उसके साथ में फिर क्लबिंग, पुरलेंट ब्रोंकोरिया, those kind of manifestations should be described in the question, and air fluid level should be present as well, which cannot be seen at the moment. For PrEP, it is tenofovir with emtricitabine. For post-exposure prophylaxis, the TLD part, but for PrEP, it is tenofovir, emtricitabine. The Harrison reference for this patient is present. Yeah, Mihir, I think in the radiology, they talked about somebody with a low CD4 count and invasive aspergillosis. So yeah, that is what I was wondering, not in this question, but in a different one. There was a question with respect to CD4 count being lesser, and then there was an invasive aspergillosis ka risk present. So that's, I think, a totally different one, and we should not be mixing up the two questions. But good, Mihir, that you brought that up, that person with low CD4 count will have a higher incidence or development of, so there would be like lung cavity, which will colonized by aspergillus, and we'll be able to see a fungal ball. Not seen in Conn syndrome. So we get alkalosis, we get hypokalemic alkalosis, we get hypertension also, but hypernatremia क्योंकि dilution हो जाएगा ना, salt भी आएगा, पानी भी आएगा. तो अगर salt भी आया और साथ में पानी भी आ गया, so as a result of this, most of the time, like in these patients, you would not be having is hypernatremia. Why not option A for पिछला वाला? वो तो post के लिए हो जाएगा ना, post exposure. PrEP पूछा ना, pre exposure prophylaxis, which is why the answer will turn out to be this. Yes. Yes. Okay. Okay. That's another incidence one. Alicia, you have a point. For invasive aspergillosis, yeah, I will first go with the low CD4 count. Like I will first go with febrile neutropenia. So I went through that question in some other group. So I thought that I leave it to the pathologist. But anyway, you put up a good point there. If it is gonna be a aspergillosis, invasive one, febrile neutropenia would be the first important risk factor to be associated, but the wordings of that are not to be present. Hypernatremia होगा तो ICU जाएगा. Yeah, true. I mean, hypernatremia is not a small thing to happen. Okay. Yes, Alicia, you're right in that one. Then is recurrent peptic ulceration and there's a nodule in the third part of duodenum. ये third part ही था क्या? मतलब second part से और आगे third part पे ले गया. So, but anyway, we are thinking in terms of a Zollinger-Ellison syndrome. So we'll go for serum gastrin levels for this patient. But yeah, I think, okay, second part of the duodenum, fine. So, but we'll still be going with the gastrin levels in this patient. Yeah, Harsh, I get your point. Febrile neutropenia is what I'll go with. Next is an old man with bone pain, and then serum calcium is elevated, phosphate is low, SAP is elevated. ये बस ये biochemical बोल देना, इसी से कहानी change हो जाएगी. Because if SAP is normal and only calcium is elevated, phosphate is also normal, then we'll go with multiple myeloma, and then we'll think in terms of either a PET or a MRI in a patient, and even a bone marrow biopsy. But considering the fact that the lab report is like this, you can understand that the person would be having hyperparathyroidism. There could be a tumor in one of the parathyroid glands of the patient, so that primary hyperparathyroidism thing is present. So we'll go with a system scan, because if the SAP was normal, then it becomes a question related to multiple myeloma, considering old man with bone pain. But then since he has mentioned diffuse osteoporosis, that also gives more credibility to the fact that PTH is responsible in this case, and we'll go with option number B for this one. Perfect. Triphasic bone scan. Okay, man. Fine. That is a good, interesting input there. A triphasic bone scan. So that would again be bone scan would be done to demonstrate the multiple lesions only. Like if there is going to be multiple bone lesions, we can diagnose on the basis of bone scan. But since the SAP is elevated, that makes it easier for us. Okay, patient came with meningitis. The ELISA shows a cryptococcal antigen is reactive. So we'll give a liposomal amphotericin B and 5-flu cytosine for this patient. I'll go with A for this one. If you want to modify anything, let me know. Otherwise, pretty straightforward one. Any image for India in given or like, okay, so I think this is straight. Okay, multiple options. I mean, maybe the framing would be a little different, but then the gist of the question is LAMB and 5-flu cytosine for management of these patients. Okay. Okay, LAMB plus itraconazole. Okay, got it. Got it. We'll do the reframing of this. Fine. It is multiple correct options that we get it. फाइन गाइस गोल्ड क्राइटेरिया पे 2 सवाल थे बड़े इंटरेस्टिंग से थे तो अब मुझे थोड़ी हेल्प चाहिए यहाँ पे लाइक आई वांट टू नो वाज इट रिटन ओनली acute exacerbation of COPD or were the vitals given in a question? One guy said only it was acute exacerbation, other guy said no vitals were also given and PCO2 of the patient was elevated because PCO2 बढ़ जाएगा तो you can understand non-invasive ventilation will also come into the picture. So let me know like या इनिशियल ट्रीटमेंट ही है मतलब कि करेंगे क्या उसमें तो वी हैव टू गिव स्टेरॉइड्स वी हैव टू गो फॉर ब्रोंको ये दोनों तो देना ही देना है राइट वी हैव टू गिव नेबुलाइजेशन ओके 87% तो सिवियर की तरफ जा रहा है ना फिर तो सिवियर हो गया ना सिवियर एक्यूट एक्सेसरबेशन तो देन तो मेरा जो रेफरेंस है बिल्कुल सही है ना कि भाई इसमें ब्रोंकोडायलेटर भी देना है SpO2 86 कोई बोल रहा है ठीक है 86 87 तो दैट गोज इन फेवर ऑफ सिवियर and like the PCO2 of the patient is elevated तो type 2 respiratory failure हो गया ना if person is having type 2 respiratory failure that means non-invasive ventilation will also come the only thing that is left now is was there anything mentioned like increased purulence or bronchuria present in a patient even if नहीं भी है ना तो this is the guideline guys he says कि उसमें वो बोलता है कि भाई सभी all aggression पे चले जाओ all aggression would mean that we'll give bronchodilators we'll give steroids antibiotics and non-invasive ventilation for the patient so antiviral okay fine COPD with this NIV is not in the options okay जी non-invasive ventilation नहीं है fine तो फिर मेरा आंसर थोड़ा सा चेंज हो जाता है मतलब तभी मैं PCO2 का वैल्यू वगैरह पूछ रहा था आपसे तो एंटीवायरल तो नहीं देंगे डॉक्टर साहब देयर वुड बी नो रोल ऑफ एनी एंटीवायरल्स बट या देयर इज रोल ऑफ एंटीबायोटिक्स इन अ पेशेंट एंड स्पूटम इंक्रीज है ओके एंड विद स्पूटम increase in a patient so that is an indication no that there is more purulence or there is more sputum it's not related to purulence अगर sputum का amount भी ज़्यादा आ रहा है तो we'll go with the antibiotics in this case we'll go with the steroids and we'll go with nebulized bronchodilator but not antivirals for a patient so this would be A B and D as far as the current data is concerned and since you said non-invasive ventilation is not in the options but yeah PCO2 is elevated so we have to call the patient and manage with non-invasive BiPAP would be used if we don't have a BiPAP then maybe a venti mask लगा के we try to time pass and then subsequently put the patients on BiPAP there pulse rate is 112 okay doc that's pretty close the value that I mentioned so like all these parameters go in favor of severe डिटरी एंड किसी भी सवाल में ना एस्थमा या COPD के सवाल में अगर SpO2 90 के नीचे दिया हुआ है मतलब एग्जामिनर इज ट्राइंग टू टेल यू अबाउट द सिवियरिटी ऑफ द इलनेस सो वी नीड टू गो अ लिटिल बैलिस्टिक और वी नीड टू गो अ लिटिल अग्रेसिव फॉर मैनेजमेंट nebulized salbutamol will cause but we don't have an option ना यही तो बताया मैंने कि salbutamol is a rescue drug and should be used as a rescue drug है ना लोग उसको क्या करते हैं प्रिवेंशन के तरीके पे यूज कर रहे होते हैं तो इट हैज टू बी गिवन इन केस देयर इज लाइक इवन इफ देयर इज अ टैकीकार्डिया कंपोनेंट आई स्टिल टेक अ चांस इन बिकॉज नहीं दूंगा तो मैट हो जाएगा मैट क्या होता है मल्टीफोकल टैकीकार्डिया ना एनसीवी वाज गिवन नो नो बच्चे दैट एनसीवी वाज अ क्वेश्चन अलग से ना पैनकोस ट्यूमर वाला सवाल था वो आप उससे मिक्स कर रहे हो ना इट इज नॉट एनआईवी वो एनसीवी होता है नर्व कंडक्शन वेलोसिटी ना दैट इज डन इन पैनकोस ट्यूमर में करते हैं उसको क्योंकि इंट्रिंसिक मसल्स होता है हैंड की वेस्टिंग हो जाती है ना सो दैट्स व्हाई ओके पेशेंट केम विद बैक पेन एंड वीकनेस इन बोथ द लिम्स एंड कंप्रेसिव माइलोपैथी के लिए क्या करेंगे तो कंप्रेसिव माइलोपैथी विल अल्टीमेटली बिलो द लेवल ऑफ द लीजन कॉज अपर मोटर न्यूरॉन के मैनिफेस्टेशंस सो आई गो विद सिंगल बेस्ट रिस्पॉन्सेज एंकल एंड नी क्लोनस इन अ पेशेंट If he had mentioned separately, like at the level of the lesion, below the level of the lesion, then I'll be a little, changing my approach. But considering that if I have to give a single answer in this question, then not support the question, would support the diagnosis of compressive myelopathy. Okay, fine. So ankle and knee clonus will, okay, चलो मैं इसको ankle word को हटा देता हूँ. Only knee clonus is given. I think this is straightforward, man. I mean, for diagnosis, we'll go by knee clonus for identification because absent Babinski sign तो कभी नहीं बोलते ना. We Babinski sign जब होता है तो बोलते हैं. We never say the word absent. Absent तो आप में मुझ में भी हो गया ना. So that's not a situation to be answered. Okay, one option is cremasteric reflex. Okay, normal cremasteric reflex. Okay. तो कौन सा वाला हटाऊं इसमें से ऑप्शन जरा थोड़ा सा बताओगे मुझे सिंस यू सेड नॉर्मल क्रेमास्ट्रिक रिफ्लेक्स दैट्स अ गुड इनपुट आई मीन क्रेमास्ट्रिक रिफ्लेक्स नॉर्मल इन द पेशेंट या NICP rheumatoid arthritis I agreed that was a honeycombing one. I thought the radiologist talked about it, the honeycombing with non-specific and female patient है तो anyway non-specific interstitial pneumonitis and especially if steroids are given then the NSIP part would be even much more significantly important. Okay. Okay, D option is not there. Fine, I have removed that. See, I'll explain this to you. The bottom line is for any patient with compressive myelopathy, at the level of the lesion, there would be lower motor and below would be upper motor के manifestation. तो मैं तो below के हिसाब से knee clonus answer कर रहा हूँ. अब अगर आप क्वेश्चन को no में change करते हो, then slight options would be different there. But considering the language of the question, I'll still stick with but what is the answer that I've given here. एंड गोल्ड क्राइटेरिया तो बच्चे आई हैव ऑलरेडी मेंशनड रेफरेंस यहाँ पे दिया हुआ है आपको सिवियर का ना फॉर मैनेजमेंट ऑफ द पेशेंट बिकॉज SpO2 ऑफ द पेशेंट वाज लेसर सो या वी आर कमिंग टू दैट हर्ष वी आर कमिंग टू दैट क्वेश्चन अभी आगे वही वाला क्वेश्चन है ये वैल्यू वाला ना इतने के नीचे तो सिवियर में बोलेंगे ना दैट इज वेरी सिवियर में जिसमें वैल्यू 30% के नीचे आई कम टू दैट अभी अभी आ रहा हूँ उस क्वेश्चन पे भी तो compressive myelopathy wala we need to reframe a bit for the not feature there but if it is the feature of compressive myelopathy then we'll go with option number C here. Yeah, Nitesh Parmar, I get your point. We'll try to reframe it according to not a feature of compressive myelopathy also. So then उसमें एक जो feature आएगा that has to be like then like लोअर मोटर न्यूरॉन लीजन अगर प्रेजेंट होगा उसको ना एट द लेवल ऑफ द लीजन तो देन लो अमन दैट वुड हैव हाइपोटोनिया एंड एरिफ्लेक्सिया आल्सो प्रेजेंट इन द ऑप्शंस बट आई गेट योर पॉइंट आई विल ट्राई टू फ्रेम इट अकॉर्डिंग टू नॉट अ फीचर आल्सो involuntary jerky movements in a young guy, personality changes and progressive forgetfulness. Ventricles look relatively bigger. Jerky movements दो ही हो सकते हैं मतलब इस उम्र में सेंडेनम स्कोरिया वाला होता है या फिर वो हंटिंगटन स्कोरिया होता है तो अगर वो सेंडेनम स्कोरिया होता ना तो MRI देता नहीं वो फिर ही वुड नॉट हैव गिवन एन MRI ही वुड हैव मे बी गिवन सम अदर हिस्ट्री रिलेटेड टू सोर थ्रोट वगैरह तो कंसिडरिंग दैट पर्पसलेस मूवमेंट्स ओके पर्पसलेस मूवमेंट्स भी दिया उसमें दैट इज अगेन गोइंग इन फेवर ऑफ कोरिया ओनली ना मैंने बोला कोरिया पे सवाल तो दो ही होगा या तो सेंडेनम्स होगा या हंटिंगटन्स होगा एंड अगर सेंडेनम्स वाला होता है तो देन ही डज नॉट गिवन MRI यूजुअली so we'll go with the synonyms. We'll go with Huntington's disease for diagnosis of this one. Anticipation में the disease is becoming much more earlier in presentation. Though like first generation 50s, then 40s, and then 30s is like how there would be present. Yeah, I mean what I'm trying to say is even if that you're not able to identify that caudate loss or caudate volume loss because that requires proper analysis of CT with a normal person's proper analysis of a MRI of this person in comparison with a normal person's MRI. So I'm saying that if the neuroimaging was not given, I would have still thought in terms of syndrome scoria. Okay, patient is started on haloperidol and then there is high-grade fever, generalized muscle rigidity. So I'll go that as neurolep malignant syndrome. He says what is to be done. So stop the drug and give dantrolene sodium for the patient. That centrally acting calcium channel blocker would be making the job easier for this particular case. Any change in options, let me know. Okay, so this one guys is like this guidelines कहीं पे usually दे नहीं रखे हैं कि इतना परसेंटेज के हिसाब से होगा, but then clinically significant resting hypoxemia if is present in a patient, then कि चेयर पे भी बैठा है तब भी उसको breathing trouble हो रहा है, तो resting hypoxemia is something that would be seen with respect to a very severe COPD in a person, and when I say the word very severe COPD in a patient, that would be especially when FEV1 of the patient is less than 30%. That would be the best way to identify, because we have grading now, like 50 to 80%, then 30 to 50%. Less than 30 is when we go into the very severe category. So that's where the resting clinically significant hypoxia would be coming in a patient. So we should be selecting a value according to the table and the classification that is given for the grading as mild, moderate, severe, and then very severe subsequently. In the mild one, the FEV1 is more than 80% only, but then subsequently you have a decrease one. गोल्ड ग्रेडिंग क्राइटेरिया क्वेश्चन, नो गोल्ड ग्रेडिंग नहीं होता, बट बच्चे आई थिंक डू लेट मी देयर, एमएमआरसी होता ना वो, तो आई थिंक दैट इज एमएमआरसी की ग्रेडिंग होगी, दैट इज नॉट गोल्ड, इट इज एमएमआरसी ग्रेडिंग, एंड ही वुड हैव मेंशन्ड रिगार्डिंग द ब्रीदिंग ट्रबल इन अ पेशेंट, उसमें मेंशन कर देना कि या रेस्टिंग हटा देता हूँ मैं, रेस्टिंग वर्ड हटा देता हूँ, क्लिनिकली सिग्निफिकेंट का मतलब ही यही है ना कि भाई उसका एबीजी आप चेक किए तो PO2 वैल्यूज जो हैं दे कमिंग टू बी लेस देन 60, इवन इफ आई रिमूव द वर्ड रेस्टिंग फ्रॉम द क्वेश्चन, clinically significant would mean that the PO2 of the patient is turning out to be at this low value, I mean PO2 less than 60. So that would happen in a very severe case only. Yeah, monoseph, I take your point. Threshold for hypoxemia. Okay, cutoff की जगह पे the word I'll use is threshold for hypoxemia. There was another gold guidelines. Okay, so I would need that question, doctor, that you're talking about. There's a third one on the gold. I heard there are 2 questions on gold, but there's a third one also coming in. तो एक बार पहले तो clarify कर देना कि were there 2 questions on gold or 3 questions on gold? Because what I can pick up from the chat at the moment is there were 2 questions on gold and 1 on MMRC grading, which I can pick up here. Okay, third one. Okay, got it. Another gold question. So I would need this. No, there are three. I got it now. There are 3 जिसमें 2 में gold है और एक में MMRC वाला, एक MMRC grading वाला है. So I'll have to frame up that before you. So we'll come up with a full consolidated paper, guys, very soon. Okay. Gold stages. No. I think this question is for the threshold of hypoxia. No, the wording I'm very sure, man, that the threshold of hypoxia is being asked कि कब जाके उसको clinically significant hypoxemia होगा. So we'll have to correlate it from the percentage values here. Okay, 30 to 40 for stage 3. Okay, good. In the last one in scrubs, if you can just drop me a mail at this one, that would be great for me to be able to analyze the data relatively better. And I think we can move on to the next one, but those 2 cold questions are ones that I've spoken out. This one was a patient of dengue, and manifestations are vitals are stable. The hemoglobin is 9, platelet count is about 20K, and what is the appropriate step for patient? So I don't need to give any platelet transfusion to the patient. Paracetamol, yes, makes sense for the person, but the remaining things would not be given. So I'll go with option number D for the current one at the moment. That is like a patient with dengue, and dengue or dengue, whichever way you want to call it, but the patient is like pretty stable. Okay, 1 in adult and 1 in child. Okay, so 1 in child, I think, what requiring fluids, and the 1 in adult is like a pretty stable patient where only paracetamol would be required. Okay, guys. So I think we are at the last slide of ours. I think I have like 28 at the moment. We have 28 at the moment. So this is the last one, I think, pharmacology oriented. Sitagliptin, vildagliptin, they are the ones which would be, metabolized via the kidney. So they can be ruled out. So the only ones that would be metabolized by the liver are linagliptin and saxagliptin. And linagliptin is like does not take cytochrome P450 system. So considering the dose adjustment thing, every time the dose adjustment is asked, it is always with that cytochrome P450 only. So we'll go with option number D there. And yeah, I would be requiring instead of antibiotic, blood transfusion is there. Okay, fine. Okay, so that makes my job even relatively easier for this one. Platelet transfusion is not 25, doctor. It is like platelet transfusion is agar fever present hota to it is less than 10,000 or it is like more than 10,000 with evidence of bleeding. Na? That is where when we give platelet transfusion to the patient. The threshold for platelet transfusion is अगर किसी को वैसे भी जनरल स्टेटमेंट है ना 5,000 से कम और इट्स गोना बी विदाउट फीवर. अगर फीवर है तो 10,000 या 10,000 है, देयर इज नो ब्लीडिंग मैनिफेस्टेशन. बट 10,000 के ऊपर है और ब्लीडिंग है, दैट इज व्हेन वी गिव प्लेटलेट्स टू अ पेशेंट. तो नितेश, इट्स नॉट 25,000. एक बारी प्लेटलेट्स वाला फिर से आप सुन लेना तो इट विल मेक इट इजियर फॉर यू. So guys, we are sorted for the current one at the moment. My count goes at 20. I have 29 slides, so अगर एक intro वाली निकाल दो तो 28 बनता है. But yeah, I think one I'm missing out is the COPD part. So in the consolidated fashion, I will be coming up with those remaining, the one that I missed out also. And yep, I think you guys did great by focusing on all these sessions that we were conducting. We tried to replicate the same things only. I mean, the options would always be that typical INI-CET twist that would be put in the paper. But anyway, like that's a part and parcel of the game. Hepatitis B question. Okay, doctor, I think the PSM teacher has already discussed that. The one where the antibody titer was given, and if antibody titer is sufficient more than 10, then we don't need to anything, and if it is lesser, then a vaccine shot would be required. So we are sorted. Okay, S. Jogran, this I would be interested in knowing. Can you let me know, please, for the S. Jogran part, the investigation part? I have covered, doctor, in my file, there are 28 questions as of now. And I'll be obviously adding one MMRC one and one S. Jogran that is coming up. Okay, Monosef, can you just let me know for the S. Jogran one? SLE part I've taken care that iatrogenic Cushing, no? Okay, Arpan, I'm waiting for like the S. Jogran options there. That will make it very non-specific. Okay, rheumatoid arthritis deformity would either be Boutonniere or would be Swan neck, or it's gonna be Z-line deformity depending on the issues present there. Okay, that is the pediatric question, SDF, that dengue PCV was 51. So if it is like a child and PCV is 51, then I'll say that it's okay. I mean, it is on the increasing side. So I would like to still keep a watch for dengue shock syndrome and give fluids to the patient. So DSS possibility would be there. Doctor, for S. Jogran, we have to go for a minor salivary gland biopsy, no? It is like a labial biopsy that we'll be using. So for S. Jogran, if he says, how do you diagnose it? Then it is a labial minor salivary gland biopsy that would be used. And along with that, we can go ahead with antibody titers also, but then antibody titers alone would not be sufficient. If PCV is 41, no, I don't need to give then fluids to the patient. Then if it is PCV in range of 35 to 45 is normal, na PCV. So if it is like 51, then I will be a little wary. If it is like 41, I don't need to give fluids to the patient. Yeah, salivary scintigraphy. Okay, that's a good input here. Salivary scintigraphy, ANA plus titers. So we'll go with the, though I would have liked all the 4 options, but considering the salivary word that you are incorporating is the most important thing for S. Jogran, no? So salivary scintigraphy is what we need to take into consideration. Okay. Yeah, I get the point, doctor. Like we need to mention the remaining ones. I obviously got the point for this one. Okay, guys. So I think we are sorted for the current slides that we have discussed as of today. And thank you so much for joining in and helping out with a recall session. Take care. God bless you.
Hi everyone, very good evening guys. I hope I'm audible and visible to all of you. And before we begin with this paper analysis / recall session, heartiest congratulations on getting over with the exam, because I think that is the biggest relief that you would have at this point of time. So you deserve a pat on the back for surviving through this, not just exam, but also I know that as soon as you come out of the exam, you're bombarded with so many paper analysis and exam recall sessions that it's somewhere that you cannot get over the fact that you've given an exam. So congratulations on passing through this entire phase. I'm not going to take up too much of your time because I know it's late evening, you're already tired with waking up early in the morning. But a quick first impression that I got after talking to a lot of students who gave the exam this time was the first impression when I talk about the topics, and I'm talking about my subjects. The first impression has been that the topics have been easy to medium. Well, don't be a little too startled by listening to this, because when I saw the topics, I was like, oh, we've read all of this. We've read Aspergillus and we've read, Prader-Willi, and that is really easy. But when I saw the options, they were very close, which makes it definitely a typical INI-CET type of paper where someone who has superficial knowledge would not have been able to crack most of the questions. You require a lot of in-depth knowledge, especially considering that they just went overboard with the multiple choice, and that is something which has just changed the entire thing, which is a very INI-CET thing. But this time I believe the number of multiple choice questions have just multiple options have just gone overboard, and I think that must have taken a lot of your time also, because when you have to mark one answer versus going through multiple options, time management becomes very difficult. And that is why, in my opinion, it is a medium to difficult paper. Although the topics, when I just make a list of topics, it's a very easy paper. I've not received all questions as of now. Roughly I have received a total of 30 in two subjects combined, but I'm still having more questions come in. So the final analysis will come up, of course, when we go to the app, and in the coming week we'll upload a final PDF and a video solution. Not gonna take too much of your time. I know you're tired, so we'll keep a timeline of 20-25 minutes, and we are gonna wrap up all of this. Let's start with the very first question, which was our very favorite Peutz Jeghers. And in Peutz Jeghers, we have again, a multiple option thing was there, where they have mentioned something about hamartomatous polyps, and we know on the last day, if one hamartomatous polyp we have to read, it has to be Peutz Jeghers for every exam that you're appearing for. You have macules mentioned, so it was pretty much falling in place. Now you had to pick up the statements which were accurate. This is not because it happens to be an autosomal dominant disorder. It is not usually associated with any retinal pigmentation, so that is also not correct. This definitely is correct because STK11/LKB1, I mean, whatever was mentioned, I think loss of function mutation is definitely there. And we know the final Christmas tree pattern, which is very, very famous. So they also gave you that the Christmas tree is because of what? It is because of the smooth muscle. So the accurate statements were C and D, and I know there will be a discrepancy because whenever multiple options come up, it's not very easy to narrow down. But this is what I've got up till now. And if you feel you have more inputs on this, in the live chat you can put in, or you can also put it up in the comments later on, because then I'll combine all of that and put it in the PDF which I upload on the app finally. Okay, so oh yeah, of course it must have been A, B, C, B, C, D. So I've not gone into that because it would make the recall very lengthy. We'll just discuss option by option. So right now, C and D obviously seem to be the accurate statements. Many of you are saying C and D are together. Some of you are saying C and D were not together. So then we'll have to, if ideally, if this is the language that I have got, this is correct. But then if this is not the option, there must have been some change in the language which we are not able to catch as of now. So then in that case, we can only wait for more input to come our way, and then we'll be able to give a better answer on that. Moving on to the next, there was definitely a question which everyone told me with translocation 1114. So I'm assuming that you all could make mantle cell lymphoma. There is a little gray zone whether they asked flow cytometry or not, but the markers was definitely asked. And we know cyclin D1 is a marker. Cyclin D1 was mentioned in the exam. Then what other marker? We know when cyclin D1 is not there, in those cases, SOX11 can be positive. And because it is a B cell tumor, B cell lymphoma, CD20 can be positive. What is not is CD200. I think these CD markers we had discussed in our LRR also as a tabular format. And I told you that these CD markers will be played around in the exam. So yes, it was. So translocation 1114 mentioned, not the other things. So then we can just rule out. That's also okay. I mean, if this was mentioned, this is the biggest hint they can give to you towards mantle cell lymphoma. CD20, guys, if mentioned, can also be positive in mantle cell lymphoma. They didn't mention CD23. They mentioned CD20. If this was an option, then that is also positive. Agar nahi tha, then it's simple. Then you just have cyclin D1 and SOX11. Moving on to the next question, which I think you just discussed it with Shanmuga Priya ma'am in biochemistry also, because every time Gaucher's disease and the famous crumpled tissue paper appearance has to come. So thankfully, Aulai and crumpled tissue are like exam favorites. Aulai didn't come, I'm assuming didn't come this time, but at least they kept up with their crumpled tissue paper appearance. So here we have this question, and this was one option which was correct. The enzyme deficiency, of course, is the glucocerebrosidase. That is also correct. So now over here, what I feel could be a catch point which could determine whether you got this question right or wrong is that if you have B and D as the options and you had to select the correct one, then this is right. Okay. But if in case, I'm not sure, but in case you had B, C, and D as the options, because see, foamy macrophages ideally or in most common situations are not something characteristically used as a word. Foamy macrophages, for Gaucher's we don't. We use very classical crumpled tissue, but under light microscopy, foamy macrophages can also be seen because it's medicine, which means that rare possibilities are there. So just in case BCD was one of the options, then that would have been a better answer. But what everyone has told me was that B and D was the only combination, and that makes life a lot simpler. So I think I would go for B and D, but please do select that if B, C, D were there, then foamy macrophages can also be seen. Moving on to the next, this also is recently discussed in biochem. We've done it in pathology. What are the steps of polymerase chain reaction? So we know first is going to be denaturation, where the double-stranded is split into single-stranded DNA. After that, you are going to add the primers. This means adding annealing is done, and finally extension is done. So option A becomes the best answer. Many of you had a confusion that, ma'am, maybe option B is the answer. But now please note, hybridization in textbook language is almost similar to annealing, which means joining something. So in many places, annealing and hybridization is used simultaneously. But if in case in future for other students, aisa question aaya where there is typical 3 steps and then there is hybridization, that means some blotting technique has been done later on. So then that is not typically a part of PCR. That means after that you've done some blotting, to wo alag ho gaya. Right here, typical standard, gold standard PCR was asked. Option A is the final answer. Moving on to the next one, a recent, it's INI-CET. They would love to give you a question which is related to something that has been happening around you. So I assume there were a lot of questions in physio, etc., about pollution also and about dengue fever also in medicine, because that's what's happening around you, right? So again, what was happening is the Nobel Prize, and that has been recently given for peripheral immune tolerance. I know you recently didn't have time because of exams. Now you do. So you must read that this was given because they told us a lot about peripheral tolerance in the immune chapter, regarding T regulatory cells, regarding the FOXP3 gene, how it's related to IPEX syndrome. Immunology is something I know you never get time to study, but now only for your, if you want to, I mean, if you're not feeling too burnt out by it, if you want to read it just for your own knowledge, you should read about this Nobel Prize that has recently been there. Okay, moving on to the next question is about stains. This is also something I was trying to discuss with students over Telegram, and they they asked you what is right regarding the stain. So when I talk about pearls or Prussian blue, it is for iron, but the name suggests it's blue. It's not giving a red color, so ye galat hua, right? Then when I talk about alizarin red S, it is definitely for calcium, but the name suggests red, so it cannot be black. So this is also ruled out. When I talk about Van Giesen, if you remember, we've used it for elastin. Where do you remember that photo of giant cell arthritis where I use Verhoef Van Giesen stain, and that usually is a silver stain, so giving a black color. It was never giving a blue color. This is also ruled out. So now when I have to, I'm ruling out one by one, I come to the last one. I see mast cells and purple color. Yes, but usually I read mast cells are purplish on toluidine blue, but can they also be stained with Gimsa? That is correct, because the property which I had taught you even in the LRR sessions were mast cell is metachromatic, which means it is always going to give a different color under the microscope. Remember that story of the topper of your class who says that he has not studied, but on the day of the exam has topped. So remember the two-faced person. We told that metachromasia means two-faced. It is of a different color, but shows a different color. So yes, this is something which must have taken a lot of time because you had to go first stain, then substance, then color. So obviously time consumption hai. But if you spent that 30 to 40 seconds to it, which it deserves, you should have been able to come to an answer. And over here, yes, guys, to save time, I have not written A, B, C, B, C, D, etc. I have written down the options and we are making the correct combinations out of it. Because if I would go by A, B, C, etc., then everyone would come up with different combinations and that will just create a lot of confusion, which I don't want to, at least right now when you're freshly out of the exam. Moving on to the next one, I would take a very fast pass through this because you've just now discussed it with Deepak Marwa sir regarding the revised Jones criteria for rheumatic fever. And I believe I was watching the session. Many of you were confused that time also that whether only the major criteria were asked or whether the minor criteria were asked, what was exactly asked. But if I just have these in front of me, carditis, yes, pancarditis is a major criteria. Fever is definitely a part of the minor criteria. Then erythema nodosum is something which is not a part of the criteria because it is erythema marginatum, right? So this is not a part of any major minor criteria. Sydenham's chorea is and prolonged PR interval is. But yes, nodosum obviously nahi hota, right? That is, it's erythema marginatum that happens in acute rheumatic fever, right? So is that okay with everyone? But Acha, shortened PR interval was mentioned. This is something new that I've got. Okay, sorry. Then that changes the answer altogether. So then this also, what was it? Were you having to mark major and minor? Was it match the following? The framing of this question, of course, will then change a lot, and I'll put a star on all these questions, which I have to work on after I will be discussing with you on Telegram over the next few days. And once the final language is settled, then I'll be uploading it on the app. I'll also share a PDF with you so that, by that time, but you've broadly got an idea that, yeah, erythema nodosum definitely is not, short PR interval and all is not. So that is multiple choice. Okay, perfect. So I think in medicine also we will be working on it, and also in pathology. Moving on to the next, this was another one. Were there 2 questions related to rheumatic heart disease? If I just go through these, there is a little language problem that I faced in this question also, because I felt they might have tricked you somewhere. So help me with it. What is true regarding rheumatic heart disease? Does it show ash of bodies? That is correct. Is it group A beta hemolytic streptococcus? I mean, of course it is. Can it show myocarditis? Yes, as a, we know rheumatic heart disease in fact shows pancarditis, right? It shows pericarditis, the bread and butter appearance, then myocarditis and endocarditis. So does it show myocarditis? Yes. But if some student said, ma'am, the option was that it only shows myocarditis. Agar only likha tha, then it becomes false because rheumatic heart disease is pancarditis and not just myocarditis. So, reading, and right now you must be thinking, oh, was only written or not written, and you start doubting your entire existence on that one word. But the thing is that that's how INI-CET has played, and that is why I want to tell you that even I am conducting a recall session, but I every time after the exam tell students, don't break your head over recall sessions, because you really don't know what you're discussing right now, what versus what might have been there in the exam and you might have missed it. You can't really take a guess on that right now. So there will be a certain variation in the exam result versus the recalls of a million platforms that you might be watching right now. So know it for getting closure, because you give an exam, you are in a lot of dilemma, what has happened around you. So you just want closure on it. But then it's very important to put a stop at the right time and then come to the fact that, okay, now I have to just stop looking at recalls. I've done my bit for 24 hours and now I'm going to move forward, wait for the result to come, and then let's see what happens. Let's see what's destined, right? So you have to come to that closure at one point of time. And I think after these recalls are done, just put an end to it. Moving on to the next, is it associated with aortic valve rupture? Again, that seems to be false. So now if they're asking you correct statements, of course, the first 2 are correct. The third, I've told you what language would make it true or false. And the fourth one, aortic valve rupture, is not something which is commonly seen with rheumatic heart disease. So that is definitely false. Moving on to the next question was, I didn't see too much of hemat, because usually INI-CET loves to give you way too much of hematology. I saw 2-3 questions of hematology, one from anemia, one from lymphomas. Leukemias were not there. I don't know if I've missed it. It hasn't reached me, but I didn't see the usual AML, ALL happening this time. Over here, you had a question whether Menzer index was 11. That must have been a buzzword making you think towards thalassemia. Further, the RBC count increased with microcytic hypochromic, further points towards, this is what everyone told me, MCV इस range का था मैम, 70 to 79 के बीच में सबने अलग अलग values मुझे बताया, but that is okay as long as it was less than 80 femtoliters, microcytic था, that value then does not matter, right? So it was less than 80. Men's are 11. This means we are thinking now of thalassemia trait. Further, they said target cells were also there, which can be seen with thalassemia. So what would you be doing in that case? HB electrophoresis, HPLC, whatever, or both were there in the options. So then you would have to select on both of these, right? So this is what is done. And of course, HPLC sentence is considered to be better, but whatever was there out of these, you had to mark. Many of you wanted to first, ma'am, first we always go in for iron studies. Yes, with a microcytic hypochromic we do, but when a Menzer of 11 and RBC increased is there and they are indicating towards thalassemia, I would want to go in for electrophoresis. Okay, so MCV 72, theek hai. Anything between 70, 79 pretty much means the same, so we'll not argue over that. Moving on to the next question where we had, this is a question which only one student sent me on Telegram, so I have my own doubts on it, whether this was even a part or was it like, because not everyone gave me this question. So I have my own set of doubts on this question. You can help me with this. Was there something to do with retinoblastoma? And whether it is true or false. If yes, I'll just go through the options. You can just give me confirmation on this. Retinoblastoma, always unilateral? No. If it is familial, then it can be bilateral also. Is it called guardian of the genome? So again, I'm getting yes and no again for this, which gives, I mean, I don't know. I didn't give the exam, so you are the only people I am depending on to let me know. Is it guardian of the genome? No, because we know it is P53, which is the guardian of the genome. Then coming to the next, RB gene is, remember that story of the love affair and a third person coming in, which we do in our rapid revision and main video. So retinoblastoma is usually hypophosphorylated, does not have phosphorus, right? Does not have phosphorylation, but that would mean it is the active state. The usual active state of retinoblastoma is hypophosphorylated. So this statement was also written falsely. So now the only correct one, if I can see, oncogenesis is associated with loss of function mutation. Yeah, that is usually seen with all tumor suppressor genes like P53B. When there is loss of function of P53 gene, then cancer occurs. When there is loss of function of retinoblastoma gene, then cancer occurs. So the only true statement over here, I think, is this. Now you have to see what was asked. If false was asked, then ABC is false. If true statement was asked, then only D is going to be true. Is that okay? Options were a little different. So you can, at least we've come to this consensus that the question was there. So maybe we have one or two more options which we've not gathered because very few students actually touched on this. So again, this becomes a little bit of a homework for us to do later on and gather this question. Moving on to the next one. Again, a controversial one. In fact, this is the first question I received as students walked out of the exam hall. And ma'am, there was something on Prader-Willi and Angelman, and we thought both of the options were correct because they were dealing with a boy 46XY and they said deletion 15, and that is exactly the site where imprinting occurs in both Prader-Willi and Angelman. So only on this much of information saying Prader-Willi, Angelman is just next to impossible because that's the imprinting site for both. Later on, many students have told me that somewhere, now you need to tell me whether both were mentioned or one of these were mentioned. They said obesity was one hidden word written somewhere in the question, which very few students have told me that was. Because then that gives you a clear cut answer, right? Because obesity and increased ghrelin takes you towards Prader-Willi. But then I totally agree with many of you that many students have told me, nahi ma'am, kuch bhi nahi tha. Truly, they just gave us this information and there was no history. So that put me also in a dilemma. If I would have been in your place and if I would have been, if I would have had this, then it's a clear cut Prader-Willi. If I would have been stuck in such a situation, I don't think kuch hai is question mein which we are not able to get. But let's assume I take it on face value and I say that you are saying ki ma'am itna hi tha. Going by the more commonality and how questions come more often, I would have still taken a smart guess or a vague guess or just a destined guess towards Prader-Willi syndrome. But there is something which still stands missing in this question, which we are not able to gather up till now. So let's take a wait on that. But yeah, I still told you that if I would have been in that situation, Prader-Willi still would have been the smarter answer that we would have gone in for. Okay. Okay. Many of you are saying obesity was in a different one. So, okay, let's wait. I've not got any other questions. So, agar tha, to maybe we can work on that question and then again, we'll be able to work on, frame that properly. Moving on to the next one, was this a separate question or was this part of that Menzer index wala question regarding microcytic? Because this seems too easy to be an INI question. I mean, I had my doubts on this. Someone sent me a screenshot on Telegram. Which of the following causes microcytic anemia? I mean, the Sita, Sheetal mnemonic. You guys have done this so many times, and you know B12 deficiency causes megaloblastic or macrocytic. But is it truly a question that came, or was this was not? I don't think this could have been the question. I mean, this. Okay, this was the question tha. Okay, very good. I mean, sometimes we just tend to overthink. Like I was overthinking that, oh, really, could this be a question? This was there, very good. Then I'm so happy about it. And this means you guys have got it right. There's no doubt on that. So I don't think we would want to spend more time on it. All of these are microcytic, hypochromic, vitamin B12 is macrocytic. Same options the, but different question. Maybe the question would have been a little lengthier, could be that, but as long as the options were this and you got it right, I think we are good to go. Okay, thanks for the input that the value of MCV was given. It must have been less than 80 femtoliters for them to indicate microcytic. That does not change much at all, right? Perfect, guys. I think this is done. Moving on to not got the options. I didn't ask anyone for options because as soon as I got the question, I knew answer yahi hona tha, that lipid is used or is seen with which technique in pathology. Answer has to be frozen section. I'm sure they must have given frozen section, or if they wrote cryostat for frozen section, that is the same. I didn't ask for more options, to be honest. So oil redo staining, yes. If the stain was asked, oil redo is the stain. We know that. If the technique is asked, then frozen section. Yeah, 2017, since the days JIPMER exam and all these exams used to happen separately. Since those days, the frozen section for lipid has been quite a favorite with them, and this has been one of the direct repeats. Thankfully. Paraffin embedded and all other options don't hold relevance. If frozen section is there, answer is frozen section. Okay, moving on to the next. Another question which I have not gathered. At least everyone told me, ma'am, LRR में से neuroendocrine tumors आया था, which I agree, we have always discussed it in neuroendocrine tumors or in LRR. But then there were 4 histopath images, and those images I have not got. So before I discuss, I'm just letting you know. One image students told me that there is something called neurosecretory granules. That, of course, is a part of neuroendocrine tumor, like carcinoid tumors. But 4 images abhi I have not received. So again, I don't want to confuse you by giving you random images right now. For the previous question, some of you are saying that, ma'am, paraffin options mein tha, ho sakta hai, but you know, when paraffin sections are made, before making a paraffin section, you treat the tissue with a lot of chemicals like alcohol, xylene, and alcohol and xylene will dissolve the lipid. So then they will dissolve it. You won't be able to see it. That is why I said that to be able to see lipid, you have to use a frozen section. Is that okay? And coming on to this is something, because it's image based. I don't want to give you random images and confuse you and make you have a sleepless night for saying you made it wrong or right. It's better that we take a break and we, get the images, and by tomorrow I can give you confirmation on what were the 4 images and what was the answer. Okay, I'm sure when 4 histopath images come, it cannot be easy. I know for a fact, you know for a fact. That is why I don't want to confuse you more. Okay, moving on to the next one. I want to move on to microbiology now. So let's start with that quickly. Right now, I've got 15 questions roughly of both subjects. But since more questions, as all of you are saying, are dropping in, I think we've easily crossed a 30 plus of path and micro this time. And I think micro has been more because they are just integrating that with patho many pending. Yes, Dr. Dharmesh. That's why I'm saying, even if now, if I've got a 30 plus for both subjects, I'm easily hoping, and I know that by tomorrow I will lock in at least 40 plus, because there are so many questions which are still coming our way and which we don't know the options for. So let's wait. There is one question before I start with micro. I mean, just let me know if this was there, because only then I'll work on it. Was there a question related to the RAS pathway and the oncogene pathway and how it works? It must have been there either from physiology or from pathology, either of the two. This is a very core neoplasia topic. If this came, then they have somewhere gone into the main videos. They have made sure that you are not able to answer questions only from rapid revision. Then this means they are going into the core of second year of neoplasia chapter. And we know that the RAS gene, it is the more, remember, KRAS, HRAS, NRAS that we study, they've gone into the mechanism of it. And we have done this very clearly in the main videos. I've touched upon it in the rapid revision videos also. And RAS gene is very much dependent on GTP. When GDP to GTP will happen, when this activation will happen, that is when the RAS gene will start working. So there will be a constitutive activation of the GTP binding protein. That is how RAS works. And when RAS is activated, we know multiple pathways are going to get activated, like the MAP kinase pathway or the PI3K pathway, or even the BRAF pathway can be activated. So all of these pathways are going to get activated once the RAS gene is activated. This is a very core main videos, second prof kind of question. And we know, being it INI-CET, I would not expect this in a NEET PG or FMG, but in INI-CET, where they want to get the details of pre and paraclinical subjects out, this is a core INI-CET topic. RAS map kinase. Okay, so this was a question. We've added one more in pathology then. Okay, moving on to the next one that we have. Let's start with micro. After that, if you have more pending questions, you can let me know. Which of the following is an obligate intracellular organism? So many students told me that, ma'am, हमें ये दोनों लग रहा था. First confusion was कि at least answer, I would have been in your place. The single best answer अगर ऐसा situation था, it would have been Ulricea. Whether they wrote Ulricea schaffensis or they wrote just Ulricea, it means the same. So whenever we are talking about this family, that is Ulricea or Anaplasma, because these are very famous those INI-CET topics, right? So in Ulricea and Anaplasma, and if you guys remember in the RRR app की जो live classes थी, TND था, in that also I taught you the Ulricea versus Anaplasma difference. That Anaplasma, you will see the inclusions in the neutrophils, and in Ulricea, you will see it in monocytes, basically always inside a cell, because they are intracellular organisms. So this is something which was a part of the test and the discussion that we did. So of course this had to come. Many students also have read that Tropherema vipli bhi to ma'am aap padhate the, pass positive macrophages. Yes, they are found inside the cell, but they are not obligate. This means they are not only and only going to survive inside the cell. They can be extracellular also. Okay, so single best answer is going to be this. Okay, हाँ, coming to that diarrhea wala question also, I think एक या दो slides में आ जाएगा. This was another one, thorn prick injury, their favorite. One prick has to happen, either a thorn prick or a Rose Gardner ka history, so something related to that. So it is a common mode of infection in all except, of course, in sporotrichosis it is Rose Gardner's disease, rose thorn. Chromoblastomycosis, you must have studied copper penny bodies, पढ़े बिना कोई exam में नहीं जाता, so that foot picture of cauliflower lesion after a walking barefoot, so prick can happen, trauma barefoot walking का होता है. Mycetoma madura foot, of course, you know, is one of them. So which of the following is not, is except पूछा था ना, तो dermatophytosis is something which is not. इस बार थोड़ा different आया. Usually in dermatophytosis they always end up asking you the घिसा पिटा TME, PSC. So this time they decided to take a skip. Maybe they don't like my Telegram channel. Maybe they feel that it is all full of people trying to sell apps or whatever. So they decided we will now not go for this Telegram wala mnemonic. We will now give thorn prick injury related. But that either ways has solved your query, right? So then they have, I hope you must have been able to solve this. It wasn't a very tough one. You just had to read through options, right? Moving on to the next one, here it is the virus ka diarrhea wala question that all of you were asking me. Which amongst the following is the most common cause of diarrhea in adults? I don't know why this time they wanted to know about adults, because usually they want to know about infants and neonates. But yes, over here, of course, if I'm sure no one marked rotavirus unless you just read diarrhea and you were just so excited that acha diarrhea matlab rotavirus, but that's in infants. You didn't mark even adenovirus 4041 infantile diarrhea. That is infantile word tells you, so not happening in adults. In adults, what I would have marked is of course going to be the norovirus, which is the answer over here. So yes, that's the answer. A simple one-liner. Even astrovirus is for kids, so you just had to look through it and find the one which you've not read for kids. That becomes for adults. So simple one to go with. This was another one. I think एक या दो options इसमें मुझे गलत receive हुए हैं, which you will tell me now. There was a question on Buscheraria bancrofti, which is to do with filaria, and they said when filaria is not seen in the peripheral blood, then where is it likely to be found? Was lymph node there in the option? Because lymphatic से अच्छा आंसर नहीं हो सकता. But then students told me कि मैम lymph node options में नहीं था. I mean, अगर होता तो then it would have been one of the easiest, I believe, questions. But if it's not there, then the next best answer that I would go in for will be the lungs, because we know that where are the babies or the microfilaria present? They are present in the peripheral blood. They are saying अगर नहीं है, this means they are passing through certain organs, and they very commonly pass through the capillaries of the lungs. So that is nahi tha. So then, of course, as you told me, होता तो then it would have been a straightforward answer. What I thought was INI-CET है इतना easy नहीं करेंगे, so then lungs is going to be the best one that you would go in for. Okay, so many of you were saying skeletal muscle. Okay, so we'll just correct it here and now. So skeletal muscle, even then, lungs is going to be the better answer. Okay. Okay, the next question, I think germ tube test देखते ही समझ आ गया होगा. This was a candida germ tube coming out, whether they mentioned germ tube or not, or just photo दिया था. Either ways you sorted it, and it is shown by Candida albicans, and also remember its cousin brother who follows it in everything. Dubliniensis, although वो नहीं था in the options, albicans was there, so this was also a clear-cut answer. So I think this again no confusion. I'll take a quick pass on this, right? Moving on to the next one. Photo might have been a little different because some students sent me this because उन्होंने सीधा सोचा कि स्टैफ ऑरियस है, बॉट्रायोमाइकोसिस है, तो उसका फोटो नेट से लेके डाउनलोड करके दिया. बट फोटो जो भी रहा हो, all of these pretty, although this does look like a lot like botryomycosis, but as soon as I read the question over here had a very classical thing mentioned about black granules coming out from the discharging sinuses. Now, Staph aureus being a bacteria, actinomyces, all of these, they don't show black granules. Black granules, जैसे ही बोला, there is one thing that is there, and that is going to be Madurella mycetomatus, which is basically a fungus. तो इनमें से जो भी wordings लिखा था, ठीक है, फोटो में या तो फंगस लिखा होगा, दैट इज यू माइसेटोमा, या फिर फंगस का नाम लिखा होगा मदुरेला माइसेटोमेटस, बिकॉज दैट रिलीजेस ब्लैक ग्रैन्यूल्स फ्रॉम द डिस्चार्जिंग साइनसेस. So either ways, that is the best answer. Chromoblastomycosis, I'm ruling out. उसमें तो discharging sinuses नहीं होता. That shows you cauliflower-like lesions. Actinomyces Israeli does have, but Israeli, this is a very famous first aid mnemonic. Israel has yellow sand because that shows you yellow granules and not black color granules. And then Staph aureus being a bacteria, it shows you more of a pus kind of a thick discharge, not a black one. तो ब्लैक ग्रैन्यूल्स रिटन था, तो उसके बाद एक होता है ना बज़वर्ड हो गया, देन यू काइंड ऑफ एलिमिनेट अदर थिंग्स ऑटोमेटिकली एंड कम टू द सिंगल बेस्ट आंसर व्हिच इज हियर. Whether this or this being written, it is the same thing, it's a fungus. Moving on to the next question. Oh, this we've already done. Let's take up the next one. Yes, this was a micro and pharma correlation. I'm sure you've done this in pharma also. I don't know whether they gave you the photo of the egg or whether they gave you the written part, but there is something to do with the pulmonary involvement, and they have given you operculated eggs. So now, of course, you are thinking of operculated eggs, remember, are seen in STD, Spirometra, trematodes, and D-latum. Trematodes में pulmonary कौन सा होता है? So we can think of Paragonimus, P for Paragonimus, P for pulmonary, yes. And then, of course, for trematodes, for all trematodes, the drug of choice is praziquantel. I'm not writing it. Egg का picture था. Wow, that makes it even better. So I'll add the pic in the final PDF, and that is going to be the egg which must have had a छोटा सा lid on top of it. That is the operculated egg. So for all trematodes, it is going to be praziquantel, except Fasciola hepatica, for which it is triclabendazole. Someone said crab ka photo bhi tha. Oh my God, so many photos were there. So somewhere the examiner was feeling good that he wanted to give you one answer in like 10 seconds. Ki acha crab bhi hai, egg bhi hai. So let them just answer and move ahead. That's amazing. I think I couldn't thank the examiner more by giving you this. Was another. So this becomes one of our easier questions. Then I would not even place this in medium category वाला. ये आपको आता था. Pulmonary भी लिखा है, crab भी है, egg भी है. So then egg नहीं था. Some of you have said कि नहीं ma'am. Now as soon as I started saying अरे ये बहुत easy था, some of you just withdrew your options. नहीं ma'am, egg नहीं था. Either ways, crab bhi tha. Then also it's easy, guys. Pulmonary and crab coming together with these drugs written. I mean, you know you're talking about helminthology. Still, it is easy. Okay, I'm not going to take that away. Moving on to the next one. This, I believe, was it truly so easy? ये वाला नहीं हो सकता इतना, because 2-3. I mean, I have myself felt the exam was a medium to difficult level, but then बीच में there are such questions which make me question, that what is the range in which the examiner is playing. That in one way he's giving you RAS ka pathway, and the other side is giving you strawberry cervix. So the student is just confused कि मुझे difficult सोचना है या मुझे easy सोचना है. That gives you a lot of uncertainty during the exam also, that am I overthinking or am I underthinking over here? So this was a straightforward question. Of course, you must have stared at the screen 10 times over कि कुछ ऐसा है which I am missing out, because it's INI-CET. But then again, of course, strawberry cervix, trichomonas vaginalis. Yes. The next question was something to do with the life cycle. What many of you sent me was this photo, but the photo that you guys downloaded from the internet had a couple of proteins written on the side like L1, L2, which I have cropped out because I don't think any examiner would write all the proteins and then ask you, वो तो फिर L1, L2, E4, E5 से तो सबको ही पता है that it is human papilloma virus. There is no doubt about it. But if that was written, L1, L2 लिखा था, very good, excellent, but I don't think ऐसा होगा. I believe it must have been cropped, right? If the image has been cropped, then you're left with just this much, where there are written things like corneum granulosum, basically epidermis का layers हैं. And I've always told you a virus that loves to play in the squamous epithelium, and that is why it causes cancers wherever squamous epithelium is, like cervical cancer, cervix, squamous epithelium. Anorectal region cancer, squamous epithelium, penile cancer, squamous epithelium, head and neck cancer, squamous epithelium. So HPV is one thing. Is it an RNA virus? Not at all. HPV is a DNA virus. Is it an oncogenic virus? I mean, we couldn't have any doubt on that. It is causing all the cancers we know. Vaccine is not available. Gynae mein to padha hi hai ye. Vaccine is the mainstay. And most common manifestation is painful genital ulcers. No. So that only true thing which I can think over here is oncogenic, provided it was HPV. Okay, so nahi likha tha na. That is what I kind of guessed it, although many of you sent me a photo in which all those proteins were written, but I don't think they would do such a thing. They obviously gave you a virus, virion virus words likha tha, so they were telling anyway the options were related to viruses, and they focused a lot. They didn't erase this part, so they focused a lot on the squamous epithelium and layers of the squamous epithelium. So they were indirectly wanting you to look at an image, get thoroughly confused, then come to the options, and then assimilate everything and come to a thought of which virus could lead to this. Okay. Moving on to the next one. This was one anda always has to come. So this is the segmented blastomeres. This must have been the hookworm wala egg जिसे हम हमेशा लिखते ही ऐसे थे in all our video lectures. So whether Nectar americanus was written or Ankylostoma was written, both of them are hookworms. So you had to select whatever was there. Other automatically get ruled out. Okay. Moving on to the next, there was something about that typical aspergillus wala because again we always remember acute angle branching and septate hyphae. Along with that, a cardiac history was given that there was some exophytic valvular vegetations that were there. GMS stain, GMS at least Gomori methenamine silver stain, silver मतलब black color, photo में कुछ black color होगा. Fungus GMS के साथ you must have thought कि हाँ fungus की तरफ है, and then when you saw the acute angle septate hyphae, aspergillus becomes the answer over here. Chromoblastomycosis, copper penny bodies, clear cut नहीं दिख रहा. Mucor का aspergillus से बिल्कुल opposite. Candida का pseudo hyphae वाला photo is not seen over here. So I think even you didn't have to rule out. It was pretty clear cut. The acute angle was there. Some of you also told me later on कि कुछ acute angle का degree लिखा था. Was it this question or was it a different question altogether? Was like the degree of acute angle also written? That doesn't make much of a difference. Acute angle is acute, whichever degree of it is there. But just for completion, if it was, you can let me know. Coming to the next one, which was a match the following. There should have been 4 options, but I'll let you know what I have received up till now. Cutaneous larva migrans is seen with, of course, hookworm. So that is Ankylostoma. We've seen that photo also. Then visceral larva migrans is seen with roundworms, usually non-human roundworms. So if Toxocara canis was mentioned, or even if some species of Ascaris was mentioned, तो चलेगा. Larva currens had to go with strongyloids, and what towards the end students told me कि कुछ swimmers itch करके भी था. So then of course if there was anything related to schistosoma that was there, that should have been marked. This I am not sure कि swimmers itch ही था last option या कुछ और था. Swimmers dermatitis था. Okay, we can still go with, provided the option in the other side was something to do with schistosomiasis, maybe schistosoma mansoni, etc. Is that okay with everyone? Okay, you're saying there were 4 diseases and there were 5 organisms. Something they are saying partial nahi hoga. I don't know. This is my just a guess. circarial hoga, because do you remember that schistosoma is caused by which larva? Everything of schistosoma goes by CCSSS wala sound, so it is the circaria larva which was there. So maybe they just twisted the terminology that ways, and instead of calling it a direct schistosoma, they called it circarial dermatitis. ऐसा हो सकता है, but then you just had to remember कि circaria word मैंने कहाँ पढ़ा. It is the same as circaria larva, circaria for schistosoma, right? So then, okay, that's a very good, I mean, a very twisted way of putting it. But sometimes in match the following, what also helps you is कि अगर 2-3 आप match कर लो, then you know when you're left with that last thing, you can play around and take a guess on that, right? Okay, so I'll change the terminology over here as well. Moving on to the next one. I don't know if this question was truly as lengthy as students have made it, but I've not seen too many extremely lengthy long stem questions. There have been medium stem. I have not even seen any one-liners this time, except for maybe one egg ka photo ya kuch. Mostly the questions have come out to be as medium stem questions. So what I think is, while I'll be making the final recall, I will have to add 1 or 2 lines, at least 4-line sentences mujhe average laga har jagah hai. Neither have they been the typical USMLE 10-liners, nor have they been the typical one-liner. One एक medium stem question उसके अंदर लगा है overall, if I take an average of the paper. Moving on to this question, I think, was this buzzword clear cut mentioned, some carom coin or draughtsman colony, or were you just analyzing on the basis of the diplococci and the lens shaped? It was an image-based question. Either way, see, it was Streptococcus pneumoniae, and we know the famous bio, so bile solubility mark kiya hoga. If not bile solubility, then inulin fermentation and optochin sensitivity. But I think everyone told me bile solubility. But um, lanceolate shape was not written. Okay, then you are saying कि image इसमें दिया था, but alpha hemolytic लिखा था. Even if this, तो everyone has told me कि लिखा था, because if alpha hemolytic was written, either I'm thinking of Streptococcus viridans or I'm thinking of Streptococcus pneumoniae. And with this kind of a history given, my first thought would go towards Streptococcus pneumoniae, right? Then in that case, either ways, bio positivity ही होना है, right? So alpha hemolysis was mentioned, right? So that just narrows it down to only 2 bacteria out of all. And usually examiner doesn't give questions from the first 2 chapters of bacteriology. You guys have been pretty lucky. Examiner को अच्छा लगता है वो last वाला chapter, Rickettsia, Chlamydia, Spirochetes, most of the times, because examiner assumes कि first 2 chapters सब पढ़ के आए. You've been very lucky that you've got a question from staph and strepto. That has been good. Some of you are saying there is a photo of streptococcus that was present in chains. Okay, if it was present, anyone who can tell me about it? Was there a photo present in chains? I don't think, because chains wala viridans की तरफ ज़्यादा जाता है. There must have been a photo which was probably, you assumed it to be chains, but there must have been a photo where the bacteria would have been present in the form of these lens wala diplococci. I don't know if capsule was there or not. But alpha hemolytic likha tha, it is going very much in favor of Streptococcus pneumoniae. Moving on to no chains, right? So that doesn't fit also. Chains goes more towards viridins, and that doesn't fit in this entire question. This is a question which I think PSM may be discussed ho gaya hoga ab tak. Biosafety level for MTV, biosafety level 3. I don't know why there was a confusion on Telegram ke 2 hai ya 3 hai. It is BSL 3, so there should not, yeah, that is someone was asking me. BSL 3 hai, I really don't know where the confusion has come from. If you are appearing for future exams, go back to the main video lectures. There is a separate 5-minute lecture on biosafety levels. I had added it recently also, mainly because I knew कि PSM में अगर नहीं भी पढ़ा तो micro में पढ़ लोगे, so at least you will be able to come to an answer. So this was okay. This I was seeing you guys were discussing a lot in the pharma session with Ankit sir. So the doubt remains with me also, because if I just ask you what is the drug of choice or treatment that you would want to give for cryptococcal, liposomal amphotericin B plus flucytosine, yes, that is the initial management जो हमने बार बार पढ़ा. ये question बहुत बार आ चुका है in every exam. And yes, in the maintenance, you can give fluconazole, but again, I don't know how this question was framed कि single option है, multiple है. But if I had to go for the single or initial single best, I would go for lamb with flucytosine. So yes, this is something, but I know I would not want to get into this. Reason being कि I have seen all of you have done a detailed ये नहीं था sir वैसा था in the pharma session, so I don't want to start that cycle all over again. We will still wait for more students to give us answers. and to give us options of these so that we can come. But I've told you कि broadly जो answer बनेगा वो इसमें से बनेगा, that the initial therapy is LAM plus flucytosine with maintenance of fluconazole. We just need to see how the options were placed so that we can fit our answer into it. If the initial management was asked, then this of course is the best answer. Moving on to if I'm missing out on something. Yeah, there are two more questions left. एक तो something about Nipah virus. Was there a life cycle given? Typical, you know, वो fruit bat वाला वैसा दिया हुआ था? Or did they just write Nipah virus? Or did they give you a life cycle and you had to guess Nipah virus? That is something you can let me know. And in that, let us just go through it. तो life cycle दिया था. Even better. I mean, then I don't think anyone, at least Nipah virus तक तो everyone would have reached by looking at that fruit bat. That is amazing. Does it have 100% fatal? It is highly fatal, we all know, but that's 60 to 70, even up to 80%. It's not a 100% fatal thing. Do fruit bats act as a natural reservoir? That seems to be a correct statement. Is Nipah virus a DNA virus of the Rhabdoviridae family? Rhabdoviridae तो खुद ही rabies है, वो RNA है. This is totally wrong. Nipah also, this is not fitting in any DNA virus story. And does it spread through mosquito bites? No. Fruit bat बार बार बोल रहे हैं, तो mosquito bite does not come. One more thing which some students had told me कि एक option में मैम encephalitis लिखा था. So yes, it is known to cause encephalitis, and that is the reason it has such a high fatality rate of 60 to 70%. So I will now want to know that अच्छा कौन से options इसमें से थे, because I've told you the correct and the wrong ones. Everything is wrong, only two are correct कि fruit bat से होता है और encephalitis कराता है. Okay, encephalitis mention था तो वो तो कराता ही है, we know that. There's no doubt about it. Acha, okay, you are saying human being was written as a reservoir, then that would also have been wrong. I think then students must have told me the right one कि उन्हें क्या लगा. If human word was written over here, human beings are not. So human if I make a human over here, then this statement also becomes wrong. In that situation, the only correct one will be encephalitis कराता है, बाकी सब गलत हो गया. I think we've come to a final answer on this. The last question, I think after which we would go in for surgery and psychiatry and FMT, is a question which was related to diphtheria toxin, because assuming diphtheria toxin, reason being that students told me कि ma'am elongation factor 2 के ऊपर था, that it is decreasing protein synthesis. Remember, we always studied by causing ADP ribosylation of elongation factor 2. So when this kind of a statement comes, either I'm thinking of diphtheria toxin or I'm thinking about the exotoxin of Pseudomonas, right? Exotoxin A of Pseudomonas. This mnemonic we have done so many times, but now they've asked you what is incorrect. Firstly, was this in many of you are saying कि ma'am, अच्छा, this I didn't know. Thank you for the input. कि image based question था. I thought they had written that there is ADP ribosylation of EF2. So this is something that I will have to work on. But abhi tak what I know, is it the most toxic? Let's assume. So many of you are saying कि image किसका दिया था? Was the image given of diphtheria toxin? Was the image given of Pseudomonas? Anything that was mentioned? Diphtheria image based था, ठीक है. So let's assume that this is diphtheria. Is it the most toxic known to man? नहीं, उसमें तो most अगर toxicity की बात करें तो that would have been botulism, or maybe they would have given me questions on anthrax, not on diphtheria. Most toxic, no. Does it cause myocarditis? Yes. We have studied this as a PYQ, as a late complication. वैसे तो diphtheria causes that pseudomembrane on the tonsil and bull's neck, we all know that. But as a late complication, it causes myocarditis. That is correct. Is it an exotoxin? Yes. And no vaccine is available. वो तो DPT, so they तो totally out हो गया. So if they ask me what is incorrect अगर पूछा था, तो I have my answers ready. अगर correct पूछा था, so then that is also ready in front of me. D option not given, I guess. Acha, vaccine was not, then what was the D option, Dr. Dharmesh? I would need that input from students so that we can decide whether that was correct or incorrect. Yes, so I think this is something which you guys can let me know gradually. And right now, as I said, with your inputs, 30-31 तो हमारा हो गया है, but as all of you are telling me कि मैम और भी questions थे, then let's wait for another day. And I think by tomorrow, I'm sure we'll clock in 40 plus, which is a huge number. I believe that Path Micro combined 40 plus in an exam, which I assume for INI-CET, it is pre-paraclinical heavy. But 40 plus still for these two subjects, just tell us that you like it or you dislike it. You will have to study it because the examiner still loves these subjects. HOCM ka IBQ, Dr. Dharmesh, what everyone told me was that it wasn't, a pathology question. Everyone told me it was more of a medicine-oriented question where they were asking about the cause of death or something like that. So pathology inputs मुझे नहीं मिले. अच्छा, thank you for the input. Someone said कि diphtheria वाले में phage coded was one option. So that is correct. When I talk about phage coded, so diphtheria toxin, which we talk about, it is phage coded. So if that was one of the options, then that is also a correct statement. Okay. So yes, I think we are done. And as I said, recalls are for your closure. I hope you got your closure to some extent. Some minor things will keep lingering in your mind till many days to come. But from tomorrow morning, please do not watch any more recalls. Live your life ahead. If you have work to do, continue. If you have no work to do, just spend time with your family, chill, sleep, catch up on sleep, enjoy life. Don't keep watching the recall videos again and again for the next 1 week. It is not going to help you. Ultimately, what is going to happen is going to happen. So this has given you a decent amount of closure. So just get over with it. Even if you don't feel like giving me options after this and contributing, I would not mind it, because I would have been in your place. I would have cut off from the academic world and just taken time off to rejuvenate and to just get my sanity back in life. So that is totally allowed to you, that you cut off from academic world and live your life, because these are moments that you don't receive as a medical student or don't get many times in life. So if you got it now, don't just waste it by talking about the same exam over and over. Right? I hope Path and Micro lectures helped you guys, and I'm not going to take more time. Rest of the talks can happen later on. But yes, we have other faculties waiting. If you have any more inputs, if you feel that you want to just contribute a little to the options, put it in the comments, write to me on Telegram, wherever you're comfortable. But yes, congratulations once again for finishing this exam. And I'm sure no matter what the recalls have told you, I'm sure the final result will work your way. So just don't lose out on the faith as yet. Wait for the result. Things will work out. So thank you so much for joining in, and let's continue with the next faculty for the next.
Your life. Hi guys, welcome to this session. I hope you people are quite tired. So let's finish this session quickly. Let's start the questions. First question, high tissue inflammation reaction seen with which suture material? So you know that the high tissue inflammation reaction is seen with absorbable sutures. And which absorbable sutures, which are natural or synthetic? Natural. So here you can see which one is natural absorbable suture. Guys, it's catgut. So you know that catgut is natural absorbable suture. So this is natural absorbable suture, and this is having high tissue inflammation. So this is having high tissue inflammation. Clear, guys? So here, correct answer is option D. It is catgut. It's not polyglactin. It's not polydioxanone, and it's not the polyglycaprone. Clear? Now see the next one. You can see the next question, guys. Next one. The angle between two working ports in laparoscopic surgery. So you know that angle between two working ports, that is manipulation angle. An angle between the instrument and optical axis, that is known as azimuth angle. So here it is manipulation angle. What's the answer? Manipulation angle. You see the angles quickly. See the angles, guys. So here you can notice that this is azimuth angle, and this azimuth angle is angle between surgical instrument and optical axis. Elevation angle, what is elevation angle? You can see here, this is the elevation angle, is the vertical axis measured between horizontal plane and an object. And manipulation angle, this was the question this time. Last time they asked azimuth angle. So it's a angle between two working instrument. So what is the correct answer for this question? That's manipulation angle. Clear? Manipulation angle. Okay, guys? Okay, guys? Definitely, guys, I will be providing it. Okay, welcome, Saf. Now see here, arrange the following steps of surgery in order. So it is about laparoscopic cholecystectomy. So here, first step would be create pneumoperitoneum. After that, you have to dissect hepatocystic triangle and then go for ligation of cystic duct and artery. And after that, separation of gallbladder from liver bed. So what is the correct sequence, guys? It is A, B, C, D. So this is the correct sequence. Easy. First, create the pneumoperitoneum, dissect the hepatocystic triangle, ligation of cystic duct and artery, and after that, separation of gallbladder from liver bed. So what is the correct answer, guys? Correct answer is option A. Correct answer, option A. Right? Now see this question. Identify the wrong statement. Wrong statement from the following. This is related to stoma, that is ileostomy and colostomy. So first statement, you can see option A. Ileostomy loop is generally kept pouting. You know that ileostomy should be kept pouting. It should be kept pouting. Why? To prevent the contamination of the skin, to prevent the dermatitis. Next, it is correct. Maximum absorption of electrolytes and nutrients is seen with colostomy. That is also correct. And that's why you know that this electrolytemia, it is more common in ileostomy, but it is not very common in colostomy. Stoma of colostomy is everted and above the skin level. No. Stoma of colostomy, it is flush. It is flush. So it is kept at the skin level. Why? Because the fecal matter is solid. So this is incorrect. Only muscular layer is taken in sutures while creating ileostomy. This is also correct. So A, B, D, these are correct, and C, that is wrong. So what is the correct answer here, guys? The correct answer here, correct answer is option C. Okay, Joy, thank you very much. Now see this question. Identify the wrong statement about late dumping syndrome. And we discussed dumping very many times. In late dumping, you know, it is after 2 to 3 hours of meals because of hyperglycemic content. Clear? It is because of hyperglycemic content. And since it is because of hyperglycemic content, there is increased insulin secretion. And because of that, patient will be having reactive hypoglycemia. So what kind of manifestations will be there, guys? Patient will be having manifestations of reactive hypoglycemia. See the options. First, symptoms start after 2 hours of food intake. Correct. Symptoms worsen with physical activity. Correct. Symptoms are relieved on lying down. These symptoms are relieved on lying down. Which symptom? Yes, early dumping, not the late dumping. So what? This is incorrect. And clinical features, obviously, it will include signs and symptoms of hypoglycemia. So that is tremors, dizziness, palpitations. Correct. So incorrect option is option C. Clear, guys? So incorrect is option C. Okay. Next question. Guys, if you want to give your input, you're free to give your input. Clear here. Next question. Which of the following hernia is being operated in the image given below? Following hernia is operated in the image given below. Can you see, guys? This is Meckel's diverticulum. And all of you know, whenever Meckel's diverticulum is the content, if Meckel's diverticulum is the content, you know, if Meckel's diverticulum is the content, yes, in that case, the hernia is known as litters. And whenever appendix is the content, appendix is the content, then it is known as Amyans hernia. It is Amyans hernia. What is Gibbons hernia? That is hernia plus hydrocele. And what is Richter's hernia? Whenever there is herniation of part of circumference of bowel. Herniation of part of circumference of bowel. So that is what? Richter's. So here you can see this is Meckel's diverticulum. And since it is Meckel's diverticulum, correct answer is what? It is Litter's hernia. Clear? So correct answer is Litter's hernia. Next question you can see. A patient has undergone lap cholecystectomy under post-operative observation. Drain kept shows bile fluid. Ultrasound is normal. Patient is afebrile. MRCP shows 200 cc collection. What is the immediate next step? Guys, here the language is exactly not clear. See, you can see ultrasound is normal, but on MRCP there is collection. After lap chole, if there is collection, what we have to go for? Ultrasound or CT guided percutaneous aspiration, or we can insert a drain, pigtail catheter insertion, right? So it's not the close observation. Urgent percutaneous drainage, that is correct. Redo laparoscopic ligation of stump, that is not required. Laparotomy is not required. So whenever there is suspected post-operatively diagnosed bile duct injury, first, control the infection. Second, drain the biloma. Third, complete the cholangiography. And fourth, we go for definitive intervention. So what we are going to do here, guys, we are going for what? We are going for percutaneous aspiration. So what is the correct answer here? We go for urgent percutaneous aspiration. Okay, right. Okay, somebody was saying that biliary leak was there. Okay, this is one question, guys. Some students said that the question was something like this. Patient has undergone lap cholecystectomy, Mia Roy, INI-CET 25. So patient has undergone lap chole. Drain was inserted because of difficult gallbladder dissection. Day 7 drain output is 300 ml. Drain output is 300 ml. Patient is afebrile. CT does not show any collection. MRCP shows cystic duct stump leak. Let me explain. This was the patient. This was the cystic duct. Okay, guys. From cystic duct, what was happening? Here, there was bile leak. Why there was bile leak from cystic duct stump? Because during surgery, either a stone migrated from gallbladder into CBD or some kind of edema occurred in CBD. Whenever there is cystic duct stump leak, how to relieve the leak? We have to put a stent. Or if the stone is there, perform ERCP and take out the stone. So stone is there, take out the stone. And if some kind of edema is there, perform the stenting. So what is the preferred answer here? ERCP with stenting. So ERCP with or without stent. That's the next best management. Pigtail catheter insertion is not required here because the leakage occurs from cystic duct stump. Redo laparoscopic ligation of stump is not required. And follow up as it will heal on its own. No, we have to perform the intervention. And what is the intervention? क्या करना है? ERCP. अगर stone है, you remove the stone. And if some edema is there, perform the stenting. Got it? So correct answer is option A. Clear, guys? So correct answer, option A. Okay. Now see the next one. You can see this picture. A woman presented with following findings in left breast since 3 months. Okay. There was pain since 2 months. What is the management plan for the following? So this patient is having inflammatory breast cancer. And guys, you know what is the treatment? It is neoadjuvant chemotherapy plus MRM plus radiotherapy. So this is neoadjuvant chemotherapy plus MRM plus radiotherapy. Let's see the options. Simple mastectomy. No, we are not going for simple mastectomy. Second option, neoadjuvant chemotherapy followed by radical mastectomy. We are not going for radical mastectomy. MRM followed by radiotherapy. No, correct answer is D. We are going for neoadjuvant chemotherapy followed by MRM. Got it? So correct answer is neoadjuvant chemotherapy plus MRM plus radiotherapy. Here the correct answer is option D. Neoadjuvant chemotherapy followed by MRM. Clear? Now see the next question. A child spilled hot milk on his hand. Image of burn is given. Identify the degree of burn. Guys, exact picture is not clear here. So it is looking like superficial partial thickness burn. Some students were telling that, sir, blisters were also there. If blisters are also there, that is superficial partial thickness burn. No blisters, only mottled appearance, whitish, pinkish appearance, then it is full thickness burn. And if, sorry, it is deep partial thickness burn. And if there is black colored leathery eschar, if there is black colored leathery eschar, it is full thickness. In deep partial thickness burn, you know, there is mottled appearance having whitish, pinkish areas. Whitish, pinkish areas. So whitish, pinkish areas. Clear? So in this case, you can see it appears superficial partial thickness burn. Lekin depend karega what language and what image was there. Got it? So blisters, superficial partial thickness burn. If there is a char, full thickness burn. And if whitish, pinkish, mottled appearance, it is deep partial thickness burn. Okay, guys. So here, most probably correct answer is option A. Next question. You know Tigaro classification. Anybody can tell me what is the full form? Tigaro. Toxic, metabolic, idiopathic, D genetic, A autoimmune, R recurrent severe, O obstructive. So guys, this is used for chronic pancreatitis, you know. Figaro classification, this is used for chronic pancreatitis, okay? Okay, Dr. M. Kumar, lymph node dissection tha, okay guys. So there was lymph node dissection in inflammatory breast cancer. So here, Figaro classification, it is used for chronic pancreatitis, right? Correct answer is option B. After that, see, very easy question. It was asked multiple times. Patient is having abdominal pain, right? So patient is having abdominal pain. Clear, guys? So patient is having abdominal pain. And you can see there is raised mucin and CEA levels. So CEA levels and mucin, this was raised. It was raised. Amylase is normal. Let me discuss what happens in serous cystic neoplasm. Serous, you know, the content is serous. Here, CEA as well as amylase, both are normal. You know that there is mucinous cystic neoplasm. The content is mucinous. Here, what is raised? CEA, but amylase is normal. Amylase is normal. And you see, IPMN, intraductal papillary mucinous neoplasm here. Both CEA as well as amylase are raised. Why? Because these patients are having recurrent attacks of acute pancreatitis. So in IPMN, raised CEA, raised amylase. Raised CEA and raised amylase. So here you can see this is mucinous cystic neoplasm. क्यों? Because क्या क्या बढ़ा हुआ है यहाँ बताइए? CEA is raised, amylase is normal. So this patient is having raised mucin, CEA, normal amylase. So guys, the correct answer is mucinous cystic neoplasm. Okay. Now see the next one. Patient with recurrent history of gastric ulcer. So first clue, recurrent gastric ulcer, severe pain abdomen, and there is small mass on the anterior wall of duodenum. So anybody who is having recurrent ulcer, what we have to think about if there is mass in duodenum, Zollinger-Ellison syndrome, that is also known as gastrinoma. And if it is Zollinger-Ellison syndrome or gastrinoma, how to make the diagnosis? Gastrin is more than 1000 picogram. Diagnostic value 1000 picogram per ml. So guys, what is the correct answer? Correct answer is raised gastrin. So how we are going to make the diagnosis? Gastrin level. Clear? Correct answer is option B. Now see the next one. Identify the procedure. See here. Can you see sleeve gastrectomy, duodenoileostomy? It is very similar to biliopancreatic diversion, but at the place of gastroileostomy, there is duodenoileostomy. So in between there is duodenal switch. So guys, this is duodenal switch. You know what is the difference between biliopancreatic diversion and duodenal switch? Here there is gastroileostomy, and in this case there is a switch of duodenum, duodenoileostomy. Common channel 100 centimeter. Here common channel 50 centimeter. Rest of the things are similar. We perform cholecystectomy in both. We perform appendectomy in both, and there is diversion of bile and pancreatic juice. So here, duodenal was there. See the image. So guys, this is duodenal switch. Correct answer is option D. Clear? Now see the next one. See the next one. Which of the following is correct about Hirschsprung's disease? You know that there is failure of migration of ganglion cells. Correct? It causes intestinal obstruction postnatally. Correct? Proximal segment is dilated. It's not constricted. Dilated, and there is non-coordinated peristalsis. That is correct. So option 3 is incorrect. 1, 2, 4. These are correct. Clear, guys? So 1, 2, 4. Okay. Somebody is saying कि sir BPD का picture दिया था. ठीक है. So if BPD का दिया था, you can mark the BPD. We discussed both. अगर gastroileostomy है, it is BPD. और अगर duodenal है, it is duodenal switch, guys. So it depends on the image. So here what is correct? 1, 2, 4. Easy? Okay, BPD was there, 50 centimeter tha, theek hai. So it is BPD. Clear? So it depends on the image. So guys, here what is the correct answer? Correct answer is option C. It is 1, 2, 4. So that's 1, 2, 4. So here you can see this is Hirschsprung's disease. This proximal segment is distended or dilated. Distal segment is contracted. Okay. Next. Which of the following gets the first priority in triage? The first priority in triage should be given. First option, 45 years old unconscious patient with noisy breathing or grunting. If the patient is having noisy breathing or grunting, it means patient is having airway obstruction, and this patient should be getting first priority. Airway obstruction is there. First priority should be given to this patient. 23 years old conscious patient, breathing difficulty? No. 6 years old child crying? No. 60 years old conscious patient with blood soaked pants? So guys, first priority should be given to, yes, patient who is having what? Obstructed airway. So what is the correct answer, guys? The correct answer is, okay, correct answer is option A. Next, 17 years old female, there is recurrent abdominal pain for the last 3 months. Amylase and lipase was raised, means patient is having recurrent acute pancreatitis. Gallbladder is normal. On MRCP, there is choledochal cyst. So it depends. This recurrent pancreatitis can also be seen in, it can be seen in pancreas divisum. So it depends on the image. If this similar image was there, then obviously the answer would be choledochal cyst. और अगर उसमें image दिया हुआ है दो अलग-अलग duct, then obviously it would be pancreas divisum. Okay, guys. So here correct answer is option A. Okay. Now see the next one. Match the following investigations with pathology. बताइए आप लोग. In which condition we perform manometry? Motility disorders, 24 hours pH monitoring, GRD, system EB scan. Yes, parathyroid adenoma. Somebody was saying that, sir, a fourth option with anybody remembers, please tell me what was the fourth option. So if anyone remembers, tell me what was the fourth option. Guys, you can message me later. Yeah, so this is correct. Next, this question was also discussed in medicine. 30 years old patient of RTA brought to emergency. History of vomiting. Patient was initially conscious, oriented, later became drowsy, progressed to stupor and coma. Lucid interval was positive. You can see this extradural hematoma, and this patient is having midline shift also. In this case, you have to go for drainage. We have two options: craniotomy, not craniectomy, craniotomy or burr hole. So we are not going for observation, not medical management, burr hole evacuation. You know in which cases we are going for decompressive craniectomy when patient is having massive cerebral edema. For edema, we are going for craniectomy, not for EDH. So what is the correct answer, guys? Correct answer, what we are going for? We are going for burr hole evacuation. Okay, somebody is saying that, sir, annular pancreas diya tha isme. So what? Somebody is saying that image was given. Annular pancreas, okay, annular pancreas. Okay, but in annular pancreas, because there is formation of ring or annulus, then the patient is having vomiting. Vomiting is there. Okay, guys? Right. So this is burr hole evacuation. Next, arrange the steps of hernioplasty. Go for skin incision first, then identify the sac, reduce the content. After that, we have to place the mesh and close the wound. Anybody can suggest other options? Any other option, guys? Any other option? So this is the sequence ABCD. In incision, identify the sac, reduce the content, place the mesh, and close the wound. Okay? So this is the correct sequence. Okay? ABCD. Now see the next one. 20 years old male presented to emergency with pain in right iliac fossa. Last 24 hours. Diagnosed as acute appendicitis. Which of the following is correct about this condition? So this is acute appendicitis, guys. You know, investigation of choice for diagnosis, ultrasound, correct? McBurney's point is the classical site of tenderness, correct? Oshner-Sharon regime is used in appendicular lump. This is also correct. Prompt appendectomy is done after conservative management in all cases. In all cases, okay. Children and pregnancy, that is correct, right? Children and pregnancy, that is correct. In all cases, after conservative management, we are not going for appendectomy. So appendectomy is not done in all cases, right? So this option is incorrect. Rest all are correct. So A, B, C are correct. D is incorrect. Clear? A, B, C correct. D incorrect. Okay, guys. Now see this one. Patient with hypothyroidism has recently completed a 13-14 hours long flight. Which of the following are risk factors for pulmonary embolism? So you know that hypothyroidism per se is not the risk factor, but prolonged immobilization, yes, it's a risk factor. Smoking, yes, it's a risk factor. OCPs, yes, these are the risk factor. So all these three, 2, 3, 4, 2, 3, 4, 2, 3, 4, clear? These are correct. So guys, 2, 3, 4 are correct. Option C, 2, 3, 4. Clear? 2, 3, 4 is correct. Now see the next question. What is the most common site of Berry aneurysm? And you know that Berry aneurysm is most common in anterior circulation. Can you see what is the site? This is the site. Junction of anterior cerebral artery and anterior communicating artery. So it is anterior cerebral artery, anterior communicating artery. So guys, what's the correct answer? Correct answer is option A. Clear? So correct answer is option A. Clear? So correct option is option A. Mandatory. Okay, the option was mandatory appendectomy. Okay, guys. So it's not. Appendectomy is not mandatory. Appendectomy, it's not mandatory. In all cases, appendectomy is not done. Only when patient is having recurrent appendicitis, then only we are going. Then we are going for appendectomy. Then we are going for appendectomy if recurrent appendicitis is there. Clear? Somebody is saying ki hypothyroidism in all options. अगर all options में है तो you can mark, but what happens? As such, hypothyroidism per se doesn't increase the risk. Clear, guys? Now see this one. 60 years old patient with bone pain, easy fatigue, serum calcium elevated, phosphate low, and serum alkaline phosphatase is elevated. So this is primary hyperparathyroidism. Clear? It is classical case of primary hyperparathyroidism. Patient is having diffuse osteoporosis, and आपको पता है what is the cause of primary hyperparathyroidism? Yes, there is parathyroid adenoma in inferior parathyroid. और उसको localize करने के लिए हम लोग क्या करते हैं? What we go for, guys? What we go for? We are going for cysta-MIB scan. Clear? So we are going for cysta-MIB scan. Here, what is the correct answer? Correct answer is option B. So we are going for cysta-MIB scan. Okay. Now see the next question. All of the following statements are true about Peutz-Jeghers syndrome except. So you know it is autosomal dominant. This is not recessive. This is dominant. This is wrong. Polyps show arborization on histology. This is correct. Associated with extraintestinal manifestations, you know that there is hypermelanotic macules. It is going to increase the risk of carcinoma pancreas, other malignancies, and there are hematomatous polyps. Option A, that is incorrect. These are correct. So all are true except for this. The correct answer is option A. Okay, guys. So correct answer is option A. Clear? So these were the questions of surgery, right? I hope that you really did well in the exam and the result will be really fruitful. So best of luck, guys. Best of luck. Take rest. All the best from the whole team PrepLadder. Okay. Bye-bye. Good night.
So very good evening, everyone. Welcome to the psychiatry recall session. I'm sure today must have been a long day, waking up early in the morning, and now we are having this recall. So we'll quickly recall the psychiatry questions. And first of all, you must be very happy that finally the exam is all done and dusted. So let's discuss the psychiatry questions. And when we see the psychiatry questions, we could gather around 6 questions, and we could see that all the questions were, most of them were doable. And many of the questions we had discussed in our LRR, even in the RR and the main video. So let's discuss the first question. See this first question. So you have to match the type of delusion with their correct description. So delusion of grandiosity or delusion of grandeur, what is it? It is a belief that one is rich. What is delusion of persecution? Here the patient believe that someone is planning to harm him or is conspiring against him. What is nihilistic delusion? Here the person believe that the world has ended, nothing is left, I don't exist, the family members does not exist. And see this delusion of influence here, as the name suggests, delusion of influence here, the person believes that his thoughts or actions are controlled by others. In fact, this is a question, or a question which was directly asked in one of the FMG exam, about delusion of influence. So here they've used this term and they've asked this in the match the following. So I'm sure all of us would have got this answer correctly. Seeing such question, I'm sure you must be very happy seeing the question. And again, as I've discussed, that we have talked about these different types of delusion in the LRR session as well. Let's discuss the next question. So see this question, again a question which we are expecting such question would come. A patient receiving haloperidol injection develops fever, autonomic instability and elevated CPK levels. So patient on antipsychotics presents with such findings. So what are you suspecting? So we have talked about this. In fact, when we talk about EPS, we have discussed what is this? This is neuroleptic malignant syndrome. So the patient has presented to us with NMS, and we know NMS, it's a medical emergency. And again, we have discussed that the first step when we are managing NMS is to stop the antipsychotic. So see, so what we are going to do, see the options. Should we add anticholinergic medication, stop haloperidol? Yes, this is a very important step, because it's a medical emergency, person can die. So first step here is to stop antipsychotic, and we can start dantrolene, which is the drug of choice. Some students said that dantrolene was not there, bromocriptine was there. Again, that is also a drug which we can use. So here we will stop the antipsychotic and we can start dantrolene. I hope this question all of you were able to get correctly. Let's discuss the next question. Again, this is a question you'll see so many times have been asked in INI-CET, and even in other exam, you'll see this question has been asked. A woman presents in the emergency as she develops sudden loss of vision after witnessing a traumatic event. So there is a stressor and suddenly she is presenting with loss of vision, but she appears unconcerned about her blindness. So the person is not caring or is not concerned about her serious symptoms. So tell me what is this? We have discussed this. This is la bella indifference. And in the question, they're telling you that when we're examining, ophthalmological examination is normal and there is no organic cause. So they're trying to tell you that there is no organic cause. So what is the answer here? The answer here is this is conversion disorder. I hope all of you were able to get this. This is conversion disorder. We have discussed this so many times. That is functional neurological symptom disorder. Patient presents with sensory or motor symptoms, but these are functional in nature. There is no organic cause. And la bella indifference we have discussed, careless attitude towards serious illness. So again, this is a question I'm sure a very doable question which has been repeated again and again. Now this is a slightly tricky question, and this is something what INI-CET would usually ask. They would ask such detailed question. This topic, although we've discussed this topic in the main video, so if you've gone through the main video, I'm sure you would have got this. But see, even if you have not read about it, see the names. I always see in psychiatry, try to read the terms and you'll get the answer. 7-year-old child frequently shows anger outbursts that are disproportionate to the situation or the developmental age, and they persist over time for 1 year. So one important symptom we can see that there is disruption, there is anger outburst. Also the question, the patient's mood, the child's mood is irritable most of the time in between the episodes. So in between the anger outburst also you'll see that the mood is irritable. What is the most likely diagnosis? In fact, we've talked about this in the main videos, in the version X video, something known as disruptive mood dysregulation disorder, that is DMDD. Again, I always say try to understand terms in psychiatry from the name. So again, as you can see from the name itself, there is disruption. There is disruption, either verbal or behavioral disruption is there, and mood dysregulation. That is, mood between these temper outbursts is persistently irritable or angry. And these symptoms, they are present for at least 12 months. We make a diagnosis of DMDD. So again, in fact, if you're not read about this, let's try to see the options. We know it is not ADHD here. They're not mentioned about inattention or hyperactivity. In conduct disorder, usually we see that there is violation of rights of others. There is bullying or being animals, destroying property. Those symptoms are not there. And even ODD. In ODD, we know what is there. In ODD, there is defiance. There is negativistic behavior. Attitude is there. So can you appreciate the answer here is it is DMDD. In fact, we have also discussed in the main video as well that DMDD cannot occur simultaneously with ODD, where we know that there is annoyance, defiance, even intermittent explosive disorder. Many of the students got confused between this. See, in intermittent explosive disorder, as the name suggests, there is intermittently explosive behavior, no disruption of mood between the outbursts. So here the answer, remember, is DMDD. I hope if you would have tried to guess, I'm sure you would have guessed this correctly as well. Let's see the next question. Again, this is a topic even in the LRR, if you've seen the LRR also, in the last I've talked about this topic, paraphilias is one of the topics for INI-CET. See, a man derives sexual gratification by touching or using inanimate objects such as the female underwear, undergarments, or shoes. Which of the following is the most likely diagnosis? I'm sure all of us would have got this answer correctly. We know it is not voyeurism. See, double T is coming now. We know touching. Exhibitionism, here the person is exposing his genitals to others. Voyeurism, see here, O is here, observing others engaging in sexual activity or intimate behavior. So here we know it is fetishism. So we have discussed this, fetishism, sexual focus for sexual arousal is on objects, intimately associated with human body or non-genital body parts, which is also known as partialism. See, let's see the next question. Again, this is more of a psychiatry and forensic integrated question, but we also discussed this in the main videos. In fact, this is a similar question was asked even in the NEET PG recently. So again, you'll see a lot of these topics are being asked in various, exams. A patient with schizophrenia attempts to kill his boss, thinking that he was planning to kill him. According to the McNaughton rule, which of the following is true? So tell me what is the right answer here. See, we know McNaughton rules, section 84 IPC embodies McNaughton rule. Now we know it is BNS section 22. Nothing is an offense which is done by a person who, at the time of doing it, by reason of unsoundness of mind, is incapable of knowing the nature of act, or that he is doing what is either wrong or contrary to the law. So here again, we can say that he is not criminally liable for his act on the grounds of insanity. So these were the questions which we could gather from the INI-CET exam. Any other question, any other input you have, you can always, put those input in the comment section, and we'll try to again upgrade the question. We'll try to redefine the question, and we'll put all these questions in the app. So again, all the best. And as I always say, keep smiling, keep moving forward. So thank you very much.
You are live. Hello guys. So very good evening or very good night, whatever. I believe you are pretty much exhausted after giving exams. So this recall session is exhausting, but I'll take as much as less time possible for discussing only the answers of the physiology questions, right? So there are a couple of questions, 10, 12 questions has been asked in physiology. I'll try to give you the answer of all the questions in a quick manner, okay? So the first question that I got from student is that which of the following represent the most stable and the long-term mechanism of homeostasis? So two catchword you have to note here, the most stable and the long term. So you know this question because I believe you must have read about the infinity gain control system. So control system infinity gain, whenever I say, you must have answer that kidney is the answer. So here also most stable means the error of the system is absolutely zero. That means the gain of this control system is infinity, and this is a long-term control system. I told you repeatedly in my class, the long-term control system means it is the kidney. So the change in urine output will control the blood pressure, will control the blood volume, and that is the most appropriate answer in this question, that which is the most stable and the long-term control system mechanism for homeostasis in the body. Got it? So this will be the answer, that change in urine output. So one of the option was the SpO2 change. So all of these, the sweating, tachycardia, so these are the small term changes and they are not very stable changes. They happens from beat to beat also, they happens from time to time also, but the answer change in urine output will be the appropriate answer here. So gain of the control system we had discussed in our main lecture also. So as you can see here, so from here the question has been asked, right? Now the next question, the transpose system image was given. I didn't get the exact images, but most of the students told me that it was the image of the sodium potassium ATPase pump. I believe you have answered it correctly. Okay, we are not going to discuss this question again because the correct image I didn't get from Google's, right? Okay. Now this is another question which was asked, and this is very good question, I would say, that we have heard about the PV loop in the cardiovascular system. So here they have given you one PV loop. So this is a normal PV loop, and apart from this normal PV loop, they have given that the curve has been shifted in this direction. So in this direction is the upward direction, and if you have followed my main lecture videos, there I have explained that whenever the curve is shifting in the upward direction, the cause is increase in the after load. Whenever the curve is shifting in the left side, that is the increased contractility, and whenever it is increase in end diastolic volume, so this is the rightward shift of the curve. So this is the basic thing you have to remember. So here in this question, the curve is shifting in the upward direction. So if you have to remember, the upward direction means what will be the cause? Increase in the afterload, and the afterload is determined by peripheral resistance. So increase in total vascular resistance or increase in total peripheral resistance will be the best answer in these questions, right? So increase in TPR means there will be increase in afterload because TPR is the determinant of the afterload, and increase in afterload means curve will be shifted in the upward direction. So this is the upward direction shift, right? No confusion. Okay. Next question, systolic blood pressure falls slightly during normal inspiration. This I must have explained in multiple of classes, that whenever you take inspiration, deep inspiration, there will be more increase in venous return to the right side of the heart. Why? Because there will be expansion of the thoracic cavity, and whenever there is increase in venous return to the right side of the heart, there will be proportionally decrease in the blood in the left side of the heart. And you know, the systolic blood pressure is determined by the left ventricular output. So during inspiration, there is more blood on the right side of the heart, so there will be obviously less blood will be present in the left ventricle. So the left ventricular filling will be decreased transiently, and this will leads to the decrease cardiac output or decreased systolic blood pressure. So increased venous return to right heart causing transient left ventricular filling. Okay, causing transient left ventricular filling drop. That will be the exact answer, and this is the best choice. Other option which has been given, pulmonary compliance decreases, this is not going to be anchor. Increased systemic vascular resistance, this is also not going to happen during inspiration and expiration. And increased left ventricular filling, this is also not correct here. So only option that is correct, increased venous return decreases left ventricular filling transiently, increased venous return to the right heart. Okay, so this is the answer of the question. Now the next question, which of the following hypothalamic nucleus is primarily affected in leptin resistance? So leptin we have read in context of the puberty, that it's an the permissive hormone action, that you have read, and it's also acts through the JAK-STAT pathway. But If you followed my main lecture video, there I have explained that leptin is also responsible for regulation of your food intake. You know, the leptin is released from the fat cells, and how the leptin is going to act? It is going to act on the POMC producing neuron, and that is which nucleus? That is the arcuate nucleus. So the leptin resistance means it is the resistance at the level of the arcuate nucleus. So the best option to choose from here is the arcuate nucleus. So the leptin resistance is one of the main cause of the obesity, hypothalamic obesity, and reason is that arcuate nucleus is getting resistant because of the leptin action, maybe due to receptor resistance or whatever, but the answer of this question will be arcuate nucleus. That also has been given. Okay, option if some of the options are not exactly correct, you can put in the comment box, or you can give me a message in the Instagram. That is the best way to correct, because you know there is a limited time and the class is going on from long duration, so I'm trying to finish as much as possible. And this is recall question, you know, obviously some options will be different, right? Okay, heart rate, even the heart rate, tachycardia, whatever is there in the homeostasis question, that is not going to be the answer. Okay, so this is another question: which part of the brain is involved in scanning of the visual field? So this is basically a typical ophthalmology kind of questions, because the different types of eye movement, particularly the saccades eye movement and smooth parts eye movement, that we do not dealt in physiology. That is mainly taught in your ophthalmology classes. And the scanning of the visual field is done by mainly the saccadic kind of eye movement, and that is mainly controlled by the frontal eye field. So A is going to be the answer in this question, because that is the frontal eye field, frontal lobe in showing in the images. Again, this is exact images. This is recall images, so you can know that this is not the exact images. So some of you are saying ventromedial nucleus was there, that is satiety center, but that is not the site of action of the leptin. Question is leptin, right? So the leptin acts through the POMC kind of neuron, which is there in the arcuate nucleus, and that is going to be your answer. Even it is ventromedial or medial or lateral nucleus, whatever is given, that is not going to be the answer, right? Because leptin works through the POMC neuron that is there in the arcuate nucleus. So that is the exact answer. Okay, you can check the literature also. The resistance of the leptin is mainly due to the arcuate nucleus only, right? Okay, now repetitive nerve stimulation shows a decremental response in myasthenia gravis, right? So because of what is the reasons for this decremental response in repetitive nerve stimulation? So the question here is not the pathogenesis of myasthenia gravis, because we all know that pathogenesis of the myasthenia gravis is the decrease in the acetylcholine receptor in the postsynaptic membrane. That is the myasthenia gravis pathology, right? Antibody blocking the presynaptic calcium channel blocker, that is Lambert-Eaton myasthenic syndrome, that is the pathology. Okay, but they are not asking about the pathology in this question. Rather, they are asking that if you give a repetitive nerve stimulation to a myasthenia gravis patient, there will be decremental response. And if you have followed my main lecture, I have explained this thing. So the Lambert-Eaton myasthenic syndrome, repetitive nerve stimulation leads to increase in the muscle strength, and that is opposite in case of myasthenia gravis. Why so? That I have also explained in my classes, that if you give repetitive nerve stimulation, there will be exhaustion, more amount of exhaustion of the acetylcholine from the presynaptic terminal. So there will be decrease in the release of the acetylcholine from the presynaptic terminal. This will be the answer of this question. Although you may be thinking that this is a myasthenia gravis, the pathogenesis in the postsynaptic terminal, that I know, but that is not the question they are asking you here. They are asking, if I give repetitive nerve stimulation, motor nerve ko if I stimulate again and again, why there will be more decrease in muscle weakness, why there will be more increase in muscle weakness, why there will be decrease stimulation to the muscles? Because the acetylcholine is already exhausted, and if you give repetitive stimulation, there will be more exhaustion of the acetylcholine. Okay, and that will be the answer. Decreased release of the acetylcholine from the presynaptic terminal is the exact answer in this question. This is not the pathogenesis of the myasthenia gravis they are asking, right? Okay. Now, next question is, which of the following neurotransmitter is correctly matched with its site of synthesis? I don't know whether this question was there or not, but some of the students are saying, yes, this question was also there. Okay. And this is also I have explained in my main lecture video, where you can find out that I have detailed discussion about the serotonin, where from they are going to be released, raphe-nucleus, dopamine, where from they are going to be released, acetylcholine, and norepinephrine, where from they are going to release, and what is the main significance of them. So we have also we have all this discussed thing discussed in the main lecture. So best match here is the serotonin, which is released from the raphe nucleus magnus. All other are not correctly matched, although the first one is also correct a little bit. Acetylcholine is also there in the basal ganglia, but that is not the main neurotransmitter in the basal ganglia, okay? And rest of the things are not correct here. So only option that is correct here is serotonin matching with the raphe nucleus magnus, okay? So moving on to the next question. The next question is, in which of the following secretion least amount of sodium is present? So this is exactly direct from my GIT lecture, whether it is rapid division or it is main lecture. I told you repeatedly that the minimum number least sodium and the maximum potassium, both the answer is saliva. In this question, some of the students were saying that colon was also in the option, but even if the colon was in the option, that is not the answer. The answer is minimum number, minimum least amount of sodium is present in which secretion? The salivary secretion will be the answer. Highest amount of potassium and least amount of sodium. Answer is salivary secretion, right? Dopamine substantia nigra was there in the option, so that is going to be the best match. But I don't know whether other students are saying, you have to check, but whether the other option are exactly like this or not. But if the dopamine with substantia nigra pars compacta, that is also going to be the answer. But again, you have to check substantia nigra pars compacta or pars reticulata. Okay, so that way, please give me the correct recall if you got it in my Insta profile. So I'll correct it. I'll change the options there. Okay. Now moving on to the next question. Next question is there, which of the following process most significantly affect magnesium metabolism in the human body? So this is altogether a new question, but if you think a little bit, the answer will be it is the kidney, regulation by the kidney, because from the dietary source and all options which has been given here, they are not very important for the magnesium metabolism. It is the regulation by the kidney. After filtration, how much it is going to be reabsorbed, that is the main thing which is going to regulate the magnesium metabolism. If you don't believe, so you can check the literature also. So as you can see here, for dietary source, how much amount is reabsorbed, everything amount has been given in this diagram. As you can find out here, the maximum amount is regulated at the level of kidney. 84 millimole is filtered per day and 80 millimole is reabsorbed. So this is the main regulation point at the level of the kidney. So this will be the answer in magnesium regulation chapter question. Okay. Next question, all of the following are seen in Crohn's syndrome. This question was there, I believe. Okay. So if it is there, it is a pretty much simple question, because all of you know Crohn's syndrome means there will be hypernatremia a little. There will be hypertension, although not very high, but there will be little hypertension. There will be hypokalemia, but there will be metabolic alkalosis. So metabolic acidosis is not going to be seen in Crohn's syndrome. I have also explained this thing in my main lecture also. So as you can see here, alkalosis is seen, hypokalemia is seen, hypertension is also seen, but obviously the acidosis is not seen. So if this question was there in the INI-CET, so this is one of the simplest question, I believe all of you know. This is a visual film ischemia due to parietal lobe, due to visual film. Visual scanning is mainly due to the saccadic movement, and that is mainly controlled by the frontal eye field. That's what I know, right? Parietal lobe also has some role. Occipital lobe also has some role. But the main thing is that visual scanning. Okay, so that is the frontal lobe and the frontal eye field with the main answer. Okay, alkalosis was there in the option. So hypokalemia was there another option, or hyperkalemia was also there. Hypokalemia or hyperkalemia. Okay, so I believe then hyperkalemia was not there, right? Alkalosis was there, hypertension, alkalosis, hypernatremia, hypokalemia. Okay, so in that cases, if the options was the hypernatremia was also there, hypertension is also there, alkalosis is also there, and hypokalemia. So hypokalemia definitely is going to be present. Alkalosis is definitely going to be present. In that cases, hypernatremia is not going to be correct, because you know that in Crohn's syndrome, hypernatremia is very, very mild. In long-standing cases, there will be normalization of the sodium level. So in those cases, the hypernatremia will be the answer. Hypernatremia will be the answer. If you are saying that the options was like this, that alkalosis was there in the option, hypertension there in the option, hypokalemia was also there in the option, along with that hypernatremia was also there in the option. In that cases, you have to choose hypernatremia, because that is not very high hypernatremia. There will be little hypernatremia in the cases of cone syndrome. Okay, in long-standing cases that will be normalized. Okay, yes, answer is hypernatremia in that cases. Okay, so this is all about physiology, I believe. So altogether 12-13 questions, and I believe you have answered most of them correctly, but some of the questions was a little tricky. They have changed the questions in such a manner that you may be confused in the exam hall, but whatever, don't think what is going to happen. Okay, whatever has happened, that is already done from your side. Okay, just take a good nap and take a good sleep. So take rest for the next few days. Don't think of what is going to happen in future. Okay, so everything will be good. So with this, I'm finishing this session. Thank you so much. Good night. Take care. Bye bye.
You are live.
Okay. So, hello, my dear friends. We are going to start a very important session of forensic medicine for INI-CET November 25 exam. Okay. Now, friends, there were total 11 MCQ, and most of the questions were directly from LRR or directly from notes. Okay. You can see the first question, this one. The change of this one, this is a crocodile burn pattern seen in the image is most commonly associated with. So this crocodile burn, this is seen with high voltage electric injury. So here answer is high voltage electric injury. So it is not mummification, it is not adipose here, it is not coagulation burn. So here answer is high voltage electric injury. Is it clear? Okay. So you can see I discussed this in LRR also. This is a crocodile burn. This is high voltage and loose contact electric injury. This is a crocodile burn. This is a crocodile burn. The second question that was also very simple. A case arises when there is a dispute about a boy age. The police claim that the boy is 19-year-old and other claims he is 17-year-old. Which radiological examination are most appropriate for age estimation for age more than 18 year? Okay. So which is the most appropriate X-ray for age more than 18 year? Now this I had discussed in LRR also. The best answer is wrist with hand, medial end of clavicle and pelvic X-ray. These are for age estimation for more than 18 years. This I discussed here. You can see for shoulder, we can see the 18, 16, 18. Yes. And for hip, knee and ankle, 17, 18, 17. Okay. And for this I already discussed, my dear friend, the IIT, iliac crest, 20 year, inner end of clavicle, 21 year, and ischial tuberosity, 22 years. So you can see the best answer here is, you can see the wrist, that is very important, 18 year of age, then medial end of clavicle around 20 year of age, and the pelvis X-ray like iliac crest we can see. So here, if your age is more than 18 years, the answer would be D. Okay. Most of the questions were directly from LRR. Okay. Now, the third question, a 18-year-old woman reports sexual assault. Very important question by 24-year-old co-worker at her workplace. Her mother doesn't want to involve the medical legal case or doesn't want to inform the police. What is the most appropriate course of the action? As I told you, what is the minimum age for a girl to get examination with her consent? The answer is 12 years. So about 12, a girl can give consent for examination. So it means even if her mother is denying for the examination and doesn't want to report to the police, that take the consent of a girl and proceed for examination, because the age given for a girl here is 18 years. तो सीधा सा क्वेश्चन है, 18 years is the age of a girl. You can take the consent from a girl and proceed with examination. So here answer would be B. Okay, simple question. Match the following poison with its specific antidote. This I discussed in LRR also. You can see this I discussed in LRR. All the antidote and all the poison. Okay, so you can see the arsenic antidote, that is bal or dimercaprol. Opioid antidote is naltrexone. Benzodiazepine antidote is flumazenil, and methanol antidote is fomepizole. So here is 1A, 2B, 3C, and 4D. Whatever option is given, you just see the arsenic, bal, opioid, naltrexone, benzodiazepine, flumazenil, and methanol. It is fomepizole. Methanol, it is fomepizole. This was another very, very important question. Now, these are the different antidote. Now, another very important question that was given, a girl was found dead in the bathroom, and on the examination, there was cherry red color of hypostasis seen. Okay, yes. Okay. In that question, you are saying it is naloxone. No issue. Naloxone and naltrexone both are related with opioid. No problem at all. Okay. A girl was found in the bathroom, and on examination, there was cherry red hypostasis. There was a geyser malfunction and poor ventilation. This is again a very important MCQ. The answer is carbon monoxide poisoning. Carbon monoxide poisoning. Okay, my dear friend, all the questions mostly are from LRR session also. So be careful, like LRR are very, very important. So you can see these are the different postmortem staining color. In the carbon monoxide, it is cherry red color. The cyanide, brick red, hypothermia, bright pink. Hydrogen sulfide is two color, bluish green. Opium is black, and the remaining are chocolate brown. So it is very, very important. You can see the answer is carbon monoxide poisoning. The answer is carbon monoxide poisoning. Okay, dear. So here answer is carbon monoxide poisoning. Next question. Match the drug with its primary effect. Everyone should know Datura is a delirium poison. Datura is a delirium poison. LSD is hallucinogen. That is, it causes erotic hallucination by increasing the neurotransmitter, that is serotonin. Opioid are depressant. Opioid are depressant and somniferous. And the alcohol is inebriant poison. All these options are okay, beta? All these options are okay. Datura is a deliriant. Yes, Datura is a deliriant. Okay. Datura is deliriant. LSD is hallucinogen. Opioids are depressant or somniferous, whatever option was given, and alcohol is an inebriant. So here answer is option A. That is done. Okay. Okay. So this is another very, very important MCQ. Now, which of the following tests is not used for detection of seminal stain? Okay. Acid phosphatase test is used, Florence test is used, Barberio's test is used. Rinse test is not used for seminal stain. Rinse test is used for metallic poison like heavy metal poison like arsenic. Okay, this was again a straightforward question. This was given when I discussed LRR, the same table. The Florence test is giving dark brown crystal and Barberio's is giving the yellow needle shaped crystal. This I discussed in LRR. Every question are directly from LRR. Okay. According to me, there were 11 questions and 11 questions were directly from the notes only. Yes, range test is for arsenic. A patient was having delusion of persecution and killed a person who was believed was trying to harm him. That's a delusion of persecution. He was later diagnosed schizophrenia. According to McNaughton rule, that is a 22 BNS, which of the following is correct regarding the criminal liability? The patient is not criminal liable because the person is having schizophrenia or the delusion of persecution. So he's not criminally liable. That is a McNaughton rule. This I discussed in LRR, that criminal responsibility of insane, the McNaughton, the person is not liable. Not liable. This was a question on autopsy examination in hanging showing dribbling of saliva, ligature mark. The right eye is open and the pupil is dilated. Listen, my dear friend, the right eye is open and pupil is dilated. This particular finding is due to compression of. My dear friend, this finding is la facies sympathetique. This finding is la facies sympathetique. Yes. Yes, he is not liable because he doesn't know that recognize that the act was wrong. Yes, if that option is given, that is also fine because he doesn't know the nature and quality of the act, whether it was wrong or right. Okay. Partially guilty, no, my dear friend, partially guilty is not the right answer. Okay. On the side of the note, the eye remain open and pupil is dilated. It is due to cervical sympathetic chain. And you can see this LRR also, my dear friend, or in the notes, the post laugh is sympathetic is seen, and the same side of the note, eye remain open and pupil is dilated. And this was the question asked because of stimulation of cervical sympathetic chain. Dribbling of saliva is seen at the opposite side of knot, and laugh is sympathetic is seen at the same side of knot. Eye remain open and pupil was dilated. Okay, on an autopsy examination, the forensic experts see the blister and sodding. This is a catchy point. And the clear line of demarcation or red line is seen. Now, what is the case of this particular thing? It is a moist burn or scald. It is a moist burn and scald. You can see the blister, sodding, and clear line of demarcation. It is moist burn or scald. Yes. Now, sir, as I discussed this in LRR, my dear friend, the moist burn causes scald. That is a liquid or steam above 60 degrees. There will be soddening and bleaching. The soddening word was given. The dry burn causes blackening and burning. The dry burn causes blackening and burning. Now, the last question, the 11th one, the man derives the sexual gratification by touching inanimate object. That is fetichism. फटी चीज से मजा लेना. So if you are using inanimate object like female undergarments like panty and bra and you are sexually gratified, that is known as fetichism. फटी हुई चीजें बना जाओ. Frotteurism is rubbing a female is rubbed. Voyeurism is watching a sex, and exhibitionism is showing your genitalia. So this was like, I think like my forensic part, as I used to say, always come from my LRR and from my notes only. So these 11 questions, I think, was the greatest part for your success. Yes. Okay, there was a match the following for grandiosity and nihilism that was taught in the psychiatry. Okay, so not an issue. And my dear friend, this is all about. Take a good sleep now. Good night for everyone, and best of luck, best wishes for your result for INI-CET exam. Okay, good luck. Goodbye.